Good morning and welcome to CNC, our 5th annual Cardiology for Non-Cardiologist conference. Today is May 22nd, 2021, and we welcome to our Houston Methodist DeBakey educational video suite to present our conference. We are delighted to have an extensive faculty of excellent credentials and educators. Before we get started, I wanted you to focus on connecting with us during our main session today. Please submit your questions by texting DeBakey to 37607 once to join, and then text your question or go to pollev.com and enter DeBakey, D-E-B-A-K-Y. For all our friends who tweet, if you would like to tweet slides from our session, please feel free to do so. And please use the following hashtag CNC2021. We also invite you to subscribe to our YouTube Houston Methodist DeBakey CV Education channel. I would also like to acknowledge our support. We are grateful to Abbott Laboratories, AstraZeneca Pharmaceuticals, Boston Scientific for providing an educational grant. We also want to thank our exhibitors for participating: Boston Scientific, Impulse Dynamics, Janssen Pulmonary Hypertension, Medtronic, Pfizer. Please visit our virtual exhibit hall during the breaks by scanning the QR code on the screen. As we get started today, I would like to introduce Dr. William Zoghbi. Dr. Zoghbi has been an educator for several generations of his residents, fellows, and cardiology colleagues. He's a chair of our Department of Cardiology here. He's also Elkins Family Distinguished Chair in Cardiac Health. Good morning, Dr. Zoghbi.
Dr. Shah, good morning and good day, everyone. It is good day because actually many of you are participating from throughout the world, so it could be a good afternoon, good evening, and good very early morning to you. We're very excited about this educational offering because this is where we can share cardiovascular medicine, the latest of advancements with individuals and healthcare professionals who deal with cardiologists all the time, and the field is evolving so much. So I wanted to share with you who are your colleagues that are attending today. We have almost 400 individuals, healthcare professionals, from physicians to nurses, allied health, residents, fellows, and students, and I think this is really wonderful to be able to see all that. And you are from 35 countries. Yes, the vast majority is here in the United States, but it's really lovely to see the engagement. I think this is one advantage of these offerings, is that we can share this live and for later on recordings with many of you throughout the world. We would have wished, obviously, for you to be here, but for those of you who have not visited Houston and the Texas Medical Center and the DeBakey Heart and Vascular Center, this is a layout of the first downtown, which is the medical center, the Texas Medical Center, and the far field is downtown Houston. And in the Texas Medical Center, Houston Methodist, Baylor College of Medicine, and many other organizations are there. And this is our complex for Houston Methodist. You could see the proximity of the Research Institute, where we do quite a bit of our teaching also, in addition to the medical facilities. And hopefully we could do this next year, where we could, share in the facilities of dedicated space for education to share this with you. So without further ado, let's start with the program today. And the way we've structured, Dr. Shah and I and all of our contributors, is to do this in about 8 sessions, dedicated from early detection of coronary disease to the management of valvular heart disease, heart failure, arrhythmias. And I think, I hope you will truly enjoy this, because it is a high level, but at the same time, very up to date as to what's new in the cardiovascular medicine. So our first session today is on coronary artery disease risk identification, treatment, and management updates. And our first lecturer is Dr. Faisal Nabi, who's the Director of Cardiovascular Imaging, Houston Methodist Willowbrook, and he's a true multimodality imager, but he will focus today on early identification of coronary disease, detecting CAD before it strikes. Dr. Nabi.
Good morning, everyone. Welcome. I'd like to thank Dr. Zoghbi, Dr. Shah for the opportunity to be able to speak to you today. I will be discussing detecting CAD before it strikes. Now, I'll be leaning very heavily on the 2019 ACC guidelines for primary prevention of cardiovascular disease. This is really a great resource for those who are interested in further research into this. So some basic introductory slides. As everyone knows in the audience, ASCVD is the leading cause of morbidity and mortality globally. It is a very large source of annual expenditures. In the United States, we spend close to $200 billion per year on ASCVD, and this is expected to only grow as our risk factors increase. And then I think we can all agree upon that preventing cardiovascular disease is in all of our benefits, as this is much less costly to the system than treating the complications we frequently observe. Now, since the 1950s, the cardiac risk factors have been identified which increase your risk for coronary artery disease. And these are the very common things everyone's heard about, like smoking, diabetes, hypertension, increasing abdominal obesity, stress, and of course, dyslipidemia. And there are things that are associated with reducing your risk, including fruits and vegetables and regular exercise. This study also has shown us that, each individual risk factor elevates your risk, but as you accumulate risk factors on an individual patient, your risk also progressively increases. However, risk factors are not necessarily the entire story. This was a large group of men who had an incident cardiovascular event, and you can see here in 62% either had no risk factors or only had one risk factor. So still a lot to learn about coronary vascular disease. So let's begin with a story. We have a 59-year-old Hispanic female who really presented to my office just wanting to make sure her heart is okay. She's completely asymptomatic and is active in her regular routine as a lawyer. She's a non-diabetic, but does have psoriasis for several years. She reports her mother passed for her first MI in her late 60s. She's a non-smoker. She's busy at her work and therefore really doesn't have much time for exercise, usually doing only light exercise 1 to 2 times per week. After being in a quiet environment for some time, her blood pressure measured at 148/80, heart rate was 71, her BMI was elevated at 30, but otherwise her physical exam was normal. Her total cholesterol was elevated at 210, HDL was 40, LDL was elevated at 147, triglycerides were normal, hemoglobin A1C was normal, EKG was normal. So if you're like me, you see many patients like this in your clinic, and you're left with maybe 3 questions that you're often wondering how you should address. What should I advise her? How should I assess her cardiovascular risk? And does she already even have coronary artery disease that I don't know about? So one of the things the guidelines really makes a strong emphasis on is that we really should be emphasizing healthy lifestyle for all of our patients as a lifelong strategy to reduce the risk of cardiovascular disease. And this is called the Life Simple 7. They have recommendations for exercise, diet and weight control, stopping smoking, and then really being aggressive with any risk factors you identify, such as controlling diabetes and and controlling blood pressure to less than 130/80, and then treating lipids should the patient need it. And these are really forms that core group strategy when it comes to prevention. And the idea is that you really want to consider pharmacotherapy only for those patients who are at the highest risk. So what do we do next? The guidelines recommend, once you have made lifestyle change recommendations to all your patients, the next thing to go ahead and do is calculate a 10-year atherosclerotic CVD risk score, and using the pooled cohort equations. And the idea here is that you want to give a quantitative number, a quantitative risk, because you really want to be able to then match the intensity of your preventative efforts to those who have the greatest absolute risk. And in general, by calculating this number, you'll notice that in those patients who have elevated risk, and elevated risk is usually more than 7.5%, that these patients, when you look at their lipid and blood pressure management, these patients more than likely are going to need pharmacotherapy. So the idea is quantitative risk and identify those who are at the highest risk, so you can really then give your most intense efforts to those patients with the highest absolute risk. And so you can do this by simply going to the ACC website, looking up the ASCVD risk calculator, plugging in basic information such as age, gender, race, blood pressure, cholesterol values, and some basic clinical findings. And you're able to determine their 10-year risk of death, myocardial infarction, stroke, or your ASCVD risk score. Here in our patient was 5.1, which is considered a borderline number. So what do I do with this? So, when it comes to blood pressure recommendations, it was very easy on our patient. Our patient had a systolic blood pressure greater than 148. This was already stage 2 hypertension. And along with non-pharmacological therapy, I would be recommending blood pressure lowering medication for her. But had she been stage 1 hypertension, you can see here that those patients who have low risk of atherosclerotic disease within the next 10 years, really you can give these patients time to reduce their risk, to get their blood pressure under better control by simply non-pharmacological ways. Whereas those patients who have risk greater than 10%, these would be the patients you want to consider pharmacotherapy earlier to reduce their risk. What about lipids? We know some patients need statin therapies. These are patients who have known CAD, who have cholesterols greater than 190, who are diabetics. What about everyone else? Again, here the ASCVD risk score is very helpful in those patients with greater than 7.5%. As we had mentioned, these are the patients that you want to talk about introducing pharmacotherapy in order to reduce your overall risk. As you remember, our patient was 5%, and then this is considered borderline risk. It is recommended in these patients that you take a close look at their medical history and find any factors that have been associated with increased cardiovascular risk, and therefore, and these are called the risk enhancers. And if you do identify a risk enhancer, consider treatment for those patients. So these are some of the risk enhancers in the guidelines. Simply, there are patients who have family history, who have chronic kidney disease, have metabolic syndrome, women who have had preeclampsia, inflammatory conditions like our patient who has psoriasis, or if you have South Asian ancestry. Other blood findings are if you have an elevated CRP, triglycerides, lipoprotein(a), ApoB levels. These are all patients whose studies have shown that these risk enhancers increase your risk of atherosclerotic disease, and therefore should really prompt reclassification to a higher risk and consideration for pharmacotherapies. So I went back to our lady, female, asymptomatic female who had psoriasis and a risk score of 5%. I discussed, exactly the way, the logic that I presented to you, and I recommended to her blood pressure and statin therapy. However, she came well prepared. As you remember, she was a lawyer, and she had already done her research on the internet. And she came back to me and said, I'm not so sure I want to take these statins. I've read a lot about side effects, and I'm kind of hesitant to take this medication without further proof that I have elevated risk. And so the guidelines are very clear about this. They say in those patients who are borderline or intermediate risk, and if the risk decision is uncertain or your patient is reluctant to consider pharmacotherapy, you can use calcium scoring as a two-way recommendation to further either classify this patient as increased risk or downgrade this patient to lower risk. So, and this is spelled out here very nicely. So what is calcium scoring? Calcium scoring is a very simple technique. The patient lies in the scanner, literally hold their breath for about 5 seconds, and you're able to get very, very comprehensive information. What you're looking for is calcium in the coronary arteries. This is very specific for the disease of atherosclerosis. It correlates very nicely with total plaque burden. And it's very personalized risk assessment rather than a calculator that was based on large population studies. And notice this is all done without any contrast, without any IV or stressing the patient, and it's done with very low radiation. Studies have shown that those patients who have calcium scores of 0 have an excellent prognosis, whereas those patients, as their calcium score increases, their risk for cardiovascular event progressively increases. It's shown us that this can be a great tool for risk discrimination and risk reclassification. Here in the MESA study, 25% of the cohort was either reclassified to a higher or a lower level. So a very good test for reclassifying patients. And studies have shown us really when it comes to evaluating risk, this is the most superior, this is the best test for risk prognosticating your patient compared to other anatomical tests such as CIMT, brachial flow mediated dilation, ABIs, and much better than blood tests such as CRP or history such as family history. So I sent this patient, our patient, for a calcium score, and you can see the bright red highlighted pixels are evidence of coronary calcium. Our patient had a lot of coronary calcium that quantitated to 288. This is considered moderate to moderate high degree of coronary atherosclerosis. And so I went back and I showed this patient to her and I said, look, we have detected CAD. Fortunately, you are not a patient who has had a heart attack, but I can show you today with this test the evidence of atherosclerosis and that we should consider doing something to reduce your risk. And it turns out from the literature that this is not uncommon. Like our patient and those patients who you are considering for statin therapy, 43% will have a calcium score that's positive. And these are the patients with positive calcium scores that go on to have cardiovascular events. I can take this data and instead of the SCVD risk calculator, I can use the MESA calculator. This calculator is very similar, but this time it incorporates the calcium score. And you can see my patient's risk went from 5% now to 8.5%, clearly indicating that there would be a clear indication for pharmacotherapy with statin-lowering drugs. So, and that's what I did. She was much more inclined to take this medicine, especially when she saw that she has coronary atherosclerosis, and she wanted to be able to do everything to reduce her risk for the future. Believe it or not, the calcium score also helped me in making the decision to go ahead and prescribing aspirin. This was a study that showed us that in those patients who have a calcium score greater than 100 and definitely greater than 400, that no matter what your ASCVD risk score is, these patients benefit from aspirin therapy, and the benefit far outweighs the potential harm from a bleed. The studies also show us that, what do physicians do with this data, with the calcium scores? They're much more inclined to initiate pharmacotherapy and to discuss lifestyle changes. This was a randomized study amongst patients who underwent calcium scoring or did not undergo calcium scoring. And those patients who had undergone a calcium score at 4 years demonstrated an improvement in blood pressure, lipid values, and weight, likely due to the initiation of medication and the compliance with medication on the patient's part. And the big question always is, do we have outcomes data? And I can show you from this slide that we do have data. This was a retrospective study that showed us that in patients who have positive calcium score, that if you were treated with a statin, you had better prognosis than those who were not. And in a randomized control setting from the SCART-HEART data in patients with acute chest pain, those who were randomized to CTA and you had identifiable evidence of coronary atherosclerosis by CTA, these patients had improvements in the risk of death of myocardial infarction, all due to because of the initiation of pharmacotherapy. What if, on the other hand, I had shown you this and the patient had no demonstrable evidence of coronary atherosclerosis with a calcium score of 0? These patients I had shown you on the Kaplan-Meier curve have a very low risk of cardiac events, less than 0.3% per year. And even out now in studies showing up to 15 years, these patients have an exceptionally low risk, less than 1% risk of having a cardiovascular event. And you can bet this would be a cohort where really medications would not be indicated because the risk is already very, very low and you would not see further improvement. And again, this is not an unusual situation. In 44% of statin-eligible patients, their calcium score was 0 in this trial, MESA trial, and you can see that those patients with a calcium score of 0 have a very good prognosis. So with this, I conclude, and I thank you very much for your attention.
Thank you very much, Dr. Nabi, for this very important concept of power of 0. Actually, our next speaker, he was behind this power of 0 concept, and I think calcium scoring has now become mainstream. It took some time to get the evidence, but I think the evidence is very strong in our management of patients with coronary disease. So our next speaker is Dr. Nasser, Khurram Nasser. He's professor of medicine and cardiology here at Houston Methodist, and he is the director of the Division of Cardiovascular Wellness and Prevention. And he will be addressing managing cholesterol, statins, and beyond. Dr. Nasser.
Greetings, everyone, and welcome to our annual Cardiology for the Non-Cardiologist seminar. I'm Dr. Khurram Nasser, Chief of the Cardiovascular Prevention and Wellness Program at Houston Methodist DeBakey Vascular Center. We'll jumpstart the session today with the broad topic of managed cholesterol, mainly focusing on lipids, LDLs with statins and beyond. Now, these are my disclosures. In the next 15 minutes, we will discuss some practical recommendations for the non-cardiologist on optimal strategies that can identify the appropriate patients for lipid-lowering therapies, what options do we have available, as well as those at risk for atherosclerotic cardiovascular disease. We will also briefly detail local resources at Houston Methodist that are available to our primary care and other stakeholders to support lipid management among high-risk individuals. All right, so we'll start with the bread and butter case. Someone with an established cardiovascular disease, 67-year-old male with myocardial infarction 4 years back, LDLs 144, already on a high-dose statin and ezetimibe, and the current LDLs 82, blood pressure well-controlled, diabetic on metformin, asymptomatic. The question is, how and what would you decide about their further lipid-lowering management? Now, practically, while all patients with established cardiovascular disease are above a certain baseline risk threshold, not all are created equal. Extensive insights over the last decade have illuminated that many are actually at much higher risk and can be identified just by the same eyeballing and based on conventional wisdom. For example, there are individuals that are at much higher risk than average, and it mainly includes those with multiple cardiovascular disease events, atherosclerotic cardiovascular disease in multiple vascular beds, for example, having a history of stroke with MI, and at least 2 to 3 risk factors of the ones that I have highlighted here. Now, you may be wondering, why is this classification important? First, it flags a group of individuals who are much higher risk in a short duration, and that results in a significant downstream morbidity, recurrent events, cost, and of course, mortality. For example, in this large insurance data set, those with multiple ACVD events, who are now generally considered high risk, the risk of repeat clinical events were threefold higher than those classified as lower risk. And of course, you can see here that even among the very high risk group, those with multiple events tend to have a much higher risk of recurrent events. Now, second, why this classification is important, that the recent guidelines update in 2020 from the European Society have suggested that while everyone with atherosclerotic cardiovascular disease should be treated with at least an LDL of targeting 70 milligram per deciliter or less, we need to be extra aggressive for those who are considered high risk, thus pushing the LDL targets of less than 55. Now, the question is whether this enthusiastic support of much aggressive lipid lowering matters. Most of these evidence comes from the landmark PCSK9 inhibitor clinical trials that showed that on top of maximum tolerated statins, utilization of PCSK9 inhibitors resulted in an average LDLs in the 30s to 40s. It's associated with at least a first event reduction of 15%, but even further, which we are more interested in total events, repeat incidents are reduced by 25%. Now, for every 1,000 patients, almost 85% events can be prevented, the first incident as well as the recurrent. And with the significant price reduction from 14,000 down to 4,000 to 5,000 and accounting for repeat events, these reductions seems beneficial as well as cost effective. So in summary, our approach for at least in those with established cardiovascular disease is to maximize statins to the highest tolerated dose due to the significant pleiotropic effects. Now, many patients may not be able to tolerate these doses. It becomes very important to document statin intolerance. We advocate that every 4 weeks you incrementally either increase the statin and then go on a ZTIA, and if the LDLs are still more than 70 or more than 55 in very high risk, a consideration of the PCSK9 should be done in accordance with the ACC/AHA guidelines. Based on our estimate, after maximizing statins and ZTIA, about 15% individuals will still need a PCSK9 inhibitor. Currently, nationally, even locally, less than 1% of total cardiovascular disease patients are on PCSK9, showing huge gaps in care. Now, further in 2021, if due to cost, PCSK9 are not feasible, there is a new class, bempedoic acid, which is a targeted therapy designed to inhibit cholesterol biosynthesis, has no myositis effect, and was approved by FDA last April. Work well for statin intolerant. However, we need to be cautious with elevated uric acid and contraindicated in those with tendon ruptures. Of note, the outcome studies are still pending. On the other hand of the spectrum, very few individuals, maybe with genetic disorders of of familial hypercholesterolemia and ACVD and unable to respond to the therapies, may need LDL apheresis. However, very rare, we have 2 individuals in our practice on this. So now moving gears from a patient that has no documented CVD to one without established cardiovascular disease, what would you do? Now, as per the guidelines, they want us to estimate the 10-year cardiovascular disease risk, which is a very pragmatic approach and can be easily done. And if the risk is 7.5%, in our patient about 12%, then the statin is recommended. Now, here is, as per the guidelines, although they want to emphasize more on the risk factors, however, in my view, relying solely on risk factors and biomarkers have 3 major issues. Number 1, the risk estimates are not accurate. We and many others have shown that it significantly overestimate your risk. Majority of the middle adults and elderly individuals would be candidate for therapy almost about 50 to 60%, and exclusively if you're a white male above 60 are likely to be a candidate for statin. And in our practice, as well as literature is showing that the patients are not keen on committing to lifelong pills if they do not deem themselves at risk. It's really hard to convince healthy people to take drugs and they are seeking mechanism to understand whether there are ways to avoid it. As a result, at DeBakey, we are focusing on keeping the guesswork aside and emphasizing where the money is, that's the atherosclerosis, and using a simple non-contrast cardiac CT to detect presence as well as burden of calcifications, which is an established marker of coronary atherosclerotic disease, and now well established to predict above and beyond traditional risk factors, guiding our cholesterol lipid lowering management therapies. Now, the calcium test helps in 3 ways. Number one, our group over the last decade has effectively described the power of zero, that means absence of coronary atherosclerosis, as the most favorable prognostic factor. Nearly half of individuals who you would prescribe statin based on risk factors don't have the disease. Their 10-year risk is well below the threshold for statins, and they can avoid or delay it. And now this is adopted by the guidelines by Dr. Roger Blumenthal, who leads the prevention program at Chickasha Center Hopkins. Think this is the best tiebreaker. And of course, as per Dr. Harlan Krummels from Yale, this is a test that can help individuals identify if they do need it. Of note, it's being widely used in our Houston Methodist community. And already this year, we have seen almost 50% growth year to year. Now, second is also helps us overcome the heterogeneity of the risk across the risk factors or lipid. And even among those considered high risk, you can see how the distribution is. So not only in absence of atherosclerosis, you are low risk, but if in these individuals you have atherosclerosis, you are a pretty high risk. So we have summarized our approach in a recent invited editorial in BMJ that you, in an asymptomatic individuals, you start with the calcium. If your calcium score of 0, you focus on lifestyle intervention and have flexible LDL goals, and if needed, a low dose statin can be used. However, if you have a very high calcium, I would treat that patient as equivalent with CVD, with an LDL target less than 55 to 70. I would consider the PCSK9 inhibitors and ezetimibe as well as bempedoic acid as needed. Treat with the purified EPA if the triglycerides are greater than 150, and if they're diabetic candidate for an SGLT2 and a GLP-1 inhibitor. Now, a special group, and that's not that uncommon, are those with severely elevated LDL levels more than 190, which puts them at a higher risk of a genetic condition called familial hypercholesterolemia, which is seen in 7 of these individuals, but almost 90% of these individuals are undiagnosed. And the reason why we worry about them, it's one of the leading cause of premature cardiovascular disease and death in the US and worldwide. Now, this is a complex disease that will require very careful assessment, including genetics, as well as cascade screening of family members. We do a very careful assessment of burden of early atherosclerotic disease that dictates the severity of management, including diet, pills, injections, and at times even apheresis. The imaging is very useful because other investigator and our group have clearly shown that severe hypercholesterolemia is not a homogeneous group. Almost 1/3 may not have plaque, and the outcomes are clearly related to plaque burden. And even among those groups with calcium 0, they are protected up to 12 years. Now, remember, unlike the primary prevention, calcium testing is not about statin decision. All of these patients should be on some statin, but about more aggressive treatment. So as summarized here, if you have no coronary artery calcium, you can have flexible goals with at least moderate to high dose statin. If you have early plaque, then we definitely be very aggressive and target them less than 70 milligram per deciliter. And in scenario of moderate to severe plaque, target them as high risk with LDL goals of less than 55. Now, I would also like to take this opportunity to make you aware of local Houston Methodist cardiovascular prevention resources. In 2019, we instituted our CVD prevention and wellness program that serves as a system-wide resource. And in the last 12 months, we have extensively grown as a team, as you can see with the members that we have providing education and training resource for many residents and fellows, and also leading rigorous research program. Of course, we have served more than 1,500 new patients over the last 12 months, and we continue to grow. While we serve a wide range of patients, and we are not limited to just the lipids, however, specifically related to lipids, there are three groups that are prime candidates for more detailed evaluation and aggressive prevention intervention. These are patients with established cardiovascular disease with LDLs greater than 70, especially if they're on a statin. Among those without established cardiovascular disease, if patients are uncertain about risk or statin use, they're statin intolerant, they have early atherosclerotic disease with LDL greater than 70, and anyone with the calcium greater than 100, which puts them almost as a high risk as someone with established cardiovascular disease, should be considered for a prevention consult. In my view, everyone with an LDL greater than 190, which is a very complex group, and I've shown you require extensive due diligence and management and follow-up, should be considered recommendation for a preventive cardiology consultation. In our system, we seems to have more than 11,000 of these patients. Fortunately, you can easily refer these patients to our group by just emailing us directly at preventivecardiology@houstonmethodist.org or calling to our referral numbers. We have a full 5-day clinic operations, and almost all patients are seen within 1 week with the flexibility of virtual visits. We have also closely working with other cardiometabolic experts and have a very extensive workup for these patients. Now, based on the cardiometabolic risk, patients usually typically come back in 1 to 2 months, and we go through the whole ABCDE chart that was described by my colleagues at Johns Hopkins. And depending upon the severity, our care continues according to their risk and needs in collaboration with the primary care team. We have a multidisciplinary approach. We prioritize based on risk and needs, and there remains a continuous education and data-driven feedback to our own providers as well as to the patients. And in the end, if you send these patients to the CVD wellness programs, apart from the high-tech approach, our major effort will be on the lifestyle, on losing weight, quitting smoking, exercise, and nutrition. We will also teach and update them on the latest evidence on diet and health, and we'll be enrolling them and experimenting on some high-tech programs for implementing best practices. Thank you so much, and I hope you have a great session. There are amazing talks lined up, and we look forward to your feedback. Thank you so much.
Thank you very much, Khurram, for this great overview of treatment of high cholesterol and how do we use testing to optimize this treatment. I think we'll have a great discussion in the Q&A session. Our next speaker is Dr. Kershaw Patel. Dr. Patel is a preventive cardiologist. Actually, we recruited him from UT Southwestern with an expertise and interest in cardiometabolic syndrome as well as prevention of heart failure in this entity. And he will talk to us about risk factors beyond cholesterol, what and how to address. Kershaw.
Hi, my name is Kershaw Patel. I'm a cardiologist in the DeBakey Heart Vascular Center. It's my pleasure to present risk factors beyond cholesterol as part of this session on coronary artery disease risk identification, treatment, and management updates. We'll focus our discussion on primary prevention of atherosclerotic cardiovascular disease. These are patients who have not had a heart attack, stroke, or a clinical event. For this presentation, I have no relevant disclosures. I want to highlight that most of what we'll be discussing is described in detail in the 2018 multi-specialty guideline on cholesterol management, as well as the 2019 American College of Cardiology and American Heart Association's guidelines for primary prevention of cardiovascular disease. In the guidelines, this figure can be found and does a really good job summarizing several important topics. My goal over the next 10 to 15 minutes will be to highlight risk factors beyond cholesterol to help guide how we can think about working with our patients to prevent cardiovascular disease. So I want to take a moment to highlight a very important topic, especially for this forum, the annual Cardiology for the Non-Cardiologist meeting. So in the primary prevention guideline, there is a big emphasis on a team-based approach for risk factor control. So that involves the cardiologist and mostly the non-cardiologists. Most of our patients will be seeing you in your clinics and not necessarily a cardiologist, but we're always here to help. So in this team-based approach to preventing cardiovascular disease, our patient is central to this all. We should be engaging in shared decision-making to help our patients reach their goals. So how can we help our patients live healthy lives free of cardiovascular disease? Well, risk assessment is critical to primary prevention. The guidelines suggest matching the intensity of preventive therapies to the absolute risk of the individual. So how do we actually evaluate risk? And what are those risk factors beyond cholesterol? Well, evaluating risk can be described in 3 steps. First, assess risk. Second, personalized risk assessment for the individual patient. And third, if needed, we can reclassify that risk. So in risk assessment, it's important to consider 3 major groups of adults. First, if an adult patient 20 to 75 years of age has a low density lipoprotein cholesterol, or LDL cholesterol, greater than or equal to 190 milligrams per deciliter, the guidelines are clear. We think that the benefits of treating this group of individuals with a maximally tolerated statin outweighs any potential harms. The second group, patients with diabetes who are at least 40 years of age. For this group, it's recommended that they're prescribed at least a moderate intensity statin. Then there's another group that for the purposes of this presentation, we will call other. So this is the group of individuals without this LDL elevation or diabetes in this age range. So before we get into this large group of patients, we're already considering risk factors beyond cholesterol. Specifically, we have thought about the history, whether or not our patient has diabetes. And sometimes diabetes is often identified based off of tests, like screening tests or diagnostic tests through several serum blood tests, whether or not they're fasting or non-fasting. So the patients in this other group are not all the same, and we need to think about them differently, including their risk of having a heart attack or stroke. So these individuals can be considered as having low, medium, or high risk, but we actually have a tool to estimate and quantify their risk. And so when we talk about assessing risk, the guidelines recommend using the American College of Cardiology, American Heart Association pooled cohort equations to estimate the risk of having an atherosclerotic cardiovascular disease event over the next 10 years. And this can be assessed easily using the online portal or even using an application on your smartphone. And so here are screenshots from the American College of Cardiology guideline clinical apps. There's many excellent tools here, but for this specific topic, we can select the prevention and health promotion, followed by the cholesterol 2018 section. And then among these options is the ASCVD risk estimator. And so when this is selected, we have to enter in the demographics of our patients, some labs including cholesterol levels, as well as vitals and other history, such as diabetes, like we've discussed, and smoking history. So we're continuing to move beyond cholesterol. We've added vitals, including the blood pressure measurements, which are usually obtained prior to our physical exam. And with these data, we can calculate their risk of having an atherosclerotic cardiovascular disease event. We can identify their risk more precisely, and rather than saying low, medium, and high, we can actually quantify that risk. And based on these 10-year risk cutoffs, our patient will be described as having low, high, or be in this middle borderline to intermediate risk zone. But how accurate is their risk estimation? Well, here's a study that attempted to answer that question among adults who did not have diabetes and were 40 to 75 years of age. Their risk of heart disease was estimated based on those pooled cohort equations. Patients with similar risk based on those equations were grouped together in these different categories. But what was their actual risk? When you look at what actually happened to these patients, it was not what we expected. The pooled cohort equations consistently overestimated risk. So the accuracy of the pooled cohort equations was not as good as we had hoped. So among certain individuals, we may need to do some additional work. We may need to personalize their risk assessment. Now, as a reminder, we are focused on this other category. So this includes individuals who did not have LDL cholesterol levels above 190, and these are the individuals who did not have diabetes in that specific age range. Even more specifically, the guidelines say it is reasonable to personalize risk assessment among those individuals in this other category who have a 10-year atherosclerotic cardiovascular disease risk of 5 to 20%. But how do we personalize their risk? Well, we use something called risk enhancing factors. So in our friendly application on the smartphone, after navigating to the Cholesterol 2018 guideline, we can select risk enhancing factors, and then this pops up. And so we're going to go through each of these. When we talk about risk enhancing factors, these individual factors suggest higher risk of a future cardiovascular disease event. And so individuals with high absolute risk are more likely to benefit from risk lowering therapies, such as statins. So in general, these risk enhancers can be separated into these three broad categories: the history and physical exam, blood tests, and then other tests. So there are several risk enhancing factors beyond cholesterol that can be uncovered just from our history and physical exam. So we can ask about family history to find out if any first-degree relatives had a heart attack or stroke at an early age based on their sex. We can measure waist circumference to assess cardiometabolic risk linked with metabolic syndrome or overweight or obesity. The diabetes history is very important, such as how long a patient has had type 1 or type 2 diabetes, and whether or not they've had microvascular complications such as retinopathy or neuropathy. A past medical history of inflammatory conditions such as psoriasis, rheumatoid arthritis, or HIV. All of these things are associated with higher risk of cardiovascular disease. The guidelines also recognize women's health as potentially risk-enhancing factors, such as pregnancy-associated conditions linked to cardiovascular disease, like preeclampsia, and other things like premature menopause. And then additionally, there are certain racial and ethnic groups that may be at higher risk of cardiovascular disease. So there are also several blood tests that may indicate higher risk of future heart disease that are beyond this top line within lipids, beyond cholesterol. So lipoprotein A is an important marker of risk. And in some guidelines, it's suggested to be checked more broadly in individuals. Apolipoprotein B is the main apolipoprotein found on particles like LDL, VLDL, and chylomicrons. And then we check some tests in the blood and in the urine. And these tests can indicate the health of the kidneys. And that's very important when we talk about risk enhancers. And similarly, high sensitivity CRP is a measure of inflammation, and we think that can also identify higher risk. In some patients, an ankle brachial index may have been checked, and abnormal levels may indicate higher risk. So when we look at risk factors beyond cholesterol, we've added a few. The history and physical, some blood and urine tests, and then other tests such as ABIs. Now that we have assessed risk and personalized it, we may be able to engage in meaningful discussions about risk and benefits and engage in shared decision-making for selection of preventive therapies. But some patients may still be on the fence about whether or not they should take a medication like a statin. So if in this group, patients are still not sure about whether they should take a statin, it is reasonable to measure a coronary artery calcium score. And the goal here is to guide these conversations, and coronary artery calcium may reclassify their risk. We had the pleasure of learning about coronary artery calcium from Dr. Nasir, and here are some data from a study that he led that shows the power of calcium to refine risk assessment. Specifically among patients with a calcium score of 0, these individuals are at lower risk of future events. So the guidelines recommend that a coronary artery calcium score in this range of patients based off of their pooled cohort equation estimated risk can be considered for having a calcium score measure. So we add another risk factor beyond cholesterol, the coronary artery calcium score, that can be considered when we're assessing our patient's risk to help guide them through shared decision-making or deciding on preventive therapies to reduce their risk of heart disease. So in summary, I want to emphasize again the importance of a team-based approach to risk factor management that includes all of us, cardiologists and mostly non-cardiologists, and also emphasize shared decision-making when we're talking about preventive therapies with our patients. There are 3 steps to risk assessment: assess, personalize, and reclassify risk. There are 3 major groups that we discussed based off of LDL levels, diabetes history, and then the other group. And among the other group, we can estimate risk based on pooled cohort equations. And then in select individuals, we can consider risk factors beyond cholesterol. Thank you for your attention, and I'm looking forward to the Q&A session.
Thank you very much, Dr. Patel, for this very nice overview of other risk factors for coronary disease. And we have few minutes here to do a Q&A, and I would like to remind the audience that they can join us by the web, particularly if they're out of the United States. You can go to paulev.com and enter DeBakey, and then you can ask your question. And if you want to text, you could text DeBakey, DEBAKEY, to 37607. Dr. Nasser, you have a question for you. How do you treat elevated Lp(a) in patients with coronary disease after getting LDL to target? Good question. Unmute. You need to unmute.
Can you hear me now?
Yes, we can.
Okay. So Dr. Zoghbi, this is a commonly seen scenario where we have patients with elevated Lp(a). Usually at this moment, we do not have any approved therapy targeting Lp(a). The general recommendation by the guidelines, including the National Lipid Association, is trying to lower their LDL to as low as possible. For example, in my approach, we try to get their LDLs below 55, especially if they have CAD, and we categorize them as very high risk CVD patients. That's number one. We do favor PCSK9 inhibitors, which is seen to lower Lp(a) by about 15%, although not approved for this indication. However, studies have, at least from the Fourier and some of the other PCSK9 inhibitor landmark trials, it's been shown that these individuals are more likely to benefit with the PCSK9 inhibitor. So that's number one. Number two, in Horizon, there are a couple of therapies which are being tested in phase 3. We anticipate that specifically targeting lipoprotein A indications, we may see some indications coming out with these therapies in about 2 to 3 years.
So more aggressive in some situations.
Yes.
And hoping for some other, therapeutic. Question to any of you: what ICD-10 codes will allow for insurance coverage of calcium score testing? Are insurance companies basically paying for calcium score testing at this stage of the game? And if they are, is there an ICD-10 code? Anybody?
I can take
Faisal
the lead.
or Kershaw?
I can take the lead on this, Dr. Zoghbi. Right now, there is some discussion ongoing with CMS for approval. I have spoken with colleagues in Boston. It seems like, at least at Partners, they have started billing. I'm not really too sure about the codes, but I think from hypercholesterolemia, family history, intermediate risk, some of those codes are being accepted. So I think that those are the 3 codes that can be used, specifically hyperlipidemia, even for diabetes, intermediate risk, and family history. Now, the reimbursement would vary from region to region. Definitely some markets in the Northeast as well as in the Northwest are paying for that. Most of the places are out of pocket, including our own, where they have not yet started submitting reimbursements to the insurance companies, but how would that pan out is yet to be seen.
Yeah, I think from a practical point of view, because we have an audience that is quite varied, the cost is very low.
Yeah.
Usually close to a low 100s or 100 or something like this. That's number one. Number two, at least from my point of view, I have not seen really patients refusing this, particularly if it changes their management. And from my end also, if somebody is asymptomatic and active, there's no point of doing a stress test. Actually, it is much better to do a calcium score to identify risk, because most of the time the stress test will be either negative or maybe false positive in somebody with a situation. Do you agree with that? Do you guys agree with that? How about you, Dr. Nabi?
Actually, I completely agree with you. In my practice as well, Methodist has been charging $120 for calcium scoring. And when I approach my patients with this price, I'm quite surprised when they understand why we're doing it, how it is really the most sensitive test for the detection of coronary disease, how it really is the most specific test for coronary disease. I've really not had any hesitation in this test. And more importantly, if you take the time, go over a little bit about the data, how it can really change what medicines you're going to choose, how it really can tell them a lot more about their prognosis, especially if they're asymptomatic, like you mentioned. We really haven't had difficulty convincing them to get this done. I think if you look at the cost in comparison to all our medical tests that we're currently performing, it is really very cost effective and definitely can be cheaper in other parts of the country.
All right. For Dr. Patel, which high-dose statin has the least risk of increasing hyperglycemia in a diabetic patient already? Interesting question.
Yeah, that's a great question. When we talk about patients with diabetes and lowering their risk, statins are one of the mainstays for medical therapy for that. And specifically, when we talk about the intensity of therapy, we're talking about at least a moderate intensity statin. Now, usually when we have patients who are at the borderline risk for developing diabetes, those are patients with pre-diabetes, A1Cs 5.7 to 6.4, or a fasting blood sugar of 100 to 125. Those are the ones who we know are at the higher risk for basically being reclassified from pre-diabetes to diabetes. And we know that statins do elevate blood sugars. So it is one of the things that we talk about with our patients, in addition to the small probability of having muscle aches, that their blood sugars will increase. In addition to that, I still have the risk-benefit discussion that despite elevating the blood sugars, statins are still effective at lowering the risk of having a future cardiovascular disease event. So regarding which specific statins to prescribe, I actually do not differentiate them regarding the risk of progression of worsening glycemic control. Typically, in those patients who are at higher risk for progression, we select one that is going to be tolerated because we know certain statins may lead to a higher probability of muscle aches for specific individuals. And oftentimes it requires us to try multiple types of statins as well as different doses. So regarding, and also it's important to talk to our patients about cost if those statins are going to be a little bit more expensive. So I actually do not differentiate which particular statin for patients with diabetes, as long as it has been studied and has been effective for lowering risk in patients with type 2 diabetes and primary prevention.
A quick question on, we still have about 3 or 4, so let's do them rapid fire as much as possible. HDL cholesterol, how important that is when we look at the total profile, if it is reduced while you have a normal cholesterol, if you will, right? And at times you may have a high LDL and a high HDL at the same time. How do you put that into the equation?
So Dr. Zoghbi, my thoughts, the approach has been moving away from, as far as risk assessment is concerned, from biomarkers to more the imaging. You may have a normal or a high HDL, but it all depends whether you have plaque, yes and no. Right now, there are no therapies for HDL. I would caution against very high HDL. That should not be seen as a sign of protection, because upcoming studies have shown most of a U-shaped curve, especially with HDLs greater than 80. And actually, there are some very interesting investigations going on within our own Houston Methodist Research Institute, assessing I would say the risk associated with significantly elevated HDL. So from our perspective, we are moving away from making guesses to rather than seeing disease and treating disease. The HDL would not fall within that. Right now, there are no therapies in trying to improve HDL.
Patient who has an indication for statin but allergic to statin, I guess, what's the next approach?
So
do you go directly to PCSK9 or do you do anything else?
So it really depends on what we're doing for that specific patient. If their risk is low to moderate, we can consider some non-statin therapies like ezetimibe. But then depending on how high their LDL cholesterol is, if it's something in the severe range greater than or equal to 190, we would have to have those discussions with our patients. Could this be a genetic cause of high cholesterol? And they may be somebody who may warrant a PCSK9 inhibitor. But typically, talking about diet, then ezetimibe, and potentially other therapies.
If the CAC score is high and you start therapy, is it worth to follow a CAC score a few years later to see if the therapy and diet and exercise is decreasing the CAC, or any other test to show calcium regression or plaque regression? Interesting one.
It's been our practice not to follow serial calcium scores. There's a couple of reasons. We really use this as a tool to decide on whether there's a therapy, once initiated therapy, kind of the decision we make. As for, we know a couple of things. Once you start statins, calcium can actually increase. So therefore,
it could increase, right?
It can increase, and so that may not help you as well. And furthermore, there's been very few studies. There's only been one small study that looked at a change of greater than 25%, a significant marker of increased risk, but we don't have too much evidence in that.
So in general, like Kuram, is it, I mean, if somebody has a high calcium score to start with, right? And do we need to repeat it once they're on medical therapy? Is this going to change medical therapy down the line?
The consensus is not clear as far as once the calcium test is positive. Usually my practice is I do not repeat. However, prior studies have suggested that if you repeat and the absolute difference is much higher, especially from newer plaques, then that can be an indication of disease progression, could be an indication where you need to be even more aggressive. However, the utility is very beneficial. As you pointed out, statins can increase the calcifications of existing plaque. However, those changes are not that substantial. So if you have someone with a calcium score of 150 and the repeat calcium in 3 to 5 years is about 450, that's definitely not due to treatment, most likely disease progression. However, as Dr. Nabi and you pointed out, the utility is very minimal. If you're going to treat them very aggressively, I think so, then biomarkers assessment are more appropriate than a repeat calcium.
Wonderful. There are a few other questions, but maybe they can email you with those questions. I think that would be best to do that. So thank you very much, really, an amazing first session to talk about risk. And our next session is common diagnostic testing, indications and interpretations. And our first speaker is Dr. Ahmed Suleiman, who is the Associate Director of our clinic, a preventive cardiologist and a general cardiologist, who will address digital health management in cardiovascular diseases. And he's actually one of our first physicians who adopted digital health and virtual visits in the clinic before the COVID era. Dr. Suleiman.
Hello, good morning. My name is Ahmed Solomon. I'm a cardiologist here at Houston Methodist, and I have the pleasure of talking to you today about digital health management in cardiovascular diseases. So I have no financial disclosures. We will be mentioning some devices or applications just for the sake of demonstration. So we're going to try to discuss digital health in general. We'll talk about the use of digital health and telemedicine in cardiovascular risk management. We'll talk about a few devices or applications and tools. How can we use digital health? In addition to steps on working on digitalizing your practice. So when you try to dive deep into digital health, it may feel a bit overwhelming. I'll try to simplify one's understanding of how to use digital health for the benefit of your patient, the system, and for your practice. Let's start with the biggest digital health change that we have seen over the last year or so. Telemedicine, a practice that to many did not make sense and was difficult to imagine, but became very popular after an abrupt introduction during the pandemic. In my opinion, telemedicine is a very, very important step in initiating care for a patient and to continue chronic management. It all revolves around patient-generated information and data. While listening to the patient by examination is very important, but listening to the patients themselves has a significant impact and value. Digital health mostly revolves around implementing digital tools and technologies to be able to deliver healthcare and personalize that care to a specific patient. But while telemedicine revolves mostly around communication to the patient or with the patient and the use of remote data to provide that care. So if you think about it, these two must go hand in hand. So let's talk a little bit about where one can use digital tools in cardiovascular health. If you take a look at these different aspects, these are the core steps for cardiovascular health management for chronic care. And digital tools and remote monitoring and telemedicine are definitely a factor in regards to this management. So in the digital world around you, it feels like there's an onslaught of different devices and tools. When one is trying to figure out which tools to use, it can become overwhelming and distracting. So here are a few of my thoughts on how to decide about these tools. Simplification of the device, the platform, and the process is a very important step in making it patient and clinician friendly. Notice I said here reasonable, not cheap. You want the data to be presented to you in the way you practice so that you can manage the patient efficiently. While being part of a startup sounds very exciting, it's very hard in a busy practice. The integration is one of the most hardest parts of this, but if you find what fits for all the above points, it will be worth the effort to work on the integration and interoperability, as painful as it might be. So let's talk a little bit about what tools you may have to provide that type of care. We could talk about a few of these cardiovascular risks that one can use digital tools to help in management. Activity is an extremely important part of cardiovascular health, right? But for the most part, it's always been patient-reported activity. For example, a patient tells you, I walk 3 days a week, couple miles here and there, and for the most part, it's a little bit exaggerated, usually. This type of information gives you the ability to have a proper conversation with your patient on different aspects of how they can improve their physical activity and health, increasing distance, speed, resistance exercise, etc. Smoking. To be honest with you, I actually did not really think that this was going to have or be that effective. But what I've learned over the last few years was that in situations where you need to support the patient a little bit more often than just the 6-month visit, especially for something critical and ongoing and hard, like smoking cessation, using digital tools and some element of live communication with the patient and encouragement makes a significant difference. Don't underestimate that kind of feedback and live communication on a regular basis with your patient. It makes a big difference. Food tracking, everybody knows there are a lot of apps around for dietary changes, but it's again how you use it and how you communicate with the patient. So different diet ideas, fast food and outside restaurant specific healthy options. Again, the concept here is that you're providing these digital tools to the patient with some element of live communication and feedback. It has to go both ways. In the last decade or so, the remote and continuous glucose monitoring has improved significantly. And with insulin pumps, this field, when managed well with patient engagement, has a tremendous potential that is already being demonstrated. And to show the we are not waiting movement driven by patients is a true example of how patients are not waiting for the medical community to move on the digital tools that are available to improve their health. Now, this is one of the most important issues that is not well managed: blood pressure. Something, in my opinion, so simple for the most part, and yet not well managed. In the United States, we are on the decline for good blood pressure control over the last few years through data published just this last October from the National Health and Nutritional Survey. We're not doing a good job as a healthcare system for something that's clearly a major and top cardiovascular risk. There are quite a few platforms, either through Bluetooth blood pressure devices, applications, medicinal support, and organization applications that you could connect to your platform or to your system and provide an up-to-date feedback, medicinal adjustments, etc., to get your patient's blood pressure under better control. Monitor it and manage it chronically rather than an office visit every few months or once a year. The last thing I will discuss with you in regards to tools, digital tools, are rhythm identification. There's a big concern, and frankly, there's a good point to at least part of it, of over-identifying and subsequently over-testing for these abnormal heart rhythms. There's also proof that there is proper identification of abnormal heart rhythms. In my practice, I've diagnosed quite a few patients with atrial fibrillation throughout the last couple of years through these devices, in addition to quite a few with PVCs, although the device would say irregular and flag it for atrial fibrillation, it would turn out to be PVCs. One of them just diagnosed a couple of months ago with ARVC. While you may or may not necessarily agree with these tools or think that they are overreaching, these tools are being marketed to the patient directly. And for patients, this is something that they could use to look at their own rhythm and provide to their clinician. So my advice, if they're going to use it, or if you're going to recommend it, A, use it judiciously, and B, explain to the patient what it can be and what it cannot be, and its clinical impact. You know, digitalization is all around us in many, many aspects. Think about it. When was the last time you physically walked into a bank? 10, 15 years ago, we did not even imagine of ride sharing or Instacart. So let me give you a few ideas or steps to consider to digitalizing your practice. One needs to be flexible. This is a very fast-moving industry, and I mean fast. But you do need to know, you need to be in the know. Culture, I think, is a major point. There's no example stronger than the culture change during the pandemic regarding telemedicine. The culture change is from both the clinician side and from the patient side. Explaining to your patients, explaining to your practice will help them understand why you are doing what you are doing and how this will impact and how this impact make a world of a difference. Spend some time looking at how you manage your patients. Look at the specific point of care that you would make your ability to deliver that care more efficiently, more seamlessly. How would you be able to engage your patient better? Start looking at different software, apps that would help with this vision. Invest individually or as a group, downloading different softwares or applications that can be helpful for your practice and helpful for helpful for engaging your patients. It may not be a bad idea to engage with industry to see what capabilities their products may provide. And always remember, this whole thing revolves around the patient. Patients always come first. Thank you very much. I appreciate the opportunity and welcome any questions at any time. Thank you.
Thank you very much, Dr. Suleiman. A very nice introduction to digital health and some practical tips here. Obviously, the field is evolving quite rapidly. And for those of you interested, I think all of us should be interested in this because it's really involving everything we do in health nowadays. I would like to refer you to an issue of the DeBakey Heart Journal that Dr. Suleiman and myself have edited. I think it was the beginning of this year. I think that you would find it very helpful because it touches on not only practice, but also the evolution of this field, population health, large data, machine learning and AI. And I think this is a tremendous field that is really evolving very rapidly, and all of us should be involved one way or another in looking at this and incorporating some of that. Okay, our next speaker is Dr. Mohammed Shamsi Pasha. He is one of our faculty. He's Associate Director of Echocardiography Laboratory, and he's going to address a very important question, particularly even for the cardiologist, but for the non-cardiologist is going to be very important because there are so many types of testing nowadays, and the question is stress testing. So many types, which one should I use? Dr. Shamsi Pasha.
Well, good morning, everyone. It really gives me a great pleasure to talk to you about different cardiac stress testing, the why, the when, and the what. My name is Mohammed Shamsi Pasha, and I'm a staff cardiologist here at Houston Methodist. The objectives of my talk is to guide you hopefully to choosing the optimal stress test for patients that we are suspecting having coronary disease or people who have known disease in the past, along with touch base on indications, contraindications, and diagnostic accuracy of the different non-invasive cardiac stress testings that we have. This talk is going to be based off the 2014 focused update guidelines on diagnosing and managing patients with stable ischemic heart disease. Why do we perform cardiac stress testing? We have a question to answer, or to answer, whether that's diagnosing or risk stratifying patients who have suspected coronary artery disease, or people who have known coronary disease and they have anginal symptoms or angina equivalent symptoms. Number two, we need to be able to assess the location along with the degree of ischemia in those known to have coronary disease. And finally, is to determine the efficacy of my medical treatment or the patient who have been revascularized in the past, whether or not they have any residual coronary artery disease. It is very important to take a stepwise approach in seeing these patients. Number one, we need to be able to classify their chest pain, whether it's typical or atypical. Number two, we need to determine the pretest probability of this patient having coronary artery disease. And then third is we need to be able to determine the most appropriate stress test imaging modality. We all know about the chest pain classification, the typical angina, the classic Frank Netter depiction of someone with typical angina, substernal chest discomfort or pain that's usually provoked by exertion, a heavy meal, emotional stress, and typically relieved by rest or nitroglycerin. All these three components constitute typical angina versus someone who has two of the above characteristics, and these usually the people who have mostly atypical angina versus the non-cardiac chest pain who have one or none of the typical anginal characteristics. For the pretest probability of coronary disease, it is very important to understand the Bayes theorem. What that tells us is how would my testing on a patient influence the post-test probability for having coronary artery disease, which is shown here on the y-axis, versus their pretest probability. So if we start from the lower end of the spectrum and you have someone who's 45, asymptomatic, no risk factors, well, even if they do have a positive stress test, their pretest probability was already low at 1 or 2%, their post-test probability is still low, less than 5%. Testing in this patient cohort, unfortunately, is going to carry a lot of noise and a lot of false positive. Now go to the other part of the spectrum where you have someone who has a high pretest probability of coronary disease based on age, 55, they're male, they're coming to you with typical angina. Even if I do a test on this patient, well, my pretest probability was already above 50%. My post-test probability is even going to continue to go higher. But really the sweet spot where we want to test those patients is people who have an intermediate pretest probability, somewhere between 30 and 60%, because a positive or a negative stress test will actually rule in or rule out coronary artery disease substantially. Say, for example, a 45 years old with atypical chest pain, pretest probability based on age and symptoms, and a test will actually have a segue my probability of coronary artery disease. Let's also keep in mind that the true positive or the sensitivity, it really depends on the pretest probability of the patient that you are examining, and these have been derived from empiric patients' cohorts data. It is very important to know who do we test. So we, as already mentioned, that the most of the money in the bucket is in testing the intermediate pretest probability for coronary disease. We're all familiar with the Diamond-Forster classification published way back in the 1970s, that if I have someone middle-aged in their 50s, they have either atypical angina, they really have an intermediate pretest probability for coronary disease, versus someone who's in the same age group, but they have typical angina, especially if they're men or women, then these people testing them will unfortunately not significantly improve their post-test probability for coronary artery disease. Let's touch base on the ischemia cascade. It's very important for someone from having normal coronary arteries to almost 90% luminal stenosis. They really go through a cascade of changes that occur. The first thing that occurs is the perfusion abnormality, meaning that there is an alteration in the blood flow in the setting of flow-limiting stenosis, typically around 50%. And that's what we pick up on myocardial perfusion imaging techniques like nuclear MRI. Then from an echocardiography standpoint, they will actually start developing diastolic and systolic dysfunction. So this is where we see our wall motion abnormalities when we subject them to stress echoes. Then they develop ischemic EKG changes as there is more demand and less supply from a myocardial oxygen standpoint before they start developing frank angina. Let's bear in mind that stenosis that's less than 50 to 70% are really often not detected by functional testing, whether that is myocardial perfusion imaging or whether that is echocardiography. So whenever we ask ourselves about the what type of stress testing should we perform, we really go to ask the patient. If they are able to exercise, then really treadmill is actually considered a class 1 indication. If anything, it's the only class 1 indication for diagnosing or risk stratifying people for coronary disease. And we can supplement this treadmill with imaging like echo or nuclear based on certain patient characteristics and risk factors. The reason, the rationale behind exercise, it increases myocardial work and oxygen demand, and we're able to elicit and induce ischemia. Let's say someone who's not able to exercise, then typically we give them an agent, whether that's a vasodilator agent, most commonly used in the United States is regadenoson, or we give them a beta agonist like dobutamine in order to increase the myocardial oxygen demand and try to see whether or not there is any evidence of flow-limiting stenosis. When we talk about the plain treadmill, exercise treadmill stress testing, which has been around for almost 3 to 4 decades using the Bruce protocol, it's very safe. It's widely available. It has been extremely well validated for predicting cardiovascular events and mortality. It is the least expensive of all the non-invasive cardiac stress testing that we do, and it really provides a good measure for functional capacity. Obviously, since we're using EKG alone, patients who have non-diagnostic abnormal baseline EKGs, you cannot use that test alone, like left bundle branch block, a ventricular pace rhythm, or left ventricular hypertrophy. And as we all know from many years of study and research, is that they are lower sensitive and less specific than supplementing them with a myocardial imaging technique. We all know about the stress EKG abnormalities that we're looking at. We're really looking at anything that's more than 1 millimeter, a horizontal ST depression, or downsloping ST depression. These are the ones that are suggestive of ischemia versus the upsloping ST depression, which is usually seen with exercise and does not correlate with ischemia. This is a baseline EKG, and a stress-induced ischemic EKG changes will appear as more than 1 millimeter downsloping depression. Now, some of the information we get from exercise treadmill is, number one, we have favorable information and unfavorable ones. The favorable ones is people who are able to achieve at least stage 4 of Bruce protocol, that's usually 9 or 10 minutes. They have excellent functional capacity as assessed by METs. They have a very low mortality, versus people who are not able to complete a stage 1 of the Bruce protocol, which is 3 to 4 minutes. They start developing dynamic ST depression, or they actually develop diffuse ST depression in multiple leads, and or they start developing exercise-induced ST elevation, or they have angina at low exercise workload. Now, when do we use cardiac imaging to supplement our exercise stress testing? Typically in people who have uninterpretable EKG because of a left bundle branch block, patients with paced ventricular rhythms, abnormal ST segment at baseline, left ventricular hypertrophy, WPW, but also our higher risk cohort patients, people with prior revascularization, or people who have known diabetes or known clinical atherosclerotic cardiovascular disease like PAD or stroke, and also people post-revascularization like stent or CABG, because you do want to provide them with a much higher sensitivity and specificity test whenever you are trying to stressing them. The myocardial perfusion imaging techniques, we have the nuclear ones using SPECT and PET, but we also have the MRI one. And when we look at the most common modality performed in this country for non-invasive cardiac stress testing has been the single photon emission computed tomography, or the acronym of it is SPECT. It's probably one of the most validated cardiology studies in the literature for risk stratifying patients with coronary artery disease. It comes with a sensitivity which is really good of 85%, but a specificity of 70 to 75%. So you could actually be facing false positives with actually these types of stress testings. The way that it works is we actually inject a radio tracer through a peripheral IV. This radio tracer, which can be either technetium or rubidium, depending on whether you're doing SPECT or PET, This usually gets uptaken by the myocardium, assuming that you have an intact cellular membrane and you don't have any flow limiting lesions. You definitely need to augment blood flow. You can do that either with a vasodilator, that's usually regadenoson, or with exercise. And what you really want to see, that you want to increase the blood flow through that artery bed and see whether or not there's any flow disparity. So if you take a look at this diagram, we come up with something looking at the coronary flow reserve. If I have an angiographically normal vessel segment and I give this patient, whether I subject them to exercise or with a vasodilator, I'm able to augment this blood flow by almost 4 times upper limits of normal, versus someone who has a flow limiting stenosis, like an 80% stenosis here. They're really not going to be able to vasodilate their blood vessels further. And that's why they're only going to be able to augment their blood flow by 1 or 2 times. And hence, we're actually going to see an abnormal perfusion in this area versus a normal perfusion within the other area. What a normal nuclear myocardial perfusion imaging looks like, it looks like this. We actually acquire short axis images through the heart, as we can see here. We have vertical long axis images of the heart, as we can see here, and horizontal long axis images of the heart. And what we're looking at is the tracer uptake through all the myocardial segments at stress and rest. And whenever I have normal uptake at stress and rest, and there is really no bite within this donut, then this is a normal myocardial perfusion imaging, versus this one here, where I'm looking at is the inferior wall at rest and stress. And we can see that there is a definitely reduction in the counts of these photons that are being emitted. And these defects that are present at stress and not present at rest, that's really kind of equivalent of an inducible myocardial ischemia, meaning that I have a flow limiting narrowing within, most likely here, the right coronary artery that's not able to improve the flow through this segment. And that's why I see this defect on a myocardial perfusion imaging. Performing an exercise stress echo for people who are able to exercise is really kind of a complementary, non-invasive stress imaging modality. We actually monitor multiple things after we acquire resting data. We subject the patient to an exercise protocol, and then we image them at peak. We monitor their heart rate, their blood pressure. We look at the exercise capacity. And most importantly, we look at the wall motion abnormalities during peak exercise. We actually also look at the heart from different windows, from a 4-chamber view, 2-chamber view, and a long axis view. And what we're able to assess, as we see here on this resting stress echo, where you have normal thickening of all the myocardial segments, but here you have a wall motion abnormality within this apex, along with this mid to distal or mid to apical septal wall, along with the mid interior wall, where we see that the walls are not thickening as much. And this is actually tells us that this patient most likely has a left anterior descending artery ischemia as induced by exercise. Some of the advantages of stress echo is that it's able to localize the region of abnormality based on the coronary artery territory. It has a higher specificity than perfusion imaging, typically in the magnitude of 75 to 89%, based on the ischemia cascade, the fact that wall motion occurs later in the cascade than perfusion. And it's also definitely a higher sensitivity than treadmill alone, and it actually comes with no cost of radiation. Now, although coronary CTA is not considered to be a stress test, but we really have to touch base on it because of the fact that it really has an excellent negative predictive value of ruling out coronary artery disease of almost 99%. And it provides anatomical assessment rather than functional assessment like what we talked about. You get a lot of information about atherosclerotic burden, coronary artery origins for those young patients, along with myocardial bridges. And it's really the best test to rule out coronary artery disease in low to intermediate risk patients. And we've seen actually since 2016 that the NICE guidelines in UK has actually advocated it to be the first line imaging modality, but also the European Society of Cardiology guidelines, they actually give coronary CTA a class 1 indication as a substitute to doing a functional testing in people who have low to intermediate pretest probability for coronary disease. In our ACC guidelines, we typically reserve it for people who have continued anginal symptoms despite normal prior testing, or if someone has had an inconclusive results from a prior perfusion functional testing, or people who are not willing or not able to undergo stress testing using other imaging modalities. Thankfully, with the new scanners that we have, we are able to actually scan patients much quicker with a much lesser radiation to obtain motionless coronary arteries, as we can see here. and you can actually nicely see the branches of the coronary arteries of the heart, the right coronary artery here, the left coronary artery, and the fact that this patient has angiographically normal vessels with no plaque or significant narrowing, with normal origins of the left main and the right coronary artery. We have various reformats to take a look at those vessels, the RCA, the LAD, and the circumflex. And you can actually stretch out this vessel and make sure that there is absolutely no flow limiting lesion. Using stress cardiac MRI as a supplemental functional cardiac imaging technique, it's really been appropriate in intermediate to high risk patients. It really carries a good sensitivity, similar to nuclear of around 72%. It's more specific than nuclear. And other data we obtain from cardiac MRI is functional assessment, myocardial viability in those patients with known coronary disease. We take a look at the valves, and also in women, we actually can essentially rule out microvascular disease. And it's a radiation-free technique, which is particularly important in women of childbearing age. What we are really looking at is, as the gadolinium comes into the heart and it starts washing out, we see actually areas that does not completely wash out the gadolinium, as we see here, these black speckles on this basal anterior, mid anterior, and apical anterior wall. That's the anterior septum inferior lateral. And that's really kind of a perfusion defect that we're seeing with MRI that corresponds to left anterior descending myocardial ischemia. So really kind of to finish up here, choosing the right test is important. And some of the questions that every clinician should bring up is, number one, the pretest probability of coronary disease. Why am I ordering a stress test on my patient? The advantages and limitations of different modalities based on their body habitus, their kidney function, whether or not they're claustrophobic, their ability to exercise. Take a look at that EKG. Is it normal or uninterpretable, along with the comorbid conditions? With that, I thank you for your attention, and I hope you all have a great educational value from this meeting.
Thank you very much, Dr. Shamsi Pasha, for this overview. Obviously, you could spend a whole day on all various stress testing, but you were able to summarize it well, and I think it's a good primer for you if you're ordering a stress test. Which one do you use, and how do you put this thing together? Our next speaker is Dr. Nadine Faza. Dr. Faza, excuse me, his specialty is structural heart disease and cardiovascular imaging, and she will address the issue of perioperative risk assessment. When do I need cardiac testing? Dr. Faza.
Good morning from Houston. My name is Nadine Faza, and I'm one of the structural heart disease imagers here at Houston Methodist, and I'll be talking about perioperative cardiac risk assessment and management. I have no disclosures. More than 50 million surgical procedures are performed annually in the United States, the vast majority of which are elective. Major perioperative cardiac events are estimated to complicate between 1.4% and 3.9% of surgeries. In my talk, I will be highlighting the 2014 ACC/AHA guideline on perioperative cardiovascular evaluation and management of patients undergoing non-cardiac surgery. It's helpful to adopt a stepwise approach to the perioperative management and assessment of patients. The first question that needs to be asked: is the surgery an emergent surgery? Different surgeries can be categorized according to their urgency. Emergent surgeries are life or limb-threatening if not performed within less than 6 hours. Urgent surgeries are life or limb-threatening if not performed between 6 and 24 hours. Time-sensitive surgeries are those where the delay of more than 1 to 6 weeks will negatively affect outcomes. And elective surgeries are those that can be delayed for up to 1 year. So if the patient is undergoing emergent surgery, then the recommendation is to proceed to surgery without further workup or assessment. So in patients who are not undergoing emergent surgery, but rather needing elective non-cardiac surgery, the second question is the patient exhibiting evidence of acute coronary syndrome? If the patient is presenting with symptoms consistent with an acute coronary syndrome, with a STEMI, or unstable angina, then the recommendation is to proceed to ACS evaluation. With regards to timing of surgery post-acute coronary syndrome, The ACC-AHA guidelines recommend at least a 60-day interval between an acute coronary syndrome and elective non-cardiac surgery. It's also recommended that aspirin be continued or restarted as soon as possible. For patients treated with PCI who are undergoing elective non-cardiac surgery, it is recommended that patients who have been treated with a bare metal stent have a delay in surgery of more than 30 days after the stent implantation. As for patients who were treated with drug-eluting stents, the recommendation is to delay surgery for at least 6 months. In cases where a delay in surgery is greater than the risk of stent thrombosis, it's reasonable to proceed with surgery after 3 months of stent implantation. Going back to our algorithm, for patients with no evidence of ongoing acute coronary syndrome, the next step is assessment of the perioperative risk for major adverse cardiac events. In the perioperative clinical risk assessment, the following should be evaluated for: coronary artery disease, heart failure, valvular heart disease, arrhythmias, and pulmonary vascular disease. The incidence of a major adverse cardiac event of death or myocardial infarction perioperatively is first and foremost related to the baseline risk. There's a significant increase in the post-operative incidence of major adverse cardiac events as the length of time from the myocardial event to surgery shortened. In patients with heart failure, studies have demonstrated improved perioperative outcomes for patients with stable heart failure who are treated according to guideline-directed medical therapy. Decompensated congestive heart failure is a contraindication to elective surgery, and stable patients with New York Heart Association class 1 to 2 symptoms may undergo surgery. It's recommended that patients with heart failure undergo surgery at centers of experience in managing high-risk patients. In patients with valvular heart disease, studies have demonstrated that patients who meet standard indications for valvular intervention with either replacement or repair on the basis of symptoms and severity of stenosis or regurgitation, valvular intervention before elective non-cardiac surgery is effective in reducing perioperative risk. In patients with pulmonary vascular disease undergoing non-cardiac surgery, mortality rates vary from 4 to 26%, and cardiac and/or respiratory failure rates range from 6 to 42%. Current guidelines recommend continuation of pulmonary vasodilator therapy perioperatively and preoperative evaluation by a pulmonary hypertension specialist before major elective non-cardiac surgery. Risk of a major adverse cardiac event of death or myocardial infarction can be divided into low risk and elevated risk. Low risk is defined as less than 1%, while elevated risk is defined as a risk of more than or equal to 1%. The revised cardiac risk index is commonly used to evaluate the perioperative risk for major adverse cardiac events. This index includes high-risk surgery, history of ischemic heart disease, congestive heart failure, cerebrovascular disease, preoperative treatment with insulin, preoperative creatinine levels of more than 2. Patients scoring 0 or 1 point are considered to be at a low risk for major adverse cardiac events. Patients scoring 2 or more points are considered to be at an elevated risk for major adverse cardiac events. Surgeries are divided into low risk, intermediate risk, and high risk surgeries. Low risk surgeries include breast, dental, endocrine, eye, gynecological, reconstructive, minor orthopedic, and minor urological surgeries. High-risk surgeries are aortic and major vascular surgery, in addition to peripheral vascular surgery. It is also worth mentioning that the American College of Surgeons has other tools for perioperative risk assessment that can be accessed online. Back to our algorithm, in patients with a perioperative risk of less than 1%, meaning an RCRI score of 0 or 1, it's recommended that patients proceed to surgery. In patients with a perioperative risk of more than 1%, then further evaluation is recommended, and that starts by determining a patient's functional capacity. Metabolic equivalent of task, or MET, is used to evaluate a patient's functional capacity. The ability to achieve 4 METs of activity without symptoms is thought to be a good prognostic indicator. Activities achieving 4 METs include walking up a flight of steps or a hill, or walking on ground level at a speed of 3 to 4 miles per hour. If unsure, it's reasonable to consider an exercise treadmill test to establish a patient's functional capacity. In patients who are able to achieve 4 METs or more, then no further testing is recommended before proceeding to surgery. So these patients with moderate to good or excellent functional capacity are able to proceed to surgery. In patients who are unable to achieve 4 METs or have an unknown functional capacity, then non-invasive testing is recommended if the results would change their management. Non-invasive stress testing is recommended in patients with an RCRI risk of more than 1 who have poor functional capacity are unable to achieve 4 METs, or in patients with RCRI scores of more than 1 and an unknown functional capacity. Stress testing is not recommended in patients with good or excellent functional capacity or with patients who have an RCRI risk score of 0 to 1. It's reasonable for patients with known coronary heart disease or other significant structural heart disease to have an ECG preoperatively, except for those undergoing low-risk surgery. It is not useful for asymptomatic patients undergoing low-risk surgical procedures. Preoperative echo is reasonable in patients with dyspnea of unknown origin for evaluation of LV function, patients with known heart failure and worsening symptoms or a change in their clinical status, patients with suspected moderate or greater degrees of valvular stenosis or regurgitation with no prior echo within 1 to 2 years, or with a change in their clinical status. Routine preoperative evaluation of LV function is not otherwise recommended. Coronary angiography performed routinely is not recommended for perioperative evaluation of patients. In terms of medications, it's recommended that beta blockers are continued in patients who are on beta blocker therapy chronically. Beta blocker therapy should not be started on the day of surgery, and statin therapy should be continued. In patients with mechanical valves, bridging therapy is indicated in patients with either a mechanical mitral valve or patients with mechanical aortic valves with risk factors. Risk factors include atrial fibrillation, previous thromboembolism, LV dysfunction, hypercoagulable states, and older generation mechanical valves. Patients with ICDs should be on a cardiac monitor continuously during the entire period of inactivation, and external defibrillation equipment should be available. ICDs should be reprogrammed to active therapy as soon as possible. In summary, in patients with acute coronary syndrome, recent PCI or MI, decompensated heart failure, and severe symptomatic valvular heart disease, it's recommended that surgery is postponed. In patients with a perioperative risk for major adverse cardiac events of 1% or more, and an unknown functional capacity or a poor functional capacity, then further testing is needed before surgery. In patients with a perioperative risk of less than 1%, and in patients with good or excellent functional capacity, then these patients can proceed to surgery. Thank you so much for your attention.
Thank you very much, Dr. Faza, for this very insightful and very important, really, topic, because the cardiologist and even the internist will get quite a few of these questions. You know, perioperative risk, what should we do? I think, in my opinion, we do a lot of testing that at times may not be truly necessary without assessing risk and functionality and all that. Okay, so we have about 10-15 minutes to address some questions. So I would like to ask the audience and remind them that they can join us by either the web, go to Paul Ev and enter DeBakey. polev.com, and then, or by texting if you're in the United States or available to do that, text DeBakey to 37607. And we have a couple of questions already. One for Dr. Soleiman. Is there an app for assessing pre-test probability? Or Dr. Faza too, I mean.
So there's not an app per se for pre-test probability, but again, it's the matter of how you use the apps and how you use the data. So if you take somebody's Strava app, for example, one of the fitness apps, and it shows that that person does do, 10 miles a week at a 15-minute pace, and then that person tells you, I feel great, I have no symptoms, then you've already shown and proven what they're doing in regards to their physical and functional capacity, and therefore you could use that data as your preoperative cardiovascular risk assessment. So it's a matter of not just a specific app, it's a matter of how you use the data that you get from the apps.
Nadine, from your assessment of things, obviously the first question could be just a decent quick history will tell you the situation, right? I don't need electronics to help me there, but tell us from your end.
I think we're so used to like online calculators now calculating our 10-year ASPVD risk and all that. There's on the website of mdcalc.com, you can find the RCRI index and you can plug the risk factors and it will give you their preoperative risk based on the RCRI index score.
So rcr.com, is that it?
mdcalc.com.
MDCalc.
And look for the RCRI index.
Got it. Very important. Question for you, Dr. Faza. And by the way, Dr. Faza joining us overseas. I mean, that's the beauty of this forum is nowadays you could do that electronically instead of using satellites in the past. Which testing do you recommend for seniors, 65-year-old, who are asymptomatic but are at a high risk cardiovascular disease patient, but they're asymptomatic?
So again, you have to determine their functional capacity. So if they're able to achieve more than 4 METs, then you don't need any further testing. If it's unclear that what their functional capacity is, you can start with an exercise nuclear stress test or an exercise stress test to determine their functional capacity. And if they're unable to exercise for some reason, then you can proceed with like a nuclear stress test where exercise is not involved. It's best to choose a test where exercise is involved when a patient is able to exercise, because that can give you additional data.
Dr. Shamsi Pasha, how about if we have somebody with a left bundle branch block, how would you decide what test to do? If it's a stress test, is there any preference of one or the other? I'm talking about imaging because you mentioned to us, obviously, that if you have left bundle branch block, you cannot just use a CTA in those situations, knowing that there are issues with diagnosing ischemia with bundle branch block. But how do you go about it?
Yeah, great question. Thanks, Dr. Zoghbi. So practically with left bundle branch block, we have a limitation when it comes to using myocardial perfusion imaging because of the partial volume averaging of the septum, especially when we are imaging it at different cardiac cycles. We can see a false positive perfusion defect, especially when using the traditional nuclear SPECT MPI. With PET myocardial perfusion imaging, I think because of the diagnostic accuracy and the spatial resolution is much better, you do not really see those defects. So that's one imaging technique to be aware of. In stress myocardial perfusion imaging using MRI, left bundle branch block will not cause any defect because of the fact that you're seeing real-time first pass of the contrast, which is gadolinium. So either techniques, stress echocardiogram might have the septal bisynchrony, but it might create a regional abnormality, especially with peak exercise. But I think I would say the standard would be you have to supplement in a patient with a left bundle an imaging technique, whether that is stress echo or stress nuclear, but preferably PET
and cardiac MRI would be an alternative if it's available in the institution.
I mean, CTA would be a good option too, because perfusion imaging may have an issue if it's the appropriate patient, and you need something. I'm talking about not pre-op here, but somebody with chest discomfort, etc. Right? What do you think?
It is very common. There was a CT paper published 2 years ago that showed the prevalence of coronary artery disease, obstructive disease, in people with left bundle on CTA was 50%. So 1 in 2 of people with left bundle, they will have coronary disease, and I think CT would be a nice one-stop shop to kind of look at anatomy versus physiology, like other functional techniques.
Dr. Suleiman, what are your thoughts on the Cardiomobile? Basically, to be able to get an EKG, and I think there are different options nowadays.
Yeah, so Cardiomobile was actually one of the major first EKG rhythm identifiers. It's pretty simple. The way I think of it is this way. When I tried it, I learned it initially from Dr. Valderrabano, our electrophysiologist, when I was a fellow here. It takes you approximately 50 to 60 seconds to get a proper EKG, getting it out of your pocket, putting it down, putting your fingers on it so you can get a proper 30-second EKG. So for people that say, I have palpitations that occur and only last for a few seconds or 20 seconds or something like that, then frankly, cardio would not necessarily be of benefit. Then we use one of these patch monitors that we use for continuous monitoring. But for somebody that tells you I have rhythms or arrhythmias or palpitations that last for 3, 4, 5 minutes, then I tell them cardia is yours, number one. You buy it, it's yours. It's not limited by a Holter monitor for 4 days, 2 days, etc. And then that you could take it out of your pocket very simply and use it. And then they do a PDF file connected to their iPhone or so forth, and they send that to me on my chart. We here at Houston Methodist use Epic. And according to that, then I could confirm what that rhythm was that they're having for a few minutes. So it's very valuable, again, in the right clinical scenario.
Okay. What's your opinion, which is important here, Dr. Faza? What's your opinion about proceeding routine transthoracic for a pre-op evaluation? Shake your head as much as you can.
It is not indicated unless the patients are symptomatic or they have other reasons to obtain an echo, but routine echo testing is not indicated otherwise.
I know many people do that, and I think, follow symptoms, physical activity. Is there some instability? Is there heart failure, right? Concern or things like this. How about an asymptomatic patient going for very high risk aortic surgery? Is 4 METs good enough?
That's what the studies have shown. If a person has a functional exercise capacity of 4 METs, then they do well with surgery. Of course, it's important to look at other risk factors and make sure to get a detailed history, because sometimes, especially with people with peripheral vascular disease, if they're unable to walk much, and they can tell you, we don't have any shortness of breath, we don't have any chest pain. In the preoperative evaluation, I think the most important thing is to spend extra time to get a detailed history, because that changes what you end up doing.
Got it. For Dr. Suleiman, which apps do you use in your clinical practice?
So
it's a handful. Hopefully, it's less than one hand.
Yeah. So it's according to the patient. So if the patient has a Bluetooth blood pressure device, most of these come with their own apps. If a patient already has a blood pressure device at home that they use and we verify that it's accurate, then there are blood pressure log apps like BP Companion, stuff like that, where basically they just put in the information. If they already have a Bluetooth blood pressure device that automatically keeps a record on their phone, then they make a PDF file and send that to me. Same thing for weights. Same thing for activity. I give people 3, so I just don't make it commercialized. I send them 3 different fitness apps, and they get to kind of play around with it and see what they like. I use Strava. There's the iPhone application for activity. There's a lot of different types of apps. But that's my point of it's important for the clinician and the office staff to play around with a couple of these apps and understand them very well, understand how they report, and then you can recommend that to your patients and communicate with that.
Very good. Dr. Shamsi Pasha, stress SPECT versus PET. Your thought on that?
Well, there are multiple position statements from the American Society of Nuclear Cardiology that basically has talking about the advantages of PET when available compared to SPECT. A couple of the advantages are, number one, you have a far more better sensitivity and specificity. If anything, based on the meta-analysis, PET, compared to all the other functional stress testing, has the highest diagnostic accuracy and the highest sensitivity when compared to other techniques. That's number one. Number two is you have far more or less radiation with a PET myocardial perfusion imaging versus SPECT. So the radiation dose is typically in the magnitude of 3 to 4 millisieverts, versus if you're going to be doing a stress and rest SPECT, you're really talking about 7 to 8 millisieverts. Number three, with PET, you actually get supplemental anatomical data, which includes coronary calcium score. This is built in our routine protocol whenever we do myocardial perfusion imaging with PET. And then last but not least, especially in women, and we are concerned about microvascular angina, you actually have the supplemental data of obtaining quantitative myocardial blood flow. And this basically has an advantage in looking at absolute myocardial blood flow rather than relative flow using the technique of the myocardial perfusion imaging alone. So PET is actually a winner when it's available.
Winner when it's available. Also, I think maybe another caveat is at this time, we don't have an agent during exercise, right? So it's got to be a pharmacological stress test as opposed to an exercise nuke, let's say, correct?
Actually, we do have ammonia is basically a tracer that has a longer half-life compared to rubidium. So ammonia will have a longer half-life that you are able to do a treadmill. Again, the most common used radio tracer in PET is rubidium, because ammonia needs a cyclotron, while rubidium, it basically can be accessible via a generator. But that's absolutely right. That's one of the limitations of PET.
Given that in the ischemia cascade, symptoms are the last thing to manifest, and how likely is it that someone who is very active, who runs 5 miles a day, is missing some ischemia? Unlikely, right? I mean, there are very few asymptomatic individuals.
Yeah, I mean, that's really kind of where your pretest probability in someone who's asymptomatic, minimal risk factors for coronary disease, they're telling you that it's unlikely that they will have a flow-limiting stenosis. And these people who, if you want to get a better risk stratifying tool, is basically a calcium score can be considered. But that's basically for detecting subclinical disease, and maybe it will help you with performing or addressing their cholesterol and other risk factors.
Dr. Faza, I'm glad our audience is bringing such things, because it's important for us to re-stress. 47-year-old female, newly diagnosed with hypertension, asymptomatic, slightly elevated cholesterol. Cardiologist recommended echo and stress test. Would you recommend these tests to be done?
I would not recommend a stress test if the patient is asymptomatic and functionally able to exercise without having any ischemic symptoms. So again, it's all about the history in such patients.
Right.
So just having hypertension and elevated cholesterol doesn't mean that they should undergo stress testing for ischemic evaluation. We have to go by the symptoms and the functional capacity and what they're able to do.
Wonderful. Well, this has been a very exciting session here. I'm just seeing if there is another. There's one more test. We could do that. Which testing do you recommend for seniors who are asymptomatic but are at a high risk of cardiovascular disease, as you don't want to get a false positive test? Asymptomatic, 65, high risk. question is, do you need it?
Dr. Nasser will tell you it's calcium scores.
Yeah, I mean, if they're functionally very active, you really don't need a test, right? Unless you see something, a very abnormal electrocardiogram, something that you really need to investigate. So, I mean, the message here is do appropriate testing and try to decrease the number of testing where it is inappropriate. And I think you covered it very nicely in this. So I want to thank you all for great presentations, for a great discussion. We will take a 15-minute break, and I'd like our audience, if they have the time, to visit the exhibits, because our exhibitors certainly have contributed to us to be able to do this program for you. So if you don't mind taking that time and get some walking around, stretching, and come back within 15 minutes or so. So we'll be resuming at 15 after the hour.
Hello, everyone, and thank you for joining us in this course. In the next 15 minutes or so, I will discuss echocardiography and Doppler and their appropriate use. Certainly, the technology of ultrasound and its application for the heart has evolved so much over the years, and now it is an essential armamentarium in our evaluation for heart function, valvular heart disease, patients with chest discomfort, and you name it. So it has evolved into a family of techniques, echocardiography and Doppler, even 3D and strain. So we will talk briefly about that and the appropriate use of such. So the common uses of echocardiography, I think most of you are familiar with, predominantly to evaluate chamber size and function, valvular heart disease, pericardial effusion, patients with atrial fibrillation, endocarditis, stroke, and aortic dissection. So certainly a very large variety of cardiovascular diseases. So for ventricular function, this is the vast majority of the applications of such technology. We look at the size of the heart, its function, its regional function. Notice in this individual with apical infarct that there is a akinesis of the apex. Look at hypertrophy in patients with hypertensive heart disease or amyloidosis, if you will. And ejection fraction certainly is a very strong parameter for function and prognosis. And nowadays with 3D echocardiography, we can get a better assessment of volumes and ejection fraction. Another thing that you may be familiar with and see on the reports is the strain imaging. And this is another parameter of ventricular function when the heart deforms during the cardiac cycle. And notice here in this heart with significant dysfunction and apical akinesis, the deformation of this heart, meaning shortening of the myocardial segments. In general, global longitudinal strain is minus 18%, and minus because it shortens. And you could quantitate each one of these regions. Now, you may not necessarily go through all the details of that, but this is automated quantitation of regional function in addition to global function, which has significant impact in diseases, and particularly cardio-oncology, where we're monitoring cardiotoxicity of some pharmacological agents. So in assessment of ventricular function, particularly, let's say, in recent or old myocardial infarction, patients with chest pain alone, a rest echo may be of just minimal value. A stress echo would probably be much better if you're looking for ischemia. Dyspnea for heart failure, patients with abnormal electrocardiogram, cardiomegaly if you're suspecting that from a chest x-ray to assess the size of the heart, and as we talked about, hypertension and prior to major surgery in certain individuals. So for patients with chest pain, a rest echo alone may not be of diagnostic value if you're suspecting inguinal discomfort. So yes, the exceptions are if you have somebody with an acute MI, troponin elevation, pericarditis, aortic dissection, hypertrophic cardiomyopathy, abnormal electrocardiogram, and the others, I think stress echo or any other stress modality would be important. Now for heart failure, imaging can tell us a lot actually as to the underlying etiology of the heart failure. So this is a dilated cardiomyopathy, hypertrophic cardiomyopathy there with a systolic anterior motion of the mitral valve, amyloid heart disease, regional dysfunction in somebody who had a previous myocardial infarction. Now for patients with heart failure, we use echo to evaluate hemodynamics, also with Doppler, look at possible restriction or constriction, patients with pulmonary hypertension, and certainly tells us about prognosis. This is a publication from our institution by Dr. Nag many, many years ago, actually, which is used now globally. When you evaluate ventricular filling pressure, we use Doppler techniques, mitral E velocity compared to the tissue, the E velocity, and E over E prime or EA ratio can tell us a good evaluation of whether filling pressures of this heart is elevated, yes or no, and it has significant prognosis. So it can, if somebody has dyspnea, this can really help you to tell whether it is cardiac or pulmonary. Other thing, as you probably know already, is that we evaluate non-invasively PA systolic pressure from the tricuspid regurgitation jet using the simplified Bernoulli equation. And that's how we derive it. Most people have a little high-need tricuspid regurgitation, and we use that to assess PA pressure by adding in addition to the 4 V-square formula, adding an estimate of right atrial pressure. Pericardial effusion, among probably the first applications of echocardiography from Dr. Feigenbaum's early days. I think these are important to evaluate, particularly after surgery. You got to be careful after surgery. At times, you know, the may not be just fluid. It could be a clot and with echogenicity in it. Patients with chest pain from after with metastatic cancer, uremic pericarditis, etc., etc. Now, a few other things that we use, and I know you ordered these echoes for, is sources of emboli, particularly somebody in a younger individual with possible patent foraminal valley. You could see that here, that intermittently a saline microbubble can come to the left heart. Interestingly enough, with saline, these microbubbles that come with agitation of saline do not cross the pulmonary circulation. So that's how we detect shunting. And here, this intermittent shunt through the patent foraminal valley that occurs. Now, for patients at times, obviously with a large myocardial infarction or apical akinesis, you can have large or small thrombi, but not infrequently, you've seen that, is we use ultrasound enhancing agent, not agitated saline, but these are agents like, you know, Definity, Lumason, and Optison, which cross the pulmonary circulation and go to the left side to enhance the images. So here you could tell that we could not see well the this echocardiogram, particularly if patients are in the intensive care units, and notice this very large lobulated apical thrombus in an apical infarction that really helps clinch the diagnosis. Now, valvular heart disease, obviously a major application of echocardiography because it can tell us about stenosis using Doppler and regurgitation also using echodoppler to tell us the severity of these lesions. You know, we use it for patients with heart murmurs to identify where the murmur is and whether it is significantly pathologic, yes or no. Unfortunately, our physical examinations of our graduates and other physicians have gone down a bit in accuracy, but I think we have this methodology to try to help you out here. So we use it also to not only quantitate the severity, but in patients who need an intervention, a catheter-based intervention or open surgery, it helps identify that. Also, there's obviously a population with prosthetic valves already. You know, we can evaluate function, but I think whether there's an endocarditis on it or not, transthoracic echocardiogram is really not the best way. And this is a segue to look at transesophageal. We haven't even talked about transesophageal echocardiography. Usually a surface echo is certainly the first line of evaluation, but TEE has a better resolution because it's come through the esophagus, particularly for basal structures. Like if you're looking at the left atrial appendage thrombus, you're not going to see that with a transthoracic echocardiogram. At times there are aortic debris in an older individual that could be a source of emboli. If you're wondering also about prosthetic valves, endocarditis, much higher resolution, and therefore you could see vegetation. At times, even larger vegetations like this may be missed if the surface echocardiogram is not of a good quality. So I think you have to use your judgment as to regarding, you know, the need for further evaluation. At times, the echo laboratory will suggest to you further evaluations depending on what we see on the end, the indication. So therefore, we need a good indication from you, the clinician, to tell us and direct us as to what is needed. Now, this is an algorithm for endocarditis of when do you use a transthoracic versus a TEE. Obviously, transthoracic is a first diagnostic modality, but particularly if you have a high probability or a prosthetic valve for endocarditis, certainly TEE is indicated, certainly in prosthetic valves. I wanted to share this slide with you. This is an older slide, but I think it's still very relevant, meaning that in cardiology, as well as in overall medicine, so this is radiology in addition, the number of studies, particularly CT scan or advanced, have increased significantly. Now, physicians health practitioners are relying much more on imaging for accurate diagnosis, but also we want to be stewards of these resources and not just order them right and left without appropriate use. And this is where appropriate use criteria came from the colleges of radiology, also from the American College of Cardiology. And this is almost 15, 20 years ago now. Started with SPECT imaging, nuclear imaging, and then now basically involves almost all areas of cardiovascular care. And we're not going to go through all of them, but they're there for you, and particularly also for echocardiography. Yes, echocardiography is rather benign, is non-invasive with only ultrasound, but I think we have to use it judiciously. At times we see an indication for a headache or other things. Certainly it has to be appropriate, right? And one recommendation here for appropriateness is prior to surgery. And in the past, we've seen a lot of requests for even minor surgeries like cataract surgery or other things. So you have to be mindful of when is this needed. A class 1 indication would be for current or poorly controlled heart failure without a recent ejection fraction measurement. Class 2 indication, patients with prior heart failure, and patient maybe with dyspnea, whether the etiology is yes or no. But for patients who are very active, have no symptoms, et cetera, vast majority of the time, you don't really need an echocardiogram. And routine pre-op check is really a class 3 indication. So in summary, in a way, conditions where echocardiography is not cost effective, routine checkup in somebody who's asymptomatic with no clinical signs of heart disease, ambulatory patient with recurrent chest pain, no specific abnormality on physical exam, in contrast to stress echo where you may want to do it and get both information. Palpitations, everything else is negative, even your exam, EKG, and everything else. Elderly patients with strokes whom already anticoagulation is indicated, and you're not going to change any management at all on these patients. So in conclusion, know what is specific information you're looking for and how will the results alter your diagnosis. Be aware of just order sets anytime patients come in, just order an echocardiogram. Know the limitations of the test you're ordering, and if in doubt, please ask an expert in the field. Here at Houston Methodist, certainly we have a lot of expertise in various imaging, and I know throughout the day today you will hear them. This is the Imaging Institute team. Dr. Deepan Shah right here is the head of the institute currently. This is Dr. Mamarian, Dr. Quinones, Dr. Sharif Naga, who heads the Echo Lab, and all the other faculty and staff. So pleasure having you today, and enjoy the rest of the meeting.
Well, the next two talks will address advanced imaging, their indications and appropriate indications and implications. And I think our next speaker, Dr. Muaz Al-Mallah, who is our Director of Cardiovascular PET and Professor of Medicine and Cardiology, and he will address cardiac CT and PET. What do I need to know? Muaz.
Hello. I'm tasked to talk to you in the coming 15 minutes about the role of cardiac CT and PET. What do you need to know? These are my disclosures. Okay, so coronary CT angiography has been around now for more than a decade, and it is an excellent tool to assess coronary anatomy. It will allow for detailed assessment of the major coronary arteries and even its sometimes small branches. Over the years, the quality of this technique has improved significantly, and now we can have high quality imaging even with lower radiation doses. When you do coronary CT angiography, you can either have normal coronary arteries detected, or you can see some mild stenosis, as you see here, a calcified plaque, or moderate stenosis or severe stenosis, as you see here, focal or diffuse stenosis, as you see in the other vessel. And this has been studied extensively in regards to the diagnostic accuracy of images. In other words, when I see these coronaries look like this, how often they are normal? And could this replace invasive coronary angiography? And data have shown that if you have normal coronaries on coronary CT angiography, then there is no need for invasive angiography, because the negative predictive value is very high, in the range of 97 to 99%. In other words, a normal coronary CT has a 99% chance of being associated with a normal invasive coronary angiography. The problem is in the positive predictive value, which ranges from 50 to sometimes 65 or so %. In these cases, when you see a stenosis on coronary CT angiography, it doesn't always mean that there is an obstructive stenosis, and you may need to do further testing to evaluate whether there is obstructive coronary lesion or not. So as we elucidated before, this is a study looking at 15,000 patients and looking based on the results of the coronary CT angiography, whether they needed invasive coronary angiography. And you can see here there is almost a straight line tracking the x-axis, showing among those patients who have normal coronary CT angiography, there was no need over 3 years for an invasive coronary angiography. Now, which test to choose if you have stress testing versus coronary CT angiography? And this was studied in the PROMISE trial, where the patients with stable chest pain coming to the clinics were randomized to either a 64-slice CT versus stress testing. And they were followed up for death, MI, or other cardiovascular complications. And this study has shown that there was no difference whether you start with coronary CT angiography or functional imaging. Now, around the same time, there was another study which was done in Scotland looking at similar question, but now these patients were randomized more often to standard of care, which was more often just starting with ETT and then followed up by CT versus standard of care. And they noted that there was a difference between coronary death or myocardial infarction. And this was later found to be more so with non-fatal myocardial infarction. The theory behind the difference in this study is that there was an increase in the prescription of aspirin and statins, which may have impacted the outcomes of these patients. Now, there is a lot of data to confirm that after a strategy with coronary CT angiography, there is an increased referral to invasive angiography compared to standard of care. So this was seen in Scott Hart, and this was also seen in PROMISE. And remember, in PROMISE, despite the increase in invasive coronary angiography and in coronary revascularization, there was no difference in outcome. So the take-home message that if you're going to start with a strategy with CT angiography, there will be an increase in coronary angiography and increased revascularization. So how do we put it all together? The ESC chest pain guidelines are the most recent guidelines, and the AHA are updating their guidelines right now. For the ESC, those patients who are likely to have normal coronaries, like those patients with lower risk, should go for coronary CT angiography, while those with higher risk should go for ischemia testing with imaging like nuclear myocardial perfusion imaging or stress echo or others. And those with acute coronary syndrome or higher p-test likelihood should go to invasive angiography. Now, coronary CT angiography does not only evaluate the coronaries, but we can also evaluate grafts. And you can see here that we have a good shot at grafts most often. The problem is that most often the native coronaries, after they got revascularized, they calcify significantly, and we may not be able to assess these native coronary arteries very well. So if your question is the graft open closed, then yes, we can tell. But if the question is what is the cause of this patient's chest pain, we may not be able to evaluate that very accurately using CT. Stents are another challenge. Now, if the stent is more than 3 millimeter, like you see here, it may be easy to evaluate. But once they become smaller, they become more difficult to assess because of blooming artifacts from the stent. We can also assess anomalous coronaries, as you see in these cases, where here, for example, you have an LED coming from the right coronary cusp and coursing in the septum interval. And you can have, for example, here another one with retropulmonic course. Cardiac CT is a must prior to TAVR for assessment of annulus, looking at the valve, and also as looking at the ascending aorta, but also to look at the access vessel and determine if there is stenosis or without stenosis in there. We incidentally see some congenital heart disease on cardiac CT, like an ASD or VSD. Or sometimes we can also look at the valves, native valves, if the echocardiogram or MRI are not adequate. Like, for example, you see here a bicuspid valve, and here's another one with the RAFA. Or we can assess prosthetic valves and to determine why we have increased gradients after the valve implantation. For example, in this patient, the valve is not functioning and one of the leaflets is not moving around. And finally, we can also use cardiac CT to assess for pericardial disease, not so to assess pericardial effusion, because echo would be the more important test. But if you're looking at constriction or pericardial calcification, this is where cardiac CT may add a lot in these patients. So this is a summary for cardiac CT, where we have, it is a non-invasive procedure. It's a fast, easy to perform. It allows for good visualization of high-grade stenosis in almost all coronary segments more than 1.5 millimeter and can assess multiple other cardiac pathologies. Let's move on to talk about the nuclear myocardial perfusion imaging, and I'm going to focus more at PET myocardial perfusion imaging, where we have assessment of relative perfusion, but also absolute perfusion, and also added data with calcium scoring and others. It is the most accurate test as tested in the Pacific trial, where the patients underwent SPECT, PET, and coronary CT angiography, and then they were sent to the cardiac cath. And in that study, they found that PET was the most accurate test compared to all the other imaging modalities that you see here. It has superb image quality, even in obese patients, as you see in this case, where images in the SPECT were not as good, but with rubidium PET, they are adequate and can be interpreted. It allows you to do concomitant assessment of coronary artery calcium score, and we recently published data to show that the addition of calcium adds incremental value over myocardial perfusion imaging, but also adding myocardial perfusion imaging over calcium can help in risk stratification. It can all be done with very low radiation. So to put things in perspective, if you have a newer PET system, you can do it with 2 to 3 millisieverts. That's compared to almost, for example, 21 millisievert with the dual isotope protocol, and to about 10 to 12 millisievert with the other nuclear protocols. We can also provide prognostic data. Patients who have normal PET myocardial perfusion imaging have very low event rate, and those with increased perfusion defects have increased chance of having events. We can also assess myocardial blood flow and coronary flow reserve, and this is very unique to PET because using that, we can not only look at the relative perfusion, but also look at the absolute perfusion, and it will allow us to measure how much blood is making it to the myocardium. And in case of having normal PET myocardial blood flow, the chance of having obstructive disease is extremely low, similar to what we just talked about with cardiac CT. So if you do a cardiac PET and the blood flow is normal, then the chance of having obstructive disease is very low. And here I can show you how we can also use it to determine the extent of disease. This is a patient who has a perfusion defect in the anterior anterolateral wall. But when we look at the blood flow data, we notice that the blood flow did not increase in all three territories. In fact, it even went down. So even though the inferior wall looks okay here, it is telling me that, nope, it is ischemic, and this patient had 3-vessel disease. So it will help me better risk stratify and assess the patient, because by looking at the blood flow, I can determine if they have 1-vessel disease or multi-vessel disease, and determine management strategy. As in this study with nearly 12,000 patients, where they followed them up for outcomes, they found out that if the patient had low flow reserve, then these patients benefit from early revascularization. And this is very important to guide us which patients will need to be referred for revascularization early. We can also do concomitant viability imaging, because we can look why the patient has low ejection fraction. So we can look at hibernating myocardium using FDG, fluorodeoxyglucose, and determine if there is benefit from revascularization in these patients. In addition to all these benefits for coronary disease, I just want to let you know that we can use cardiac PET to look for other indications, like inflammatory cardiomyopathy or sarcoidosis, where patients will have arrhythmias and they have inflammation in the heart. And this is a patient who came in with a VT cardiac arrest and found to have active inflammation in the heart, detected by MRI, but also confirmed by cardiac PET. And we can also look at valve infections, especially prosthetic valve infections. As you see here, this is a patient who had abscess and was referred to cardiac surgery and confirmed that there is a big abscess across the aortic root in this patient. So these are the benefits of cardiac PET. So how do we put it all together? So I told you about cardiac CT, I told you about cardiac PET, and we're, at least in our practice, we're more so adopting the ESC algorithm, which is the lower risk patients will go to CT, the higher risk patients will go more often to perfusion imaging, with some caveats. So in addition to lower risk patients to go to CT, sometimes we send other patients, like those who have positive EKG on imaging, those patients who have persistent symptoms despite a normal stress test and you don't want to cath them. If you think that there is an artifact on stress test, or if the patient has new onset heart failure and there is low suspicion for coronary disease. On the other hand, stress testing is for those with high intermediate probability. We look also for patients with non-CAD, although we can assess grafts and stents, the big stents, but the optimal assessment of myocardial perfusion is very important in these patients. Patients with abnormal kidney function cannot receive contrast, and thus should be done with stress testing. Those with high calcium score cannot be adequately assessed with cardiac CT and are in the realm of stress testing. And finally, if we find a lesion on coronary CT, we can use stress testing to assess whether these patients have significant hemodynamic consequences. Finally, I want to finish up by saying that we always have to put the patient in the center and determine what is the appropriate test that will benefit this patient and how these patients will benefit from all these modalities that we will be using to help identify the cause of their symptoms and the management. Thank you for your attention.
Thank you very much, Dr. Al-Mallah, for a very nice overview of cardiac CT, nuclear stress testing, particularly also with PET. I think these are very important considerations for the clinician who's ordering these testing to try to understand the advantages, disadvantages of each, and where to use them. Our next speaker is Dr. Deepan Shah. He is the Director of Cardiovascular Imaging here at Houston Methodist. He's Professor of Medicine and Cardiology, and he's also the Director of our cardiac MRI laboratory. Actually, he was our first director and continues to be a director with major contributions in the field of cardiac MRI. And he will be addressing cardiac MRI. Is it the ultimate diagnostic tool? Tremendous applications for cardiac MRI. I think you really need to know what they are so you can navigate, the imaging area for your patients. So, Deepan.
Hello, this is Dr. Deepan Shah with Houston Methodist, and I'm going to be speaking with you about the role of cardiac MRI as a diagnostic tool for the non-cardiologist. So to start with, here's an example of an MRI scanner. You can see it's a round circular machine with a table on it that the patient lays on, and the table then goes into the bore of the scanner. Now, some of the advantages of MRI, it's non-invasive, but it's important to keep in mind that it involves high magnetic fields, and therefore we need to carefully screen patients who have any metallic implants or metallic objects within them. But using this MRI, we can actually acquire images of a very wide variety of different cardiac techniques, whether it comes to looking at perfusion, looking at cardiac masses, valve disease, tissue characterization, looking for myocardial infarction and scar, and then pericardial disease as well. And what I'm going to try to do here is talk to you about some of the roles where cardiac MRI can be useful for the primary care, the hematologist, oncologist, the pulmonologist, or the rheumatologist, the non-cardiac specialist. So, first off, I think one of the probably key pieces of information that we try to obtain for any patient when it comes to cardiac evaluation is assessment of contractile function. And so that's really assessed by ejection fraction, as well as looking for regional wall motion abnormalities. And as we'll see, MRI is outstanding for being able to visualize the myocardium to assess left ventricular contractile function. And it doesn't have limitations as far as acoustic windows or interference from enlarged lungs or rib spaces. And a typical LV function study by CMR is shown here. We're actually going to acquire a series of short axis views of the heart from the very base of the heart all the way down to the apex, as well as some of the standard long axis views. And these views can really be done in the course of about a 10 to 15 minute acquisition, and it doesn't require administration of intravenous contrast, and therefore no IV is needed for a simple LV function assessment study by CMR. And then having obtained these serial short axis views, we can then do planimetry of the end diastolic and end systolic contours of the left ventricular myocardium to then derive what the LV end diastolic and end systolic volumes are, as well as what the ejection fraction is. And there's numerous studies that have validated this over the last 25 or 30 years. And one of the advantages here is that there's no geometric assumptions that are being made. We're actually obtaining each sequential short axis slice. And as a result, it gives you much more precise measures of volumes and ejection fraction, as well as much more reproducible measures. And to give you a frame of reference, the typical reported interstudy variability for ejection fraction by CMR is about 3 to 5%, compared to echocardiography, where the interstudy variability is about 9 to 10%. So what are scenarios where this can be useful? Obviously, in patients with cancers who are undergoing chemotherapy, this is one area where CMR could be useful if you wanted to get precise serial assessment of ejection fraction. And let me skip forward here and talk a little bit also about the right heart. As you'll notice, just as well as you can see the LV, you're able to very nicely identify the right ventricular myocardium as well, using the same cine-CMR technique. And again, this requires no intravenous gadolinium-based contrast agents, or any contrast agent, I should say. Obviously, the RV is a little bit more complex of a structure, and as a result, measurement of the RV has a little bit more variability. So in fact, the interstudy variability for RV ejection fraction is a little bit less strong than it is for the LV, and it's typically reported to be about 5 to 6% variability. But this can be useful, obviously, in patients with pulmonary disease, where you're trying to get an accurate assessment of RV ejection fraction. And it can also be useful in patients where you're trying to assess serial changes in RV ejection fraction over time. So let's start off with a case. This is a 72-year-old woman who comes to the office with about a 1-month history of exertional chest pain. She has numerous cardiovascular risk factors here. She's on aspirin, insulin, statin, and an ACE inhibitor. On exam, she's not in heart failure, and her resting EKG shows some STT abnormalities. So this is a patient who is then, needing some form of a stress test. So the question obviously is, what choice of stress agent or stress test are you going to utilize? You've got stress SPECT, CT, looking more at an anatomic assessment, dopamine echo, or CMR. And I'm going to show you what the advantages of CMR are in a case like this. So this is a patient, when we did the cine-CMR images, what we do for any stress CMR study, we can see, in fact, that the overall LV ejection fraction for this patient is preserved. There is some subtle wall motion abnormality here in the inferior wall, but overall, no significant depression in LV function. When we proceed on to the stress CMR, you'll notice, and again, the top image here are the stress perfusion images. So this is done after administration of regadenoson. The bottom images are the rest perfusion images. And we're injecting gadolinium-based contrast very rapidly, and you're seeing the contrast enter into the right heart, into the LV cavity, and then you look to see it enter into the myocardium. And you'll notice in this patient that there is a delayed contrast uptake extending almost from about the 2 o'clock position here, the anterolateral wall, all the way over here to the inferior wall to about the 4 o'clock position. So this is, and we see this both in the very basal slices, as well as we extend down towards the apical slices as well. This is and these findings are not seen when you look at the rest perfusion. So this is very indicative of an abnormal stress CMR, suggesting perfusion abnormalities in this patient in really a multi-vessel distribution involving the LAD as well as the RCA territory. This patient then went on to coronary angiography, and you can see that there's several high-grade lesions within the LAD. There is a small lesion. There's a lesion here in a small obtuse marginal branch. And if you look at the right coronary artery, you can see there's significant disease within the RCA as well. So this is a patient who had multi-vessel disease, and based on the CMR then went on for CABG, coronary surgical revascularization. Now, what does the literature tell us? If we look at this series here, which is a meta-analysis of multiple publications in the literature, what it really shows is that compared to SPECT, CMR and PET had a better overall diagnostic performance, with CMR being a little bit more sensitive than PET, and with PET being a little bit more specific. Advantages, obviously, with CMR over SPECT or PET is that there's no radiation exposure that's given. The other unique advantage of CMR, I think, is this ability to directly visualize myocardial infarction. So in this example patient here, we can actually notice that there's a small area of high signal, what we call hyperenhancement, in the anterior wall. in this patient, which would correspond to LED distribution. So this patient who had no known history of a prior MI actually turns out he had a silent or unrecognized myocardial infarction in addition to their multivessel coronary disease. And there's several studies that have shown that CMR is really the most sensitive technique for being able to identify small subendocardial infarctions. And what we know from numerous studies in the literature in the last decade is that the presence of an unrecognized MI confers almost the same increased risk of future mortality as the presence of a recognized MI. And again, cardiac MRI is really the optimal test in being able to identify these unrecognized myocardial infarctions. And then from a prognostic standpoint, again, a normal stress CMR confers very low risk, less than a 1% annualized event rate in this meta-analysis here, versus an abnormal stress CMR either by abnormal stress perfusion or by abnormal evidence of an occult myocardial infarction. Now, the other advantage I think is with stress CMR is that it can also identify other life-threatening causes of acute chest pain. So here's an example of a patient who presented for a stress CMR for evaluation of acute chest pain and is actually found to have an aortic dissection. Here's another patient on the left-hand side who presented for evaluation of acute chest pain, and we found this person actually had a pulmonary embolism as the cause of their symptoms. And in addition to that, from a symptom standpoint, some of these patients that present with acute chest pain may in fact have pericarditis. And as I'll show you here in a second, CMR can not only identify the abnormally thickened pericardium, as we see in this example case here, but I think most interestingly is in patients with pericardial disease, the delayed enhancement MRI that we perform after we give gadolinium contrast can identify if there's active inflammation of the pericardium. And in this person, we can see here who has a thickened pericardium, we see a pretty significant amount of high signal in the pericardial or in the pericardium after administration of contrast, indicating that there's active inflammation in this pericardium. And this person, after 3 months of intensive anti-inflammatory therapy, we can see the thickness of the pericardium, what it was at baseline, as is shown in the top panel here, to what it is at follow-up now. You can see that the pericardial thickness has actually reversed itself. And as a result, CMR can be used to inform duration of anti-inflammatory therapy in patients with pericarditis. Now, let's turn to a variety of different heart failure conditions that cardiac MRI can be very useful in. And I'm going to highlight just a few of these that I think are patient populations that will come across the non-cardiologist. So here's an example of a patient who presents with syncope, who has a known history of sarcoidosis. And we can see this person actually has an area of thickening or increased wall thickness in the septum here, as well as in the RV. When we do our delayed enhancement MRI with gadolinium contrast, we can see areas of significant gadolinium contrast uptake. And again, these are areas that are patchy, that are not consistent with an ischemic etiology. And this was a patient who turned out to have cardiac sarcoid involvement. And there's numerous studies in the literature that show that for patients who have extracardiac sarcoid, the presence of cardiac involvement detected by gadolinium contrast uptake confers a worse prognosis over time. Also, in patients that have thalassemia or patients that are getting or that have a concern for iron overload, there's a CMR technique called myocardial T2 star mapping, which allows quantification of the iron content within the myocardium. And this can obviously then be used to not only identify the presence of myocardial iron overload, but then be used as a strategy to determine appropriate duration of chelation therapy for these patients. Here's another example, a patient who has a thick heart. You can see their wall thickness here in the LV is almost 1.6 centimeters with mild LV dysfunction. In fact, the RV is also thickened, and we can see the atria are quite enlarged. And the classic finding in this patient, though, is when you give gadolinium contrast, there's very diffuse gadolinium contrast uptake everywhere in the LV as well as the RV and also in the atrial walls. And this is really a classic finding that we see in patients who have cardiac amyloidosis. So to wrap up, I think, again, this, I'm going to finish off with this initial slide, which shows really kind of the versatility of the different types of applications where cardiac MRI can be useful. And I think, I really just touched on the tip of the iceberg, but there's a variety of additional indications where CMRs can be useful both for the cardiologist as well as for the non-cardiologist. I thank you for your attention.
Thank you, Dr. Shah, very much for this very nice overview of cardiac MRI and some of its applications. I'd like to remind our audience to join us. We've had great discussion this morning. If you're on the web, go to paulev.com and enter DeBakey, so you can ask your question. And if you're by text, you join us by text. Text DeBakey, D-E-B-A-K-E-Y, to 37607. All right. Let's see here. CT-FFR is usually quite useful, but which are the situations where we can get false negative or false positive CT-FFR? Very important question there, Moaz.
Yeah, so CT-FFR is a new tool that has been suggested to be helping in the assessment of intermediate lesions.
Can you get a little closer maybe to the microphone, if you don't mind?
Yeah, so CT-FFR might be a problem, is very helpful in patients who have intermediate cardiac lesions. And if there is motion, if there is a lot of calcification in that spot, then there might be a problem in the assessment of the FFR, and you may get a false positive FFR. Another area where if the diffuse vessel disease, so if there is diffuse atherosclerosis in the entire vessel, these patients actually may have also a false positive FFR toward the end without a specific lesion. Now, false negative, many of these CT-FFR modulations depend on the use of nitro. So if the study was done without nitro, you may end up having a false negative. I'm not aware of too many situations where CT-FFR might give you a false negative, but this might be one of them.
Very good. Thank you for a nice presentation. I guess that's addressed to me. LVEF is the most important finding on transthoracic. Although the biplane Simpson method is recommended by ASE, it may be challenging for the non-cardiologist, and I would say even for the cardiologist. So I use visual EF or M-mode or 2D method. Do you have any good practical recommendation for visual EF estimation? Very important question. Actually, most of the time, the vast majority of estimation of EF is visual. But we use clues. And I tell that to our trainees. I said, you are the machine learning in a way, because you put clues all together and try and put them together to come up with an estimation of ejection fraction. Obviously, experience come to play, but looks like a very experienced person here. One is you cannot use M-mode to estimate ejection fraction unless, M-mode is a linear measurement, to estimate a global function unless, one, the ventricle is similarly either normal function, meaning no regional abnormalities, or similarly dysfunctional global dyskinesis. This is where you could use a shortening fraction, if you will, by M-mode. Actually, by 2D nowadays, we use it better than M-mode. And it's usually almost double that. So if you have a 20% shortening fraction, EF is about 40% again, if this ventricle behaves similarly. Two is you could use a single plane as opposed to a biplane, provided that you don't have as much foreshortening of the ventricle, but also at the same time that this plane represents the ventricle. So if you have an inferior infarct and you're doing a two-chamber view, you're going to underestimate ejection fraction. And if you use a four-chamber view, you may overestimate ejection fraction. So these are the things that we use. You use also global longitudinal strain to help you, because this sounds like a sophisticated person to try to do that. Also, you corroborate the ventricle size and function with Doppler, how much stroke volume is coming out of this ventricle, so at least it gives you some idea of where things are. But we quantitate in difficult situation, we quantitate. If you have a machine that have 3D, is also helpful to do this. All right, a question. SPECT versus PET versus MRI in multi-vessel disease and balanced ischemia. This is a sophisticated non-cardiologist. Maybe a cardiologist, you never know. But basically you have multi-vessel disease and maybe balanced ischemia. How do you handle that, both of you?
So I'll start with SPECT versus PET. Definitely that's the Achilles heel of SPECT, and that might be a limitation of SPECT. For PET, we have the absolute quantitative blood flow, so we might be able to pick that up easily with myocardial blood flow assessment, especially if we also combine it with calcium scoring. So we do have multiple additional clues to help us identify that. And as I showed in the talk, if there is normal myocardial blood flow, that almost rules out obstructive coronary disease and high-risk anatomy. So definitely PET, if you're suspecting multivessel disease, go for PET, or CMR, as you'll hear from Dr. Shah.
Dr. Shah.
Yeah, so I think that it's a good point that the questioner is raising. And I think it has to do with the fact that, I think it's bigger of a challenge with SPECT, which is much more of a relative technique. With CMR, although even, you can do quantitative perfusion as well, but most of the time what we do clinically is where we're looking for relative differences. But because of the higher resolution that you have with CMR perfusion, you're typically able to see, even in the setting of multivessel disease, able to see differences between one region and another. The other aspect, I think, is that oftentimes in the setting of multivessel disease, you will frequently have an occult infarction as well, even in somebody who's not known to have a prior myocardial infarction. And the ability of this delayed enhancement MRI, which is very sensitive for identifying any myocardial damage, I think adds to the diagnostic yields. So, in the literature, numerous studies that have been done have shown that even in the setting of multivessel disease, stress perfusion CMR, when we look at CINI, to look at contractile function, we look at perfusion with stress and rest, and then we also do delayed enhancement imaging to look for occult infarction. So the combination of those three techniques still gives you very good diagnostic performance, even in the setting of multivessel disease.
Do you agree? I'm going to follow this. Obviously, SPECT is, at least to my knowledge, is the only one where you can get problems with balanced ischemia and not detecting it, because everything is relative. I'm looking at relative perfusion. Now, with quantitation with PET, you can get by. With MRI, you could see it. You could see where the perfusion defect is, and maybe throughout the ventricle. I'll throw in echocardiography, which is very important. You don't have to worry about that there, because you're going to see a ventricle that is dilated and more depressed, and your differential at that time would be multivessel disease versus a hypertensive response, during exercise, if you're doing exercise. So, this is where the issue is for SPECT. Personally, I always use an ECG with it, meaning and we underestimate that. I always look at if it is exercise or whatever, or even pharmacology, what really happened to the EKG. In those situations where you have a balanced ischemia and significant ischemia, you're going to have EKG changes, ischemic EKG changes. And if you're concerned, you do other testing. You have to relate it to the clinical situation that you're dealing with. Dr. Shah, how about diastolic assessment by CMR? Somebody is pushing the envelope.
Yeah, I have a feeling Dr. Naga may be tuned in here and planting some questions. So no, I think that's a great question. So, right now I will be the first to say that, Echo, I think, has been developing assessment for diastology for many years now, and I think is much further ahead than CMR is. There are several CMR techniques that are, I would say, in the early stages that can be utilized for assessing diastolic function. But again, most of those can also require a reasonable amount of post-processing after the scan. And as a result, they're probably not as readily useful for clinical utility. So I would say that's an area where I think there's work being done, and stay tuned. But I think for right now, that's an area where I think echo really excels.
And I think, this is a good segue to maybe a topic that we really did not delve too much. I did in my talk on diastology. It's very important, somebody with dyspnea that you're concerned about, particularly if the dyspnea at rest is minimal exertion, diastolic function with Doppler is going to be very important. And also I want to tell the audience, particularly if we have primary care physicians and others who are ordering stress testing, there is also I know we didn't go through that, but there is a diastolic function stress test looking at what really happens to filling dynamics during a bicycle exercise in somebody who has exertional dyspnea and not really knowing whether this is pulmonary or this is cardiac. And you could tell the filling dynamics, you could tell what the PA pressure is during exertion, so I think that could be very helpful. Dr. Al-Mallah, some of the applications of PET, which I think are very important for inflammation. I know you mentioned sarcoid a bit, but other things, which is, I think, a nice indication for patients, let's say, who have a prosthetic valve who we cannot see on echo TEE, maybe an endocarditis evidence, and somebody with pacemaker on the leads, not on the pocket. Few of your thoughts regarding how accurate is that?
Yeah, so cardiac PET can assess inflammation. The prototype has been kind of sarcoid, but we can look at it in different diseases. We've diagnosed cases with lupus, cases with rheumatoid arthritis affecting the heart, or Wagner granulomatosis. We've also looked at systemic vasculitis, and that's also like Takayasu and other inflammation, giant cell arteritis. Our most recent case was giant cell arteritis affecting multiple parts of the ascending and descending aorta. So these are all can be considerations for cardiac PET, not only to make the diagnosis, but also to follow up these patients and check their response to therapy. For infection, that's also another emerging tool. Unfortunately, it's not done as often in the US compared to Europe. Europe is leading the world in that, and they're doing a lot of PET for infections, looking at prosthetic valves, looking at LVAD systems, looking at pacemakers, leads, any hardware. I have to put here a disclaimer that this is not good for native valve endocarditis, and that's why we tried not to do it for native valve endocarditis. The sensitivity is very low. So if you see it, it is good, but if you don't see it, that does not rule out endocarditis. For prosthetic valves, it's very accurate. The recent meta-analysis published last year is in the range of 80 to 90% sensitivity and specificity. So it's very high. And remember, most of these cases are the difficult cases that were studied, the difficult cases that echocardiography could not make an easy diagnosis, and thus felt the need for additional information. So I think for prosthetic valve infections, devices, LVAD, this is where PET-CT will have a great contribution to the management of these patients. For native valves, I warn you not to use it unless you're looking for abscess, and a negative study does not rule out endocarditis in these patients.
Thank you, Muaz. Question for me, some people say we should not use EF as the word and focus on contractile function or fractional shortening. I think EF is a measure of contractile function. We have different ways of looking at contractility, fractional change, fractional area change, global longitudinal strain. I mean, use these as an as a measure, if you will, of contractile function. Each one is obviously influenced by load. If you're very acutely hypertensive, I think that's that could be changes almost all of them. Global longitudinal strain is important for you to consider nowadays, in addition to ejection fraction, because we know it's very interesting. Is ejection fraction prognosis, and we talked about U-shape. If it is very low, very bad prognosis. Normal is somewhere in the 60s. Hyperdynamic, actually, as of latest data tells us actually it's prognostically important with negative outcome, because usually they have hypertension or some other condition that is causing this. And also GLS may be decreased in patients with hypertension yet with normal ejection fraction because of abnormalities at the cellular level. So consider this as an evolving area of function. All right, we're not going to be able to answer all the questions, but at least we tried as much. Our next, thank you very much, really a very dynamic session on testing and imaging. Thank you both. Our next topic is as exciting: valvular heart disease advances and treatment choices. And we'll have amazing lecturers here. To start off is Dr. Michael Reardon. Really needs no introduction. He's our professor of surgery, cardiovascular surgery here. And he's certainly an expert on valvular heart disease, involved in many of the trials of the percutaneous valves. And he will talk about TAVR for aortic stenosis. Is it for every patient? Michael.
Good morning. Thank you for letting me join you this morning to talk about TAVR for aortic stenosis. Is it for every patient? These are my TAVR conflicts of interest. I've had the opportunity to design and run a lot of the TAVR trials, but most importantly, I'm a cardiac surgeon. We've run a series of randomized trials in this country that have led to some of the best data we've ever had on valvular disease. In extreme risk, there was a randomized partner 1B trial where we randomized between TAVR and best medical therapy, and there's a 20% survival difference at every year. In the core valve extreme risk trial, we can no longer randomize, so we used a performance goal, and we easily beat that performance goal, so TAVR was approved for extreme risk. We ran two high-risk trials, partner 1A and core valve high risk. And for the partner 1A, the primary endpoint was all-cause mortality, and there was absolutely no difference. For the core valve, the primary endpoint was all-cause mortality, and it was superior for TAVR in years 1 and 2, but by 5 years, no difference. So TAVR was approved for high risk. In intermediate risk, we ran the partner 2A trial, and the primary endpoint for both intermediate trials was all-cause mortality or disabling stroke, and there was no different non-inferior at the beginning for the partner intermediate risk trial, but you see the line start to cross midway through, which is a little worrisome. For the SIR-TAVI, we had a 2-year endpoint of all-cause mortality or disabling stroke, and it was strongly non-inferior. We'll have the 5-year data out this October. So we finally ended up with low-risk trials, the partner 3 trial, which is TAVR with the sapien valve versus surgery. You had to have transfemoral access, and the Evolut low-risk trial, which was TAVR versus surgery, also stratified by the need for revascularization. A couple of differences in these. The primary endpoint for the partner 3 was a non-hierarchical all-cause mortality, all stroke or rehospitalization. For Evolut low risk, it was a Bayesian 2-year endpoint of all-cause mortality or disabling stroke. S3 was already out, so implanters had experience with it. It was used throughout the trial, but in Evolut, you see we used all 3 families of valves. Evolut did not require transfemoral, but 99% were transfemoral anyway. The primary endpoint for the partner 3 of all-cause mortality, stroke, or rehospitalization was strongly superior for TAVR. The Bayesian 2-year endpoint estimates for TAVR was 5.3% and surgery 6.7% for all-cause mortality, disabling stroke, strongly non-inferior. But if we took the Evolut low-risk trial and used a composite endpoint of all-cause mortality, disabling stroke, or rehospitalization, we see it was strongly positive for TAVR. These 2 papers were published simultaneously in the New England Journal when Marty Leon presented the partner 3 trial. His conclusion was TAVR was appropriate for all low-risk patients. Mine was TAVR may be appropriate for all low-risk patients. 2-year data is out for the partner 3 trial, and what you see is the composite endpoint is If you look at death, it narrows even further. And if you look at stroke, it narrows even further. And of course, this trial will be followed out for 10 years, as will the Evolut low-risk trial. Now, these trials have led to the current ACC/AHA guidelines. And when you look at TAVR versus SAVR as a choice, there are 3 categories. Risk is not mentioned. If you're less than 65, you're going to live over 20 years, they recommend surgical aortic valve replacement. If you're 80 or above, are going to live less than 10 years, and you have anatomy suitable for transfemoral TAVR, they recommend TAVR. Between 65 and 80, it's the patient playing into the decision, plus the competing risks, particularly physiologic for surgery and anatomic for TAVR, as you make your decision. So what's happened with TAVR and surgery? Well, if you look at the blue horizontal line, lower line, this is isolated AVR. The upper red line is all aortic valve procedures of any type, and the black line rising is TAVR. So you see TAVR eclipsed isolated aortic valve replacement in about 2015. 2019, there are more TAVRs done than all surgical aortic valve procedures put together, and these lines are unlikely to ever go back. So TAVR is appropriate for everybody, right? Not really. You have to remember these randomized trials only apply to the patients who were tested. So who was not tested? Well, who was excluded? Well, we excluded bicuspid valves, significant coronary disease, unfavorable anatomy, any associated procedures, and anybody appropriate for a mechanical valve. Bicuspid valves, we tend to use the Sievers classification based on the number of Raphi. Sievers 0 have none, Sievers 1 has 1, and Sievers 2 has 2. Sievers 1 with left-right fusion is by far the most common. And in the patients 80 or above, they were still a little over 20%, but as we move to lower risk and we get into the group we're now starting to talk about half of what we see may be bicuspid valves. Now, they weren't treated in the randomized trials, but they've been treated commercially in a TVT registry, and this is a paper by Yoon and McCarr from JACC looking at this, and what they did is they divide them into people that had a little calcification, people that had no calcification of the Raphi, a lot of calcification of the Raphi, and calcification of the Raphi and the opposite reference valve. And what they found is that you have little calcification, that's the bottom black line, your mortality is pretty good at 5.9% at 720 days. If you had just a calcified Raphi, or excessive leaflet calcification on the reference valve, but not both, your mortality at 720 days was 9.5. But if you had excessive Raphi calcification and excessive leaflet calcification on the opposite leaflet, your mortality was about 26%. So not everybody is a good candidate that's a bicuspid valve. Now, we have run a low-risk bicuspid registry, and so far at 30 days, the results look really good. The results for 1 year are going to come out. They still look good, but we haven't published yet. Well, how about age? Well, age less than 65. Well, for the partner 3, only 7% were less than 65, and for Evolut, only 6% were less than 65. And in fact, the Evolut trial, which I was involved in, only 1.3% were less than 60. We excluded on the basis of anatomy, too. Whether your anatomy was too big or too small, that's not too many people. We excluded bicuspid valves, as we just mentioned. And we excluded on the basis of excessive LVOT calcification, which can be pretty hard to define. Now, in these trials, everybody was seen by the local implanting teams who were all supposed to be experts in TAVR with a surgeon that was an expert in surgery, and you had to sign off that these patients met all the inclusion-exclusion criteria and that they were anatomically appropriate both for surgery and for the TAVR valve that you were going to use. So one would think that when it went to the National Screening Committee, everybody would be accepted. But in partner 3, 34%, 520 out of 1520, were screen failed at the national level. And in Evolut, 255 out of 1,723, or 14.8%, were screen failed at the national level. Now, sometimes this is because the site thought they had a tricuspid valve and it's really bicuspid. Unfortunately, we really don't have the data on how many got excluded out for things like excessive LVOT calcification, just choosing for good TAVR valves, because once you're out of the trial, you're out of the trial, and we don't have the data. These are clearly not all-comer trials, so we have to be very careful as we look at this. Significant coronary disease, if you look at the partner 3, they excluded syntax over 32, and Evolut excluded syntax over 22. But in the Evolut trial, where we actually stratified by the need for revascularization, in the arm needing revascularization, the mean syntax was 7. 7. If you're dealing with a syntax of 7, you're not going to find a mortality difference. So we clearly were not treating people that had significant coronary disease, and this still should play into your decision of whether or not you should have a TAVR if you're lower risk. Now, we also really don't know yet about the durability of these TAVR valves. And we define bioprosthetic valve dysfunction in a number of ways, both valve deterioration, structural, non-structural valve deterioration, thrombosis, and endocarditis. And what we're really interested in here is structural valve deterioration. Now, if we look at the surgical data, we've generated a lot of data in surgery. Part of the problem is here's freedom from reoperation at 10 years. Often the definition in surgery was if you didn't get reoperated on, your valve was okay. We know that that's not true. Some people just never come back. But even with that, look at the number at risk at 10 years. There's one trial that has one patient at risk at 10 years, one with 4. You really can't draw conclusions from that. And if you look at the mean follow-up is nowhere close to 10 years in most of this. Here's one with a mean follow-up of 2.5 years, and yet we're talking about 10-year durability. Doesn't make a lot of sense. We can go up to 15 years, where we see here's one with 0 patients at risk at 15 years, and still claiming 15-year durability data. And that particular trial only had a mean follow-up of 6 years. Hard to do a 15-year follow-up. 20, here's one with 1 patient at 20 years, one with 2 patients at 20 years, and mean follow-up, one with a mean follow-up of 4.1 years. Again, as surgeons, we have not done the best job of looking at valve durability. And in fact, we've started to see early failures of surgical valves that have been published. And we've all seen this. In fact, even from our institution, we've published early trifecta failures, and we're seeing this happen more and more. So what do we know about TAVR? Well, one of the longest trials right now is the NOTION trial, which is the Nordic country trial of anybody that was 7 or over. It was supposed to be an all-comers trial. It was set up as a superiority trial with a composite endpoint. So fairly brave, original core valve. This goes way back to the very beginning of our TAVR experience, starting in 2009. And if we follow the hemodynamics over 8 years, and we're really up to 10 years, Lars Sondergaard runs this, and I've talked to Lars about this extensively. There's really no real changes between 8 and 10 years. What we can see is the TAVR valves in red are holding up their EOAs and their mean gradients. You see the mean gradients are starting to go up with surgery, which is not uncommon around 8 years. If we look at the all-cause mortality follow-up at 8 years, no difference between TAVR and surgery in this group that was 70 or above. And in fact, if we look at the composite endpoint that they used, which was all-cause mortality, stroke, or MI, at 8 years, absolutely no difference between TAVR or surgery. Now, if we look at structural valve deterioration, there's a couple ways of doing it. One way is to say, listen, moderate structural valve deterioration would be an increase of a mean gradient of more than 10 and a final mean gradient of over 20, or new moderate to severe intraprosthetic valve regurgitation. If you look at moderate, the moderate at 8 years for TAVR is 14.1%, and for surgery is 28.5%. Why? Because surgical valves often get to a mean of over 20 within a couple years. If we look at severe, which would be a mean gradient over 40, or severe AR, the TAVR is 7.3%, surgery 10.6%, so really no difference in severe. And this is what we tended to look at as surgeons. So what else durability do we have? Well, here's the Partner 1B, 5 years, no changes. Partner 1A, no changes. Core valve extreme, no changes. Core valve high risk, no changes. And the NOTION was at 5 years, no changes. Now, one of the early trials that came out was the CHOICE trial, and we don't see a lot of changes, but we do see a little signal for the SAPIEN XT, but the SAPIEN XT is no longer used. Another thing that we've become aware of is leaflet thrombosis and immobility, and we ran leaflet motion immobility 4D CT studies in both low-risk trials. And what we see is it occurs at about the same rate of this, but if we look at severe halt, it's more common in surgery than it is in TAVR for the Evolut trial, but more common in TAVR than surgery in the SAPIEN 3 trial. But again, we still don't know what halt means, so we have to be very careful when we look at this. So when we look at all this data, we have to pay attention to what wasn't studied and be cognizant of that, and be willing to talk to our patients and our referring doctors about our knowledge gaps. But still, most of this to me is related to age. So the orange bars are your expected life expectancy from U.S. life tables, kind of combining men and women. Women tend to live a little longer. And upper right is a pericardial valve survival from 80-year-olds in 5 years increments up to 50-year-olds. So if you're 80 years old in the U.S., you're expected to live about 10 more years, and your risk of losing your surgical valve is about 4% during that time. I think TAVR valves are tracking this very well. That's a good reason why if you're 80 or above, you should get a TAVR if you're a candidate. 75, now you're going to live about 13 years, and the risk is about 8%. Again, with TAVR valves tracking surgical valves. 75, good transfemoral, still probably a good bet. Well, how about if you get down to 65? Now you're going to live a little over 20 years, and your risk is going to be about 18%. So you're going to at least, for many people, get a second procedure. And if you get down into 50, where you're going to live over 30 years, you'll probably need 3 procedures in your lifetime. So these are the things to think about. I think this is largely why they use the cutoffs of less than 65, living over 20 years, get surgery, over 80, living less than 10 years, get TAVR, and in between, physiologic risk of surgery, anatomic risk of TAVR, what the heart team thinks, what the patient thinks, and make a combined decision. So TAVR is great. It's used in all risk areas, but is TAVR for every patient with severe stenosis? No, it's not. Thank you very much for your attention. I'm happy to take any questions.
Thank you very much, Michael, for a really amazing overview within just a few minutes about where we are in TAVR, what are some of the indications currently, and what do we look for in the future. Switching to the mitral valve, our next speaker is Dr. Sachin Goel. He is our Director of Structural Heart Disease Interventions here at Houston Methodist. And it's great to have him because he is truly the expert on TAVR as well as mitral valve clip and tricuspid valve edge-to-edge repair. And he will talk about catheter-based mitral valve therapies. Is it a good option? Sachin.
Hi, I'm Sachin Goel, interventional cardiologist here at Houston Methodist. My task today is to discuss catheter-based mitral valve therapies. Is this a good option? Here are my disclosures. Catheter-based therapies for mitral valve disease originated with percutaneous transvenous mitral commissurotomy, also referred to as balloon mitral valvuloplasty for rheumatic mitral stenosis decades ago. In patients with rheumatic mitral stenosis, as you can see here, the echo images demonstrate a thickened, restricted stenotic mitral valve with a very small mitral valve area. Here is a mitral valvuloplasty being performed via transcatheter transvenous access after obtaining transseptal access with the Inouye balloon, which leads to splitting of the commissures and relief from mitral stenosis with a concomitant increase in the mitral valve area from 0.9 to 1.4, as you can see in these 3D echo images. This procedure really has laid the foundation for transcatheter mitral valve therapy. Structural heart disease, in terms of the epidemiology, is increasing as our population is getting older. The prevalence of mitral valve disease is almost 10%. Moderate to severe mitral valve disease is almost 10% in patients older than 75 years of age. And a lot of these patients are high surgical risk candidates and are not being treated surgically due to the risk. So if you look at the recent statistics, there are more than 4.6 million patients with mitral regurgitation grade 2 or more in the United States, out of which only about 55,000 mitral valve surgeries are performed in the United States annually. So there is a huge unmet clinical need, which is large and growing for other therapies for mitral regurgitation, non-surgical treatment options or transcatheter therapies. Here are the Cleveland Clinic data. When I was in training, we looked at over 5,000 patients with severe MR, out of which over 1,000 had significant mitral regurgitation, and vast majority of functional patients and a significant proportion of degenerative mitral regurgitation patients were managed medically. And as you can see over time, this is associated with significant mortality and morbidity in terms of proportion of surviving patients hospitalized for heart failure. So this is a huge problem. The mitral valve anatomy, briefly, the mitral valve is much more complex compared to aortic valve, since it's not only involves the leaflets, but also the entire mitral valve apparatus, which includes chordae tendineae, the papillary muscles, and the attached ventricular myocardium. Briefly, the anterior and the posterior mitral valve leaflets are divided into scallops from medial to lateral, and these are labeled in this image, A3, A2, A1, and correspondingly P3, P2, P1. This becomes important when we talk about edge-to-edge repair or MitraClip. So briefly, what are the causes of MR? Broadly speaking, MR causes are divided into primary MR and secondary. Primary means MR related to intrinsic involvement of the mitral valve leaflets and the chordae, meaning there's something wrong with the mitral valve leaflets or the chordae themselves. Secondary MR is also known as functional MR. In this cases, there's nothing wrong with the leaflets or the chordae themselves, but the MR results from left ventricular pathology. And I will demonstrate some examples. So here is an example of primary MR or degenerative MR. This is a patient with mitral valve prolapse and in fact flail of the posterior leaflet of the mitral valve, as you can see in the transesophageal echo images. There is a lot of tissue which is redundant and prolapsing and into the left atrium up here with resultant severe mitral regurgitation and the corresponding 3D TEE image showing a large posterior leaflet flail. This is an example of primary MR where chordae have ruptured and posterior leaflet is flail. In contrast, on the next image here, you will see a case of functional or secondary mitral regurgitation where the leaflets themselves really have no problem, but they fail to coapt because of LV enlargement, LV systolic dysfunction, apical tethering of these leaflets and displacement of the papillary muscles resulting in severe mitral regurgitation. This is seen in patients who have ischemic cardiomyopathy or non-ischemic cardiomyopathy with resultant LV dysfunction and LV enlargement. So the edge-to-edge repair or mitra clip is a technique which is based on the surgical edge-to-edge repair, which was pioneered by Dr. Alfieri, an Italian surgeon. And the technique involves sewing the A2 and the P2 scallop of the mitral valve. This has been pioneered by Dr. Alfieri, and the edge-to-edge or the mitra clip technique is a transcatheter technique by which this edge-to-edge repair is mimicked. The procedure is performed via transfemoral venous access and transseptal access, whereby a catheter is advanced from the femoral vein into the right atrium, across the septum into the left atrium, and the scallops of the mitral valve, anterior and posterior, are grasped, as you can see, achieving coaptation and reducing MR. Mitra clip, this is the timeline or the evolution of the mitra clip. The first case was performed in 2003. The landmark Everest trial was performed and published in 2011, followed by FDA approval for primary or degenerative MR, followed by the COAP trial, which I will allude to subsequently, and then most recently the FDA approval for secondary or functional MR in 2019. There are anatomic criteria that define suitability for mitra clip. The most optimal cases are where the pathology is central in the middle of the mitral valve in the A2-P2 scallop region without any calcium, with large valve areas and long leaflets. There are other conditional and unsuitable anatomic features, which I won't get into a lot of detail for the purposes of this talk. So here's an example of posterior leaflet flail. You can see this is a TEE image. This is a posterior leaflet, which is flail, resulting in severe mitral regurgitation. And this was successfully clipped with 2 mitra clips. And you can see on the bottom left image here, there is trivial mitral regurgitation with the help of 2 clips, which were placed in the center of the valve. We can also treat non-central pathology. Here is an example of A1 flail, which is the anterior leaflet of the mitral valve, all the way in the lateral commissure. You can appreciate it on the 3D image here. This is the lateral commissure, this is the medial commissure, and all the way in the lateral commissure, there is a flail segment resulting in severe MR. And this was successfully treated with mitra clip, as you can see, with complete resolution of mitral regurgitation. Similarly, medial commissural flails have been treated successfully. Here an example of A3 flail, which is on the other side of the valve, on the medial commissure. And this was successfully treated with 1 clip, resulting in severe, almost abolishment of the severe MR. Here is the left atrial waveform, pre and post mitra clip. When we do these procedures, we measure the pressure in the left atrium, and this is a large V wave consistent with very severe mitral regurgitation. And you can see a significant reduction in the LAV wave, which is always very gratifying to see when we do these procedures. As when we see this, you know the patient is going to feel better symptomatically. What about next generation mitra clips? There are now 4 different varieties of mitra clips. These are the generation 4 devices. The old studies were done with the first generation clips, but now we have newer clips, which have several features, including independent grasping ability, where we can grasp the anterior leaflet first, followed by the posterior, and vice versa. In addition, we have longer clips and wider clips. So this allows the ability to treat a wider range of pathology. We've also done some urgent emergent cases during the COVID pandemic last year, and one of our residents published this. Moving on to the secondary or functional MR, the COAP trial is the landmark trial, which evaluated the safety and efficacy of MitraClip on top of guideline-directed medical therapy in patients with heart failure and secondary MR who remained symptomatic despite maximally tolerated guideline-directed medical therapy. About 600 patients were randomized 1-to-1. Here are the baseline characteristics: 300 patients in each group. Mean age was about 72 years. Usual host of comorbidities. The etiology of heart failure was ischemic in about 2/3 and non-ischemic in about 1/3. Most of these had NYHA class 2 or 3 heart failure, and about 50% had 3+ and 50% had about 4+ mitral regurgitation. The mean left ventricular ejection fraction, important to note in these two groups, was about 30%. Procedure was successfully performed in 98% patients, and mean number of clips implanted was 1.7. In about half of these patients, we can get a good result, which is less than equal to mild MR with 1 clip, and in the others, more than 1 clip needed. Here's the echo at discharge. Almost 95% patients had reduction to grade 2 or less MR, with more than 80% patients with 1+ or less MR. Remember, this was done with the older generation clip, and we have data now with the newer generation clip to say that the proportion of patients with less than equal to 1+ MR is upwards of 90%. 90 to 95% patients, we can achieve grade 1+ or less mitral regurgitation with the newer generation clip. So here are the data from the COAP trial. The primary effectiveness endpoint, which was all hospitalizations for heart failure within 24 months, was significantly in favor of the MitraClip on top of guideline-directed medical therapy compared to GDMT alone, with a hazard ratio of 0.53 and a highly statistically significant p-value, and a number needed to treat of about 3 to prevent 1 heart failure hospitalization. What about all-cause mortality? Again, similar separation of the Kaplan-Meier curves with hazard ratio of 0.62 in favor of the MitraClip on top of GDMT, with number needed to treat of about 6 to prevent 1 death. So these are very impressive data in favor of MitraClip. Death or heart failure hospitalization, same story, hazard ratio of 0.57, number needed to treat is 4.5. So just to give you a sort of a perspective for heart failure patients, the number needed to treat, these are the standard heart failure medical therapy, or the GDMT that we talk about. And when you look at the cumulative data over the last few decades, the number needed to treat for all-cause mortality to prevent 1 death is about 22 for an ACE inhibitor or ARB, 28 for beta blocker, 9 for aldosterone antagonist, 36 for sacubitril valsartan or Entresto. However, for MitraClip, on top of these medical therapies, is about 6. So again, these are highly statistically significant and impressive data, which led to guideline changes, which I will allude to shortly. Here is a quick example of an FMR case that we treated recently. Patient with cardiomyopathy and severe MR, successfully treated with 1 clip, with reduction from very severe mitral regurgitation to trace mitral regurgitation. And equally impressive is the LA V-wave waveform, which was the pressure in the left atrium, 64 millimeters of mercury. And post-MitraClip, the V-wave reduced, as you can see here, to 20 millimeters of mercury. So a huge reduction in left atrial pressure, which correlates nicely with clinical improvement in these patients. So based on the data from the COAP trial, the FDA approved MitraClip for functional mitral regurgitation back in 2019. And the most recent version of the guidelines, the valve guidelines in 2020, has included MitraClip for both primary as well as secondary mitral regurgitation. And MitraClip is now referred to as transcatheter edge-to-edge repair, or TEER, according to the most recent nomenclature. This is a quick timeline of the cumulative data on MitraClip over the last 10 years. Everest-True was the study looking at MitraClip for primary MR, published in the New England Journal in 2011. The FDA approved it for primary MR in 2013. The COAPT results were published in the New England Journal of Medicine 2018, and FDA approved this for this indication in 2019. And I will briefly go over the most recent guidelines. So transcatheter edge-to-edge repair or MitraClip is upgraded to a Class 2A recommendation for high or prohibitive risk primary MR patients. This is a Class 2A indications if the anatomy is favorable and patient's life expectancy is at least a year or more. It is a Class 2 indication for primary or degenerative MR. The surgical risk, of course, is established based on the STS risk, frailty, and other comorbidities. For secondary MR or functional MR, MitraClip or transcatheter edge-to-edge repair also has a Class 2A indication in patients who have persistent NYHA Class 2 to 4 symptoms while on optimal GDMT for heart failure. It is considered to be a reasonable approach in patients with appropriate anatomy, with LV ejection fraction between 20 to 50%, left ventricular end systolic dimension less than equal to 7 centimeters, and pulmonary systolic pressure less than equal to 70 millimeters of mercury. These are criteria based on the COAPT trial data. In 2014, there was no recommendations for transcatheter edge-to-edge repair for functional MR, whereas now it is a Class 2A indication. What about other approaches other than MitraClip? Well, there are several other transcatheter-based approaches that I will briefly go over in the next few slides. There are coronary sinus-based approaches where a device such as the Carillon device can be implanted via transcatheter route into the coronary sinus, which runs right behind the mitral valve annulus. And by cinching this annulus, reduction in mitral regurgitation can be achieved. This is an ongoing study. CT plays an important role in assessing suitability for the annuloplasty-based devices. What about neocords? There are neocords which are being studied, which can be implanted via both transapical approach as well as transseptal, transfemoral approach for cases with flail and degenerative MR with reduction in mitral regurgitation. And we are a site for one of these new devices by Pipeline, which is now acquired by Gore for transfemoral transseptal mitral valve chordal repair. Pascal device is another form of transcatheter edge-to-edge repair by Edwards Life Sciences. It has a slightly different mechanism compared to MitraClip, but the end result is very similar, and we are participating in the CLASP study, which is evaluating safety and efficacy of this device compared to the MitraClip. There are other annuloplasty-based devices, such as the Edwards Cardioband Mitral Valve Reconstruction System, which is a transseptal transfemoral system whereby anchors are implanted around the mitral annulus. Here is an image demonstrating the mitral regurgitation before these anchors are cinched or adjusted. And after the anchors are cinched, there is near resolution of mitral regurgitation. This is acquired CE mark in Europe and is currently being studied. Moving on, the next horizon is transcatheter mitral valve replacement. You all have heard success stories of transcatheter aortic valve replacement. This is the next field, the next broad field in the world of transcatheter valvular intervention. And there are various devices that are being studied as we speak. Apollo trial is evaluating the role of the safety and efficacy of the Intrepid transcatheter heart valve, which is a Medtronic valve. It is a dual stent design with an atrial rim. We are studying the valve in patients with primary or secondary MR. In addition to a MAC cohort whereby we are evaluating patients who have significant mitral annular calcification. So who are candidates for TMVR? Well, transcatheter mitral valve replacement patients are usually those who are non-candidates or poor candidates for edge-to-edge repair or MitraClip due to anatomic reasons, or they are not surgical candidates or high surgical risk candidates due to frailty and comorbidities. So how do we do this? So the Apollo trial is looking at transapical primarily, and now there is a transfemoral transseptal access as well. But extensive planning is done by way of echo as well as CT. And here is an example of a case we did recently. This patient was not a candidate for MitraClip. And as you can see on these echo images, there is very severe mitral regurgitation originating from the medial part of the valve. So this procedure, the transcatheter mitral valve replacement, was performed via transapical access. There's a big catheter inserted through the apex of the heart. This procedure is performed, of course, with fluoroscopy and echo guidance. And the valve, the intrepid valve, is slowly extruded in the mitral position. And here is the final fluoroscopic image demonstrating well-positioned device, which is confirmed by echocardiogram. In the next slide. So here's the echo image of the intrepid valve, resulting in resolution of mitral regurgitation, and a nice 3D image and fast view from the left atrium of the intrepid valve implanted successfully in this patient who's doing very well. Here's the color Doppler, again demonstrating no residual mitral regurgitation and acceptable mitral valve gradient. The Apollo study also has a transfemoral early feasibility study that is ongoing, which is evaluating the same valve via transseptal transfemoral approach. And there's a lot of excitement in the field regarding this approach because this avoids transapical access, and transseptal transfemoral is obviously less invasive. There are other devices such as the Alta valve, which consists of a large spherical nitinol ball with a supraannular valve that can be implanted via transapical and now also transseptal access. We published this case last year, the first in the United States, and we are enrolling in the early feasibility study currently in the United States. There are other approaches for TMVR with the TAVR transcatheter heart valve system, the SAPIEN valve, and we have done transcatheter mitral valve replacement for failed prosthetic rings or failed prosthetic valves, and even in cases with severe mitral annular calcification. And there is growing data to suggest safety and efficacy in these carefully selected patients, of course, with suitable anatomy. As you can see, this can be performed via transseptal access into the mitral position. Here is an example of transcatheter mitral valve replacement in a patient with severe mitral annular calcification. Of note, this patient has had TAVR previously, and transcatheter mitral valve replacement was successfully performed in this high surgical risk patient with a good result. So there are various approaches for transcatheter mitral valve replacement, and multimodality imaging really plays a key role in suitability, assessing suitability for these patients. Lastly, paravalvular leak closure is another tool in our armamentarium where we can put plugs in patients who have paravalvular leak after surgical or now transcatheter valve replacements. This is an example where patient had surgical valve several years ago and now presented with severe paravalvular leak and hemolysis. And with the help of fusion imaging, transesophageal echo, and fluoro, we were able to place plugs with resultant resolution of the paravalvular leak, as you can see in this image. So in conclusion, transcatheter mitral valve interventions are a therapeutic breakthrough, providing treatment options for high or prohibitive surgical risk patients. MitraClip or transcatheter edge-to-edge repair is a good option for prohibitive and high surgical risk patients with degenerative or primary MR, and also for optimally medically managed patients with FMR who continue to be symptomatic and have severe MR. Multimodality imaging is key for patient selection. Echo, CT, and MRI are used for pre-procedural assessment. Echo and fluoroscopy, of course, are key for intra-procedural guidance, and fusion imaging has potential role. Transcatheter mitral valve replacement is, of course, the next horizon and is being studied actively and has a huge potential role over the next few years. Thank you very much for your attention.
Thank you very much, Dr. Goel, for this very nice overview of what's going on in the mitral world from a transcatheter perspective. There is still a role for surgery, and I think Dr. Lowry, who needs no introduction, will be addressing this. Dr. Gerald Lowry is professor of surgery, cardiovascular surgery here at Houston Methodist, and certainly has contributed so much for the area of mitral valve repair and other valve surgery, and he will be addressing that question. What about cardiac surgery for valves? Dr. Lowry.
I've been asked to talk about what about cardiac surgery for valves. The real issue is what to do in 2021. There are many changes. In terms of general comments, the main issues we confront are the indications for intervention and the types of valve therapy, whether surgical or catheter. The 220 ACC, American Heart Association guidelines provide valuable authoritative information regarding optimal diagnosis, the role of medical therapy, the timing and nature of interventions. Very important document. The indications for the selection of catheter therapy over conventional therapy relate historically to patients at high risk or who were considered inoperable for conventional heart valve disease. And this can be calculated by the SDS calculator. And this risk relates primarily to the condition of the patient, advanced age, poor health, frailty, and comorbidities, or procedure-related, such as extensive disease, multiple previous surgeries, technically complex surgeries, or calcification of cardiac structures. There are aspects to the selection of catheter therapy we need to be aware of. Catheter therapy effectiveness has been shown in most randomized controlled trials to be non-inferior, not necessarily superior for most major outcomes. The main advantage has been the fact that there's no major incision. Like surgery, they all have pros and cons, but many of these have not yet been fully documented because of the lack of time since their introduction. However, patient interest is high because of no surgical incisions. Thus, the evolution of the heart valve team concept and its use is very important in the evaluation of these patients for these complex decisions as to the appropriate choice of treatment. Living in Texas, we know that small puncture wounds in the lower extremity are not necessarily harmless, and it's hard for patients sometimes to realize that these catheter interventions are still serious modifications to the heart itself. Timing of cardiac valve therapy is critical for optimal results. As we're following the patients, we're looking for the impact of the disease on the patient, which manifests as symptoms. However, regurgitant lesions, particularly such as aortic insufficiency or mitral regurgitation, the symptoms may occur too late to preserve ventricular function. So the other aspect, which has become increasingly important, is to monitor the impact of the disease on the heart itself by echo, cardiac MRI, cardiac CTA, and conventional cardiac catheterization. These landmarks and changes in these outcomes are very important to be familiar with and are found in the guidelines. So we're going to talk about the management of aortic valve disease, mitral valve disease, and tricuspid valve disease, which is the majority of the work we do. There's been an accelerating TAVR revolution in patients over 70 years of age. There's very little data in people under 70 years. There are problems with TAVR, which relate to the fact it can only deliver a tissue valve, only suitable for calcific AS, not suitable for aortic insufficiency. Status of bicuspid valve yet to be determined by randomized trial in progress. Pacemakers needed in up to 10 to 30% of people post-procedure. This can lead to late congestive heart failure in chronic pacing. Serious vascular complications, 10 to 15%. Periprosthetic leaks, 10 to 20%. Only 5 to 10% of these tend to be significant, but it can be difficult to quantify. Unknown durability beyond 5 years. Stroke risks similar to surgery, but may be more diffuse in TAVR and could possibly give rise to late dementia. This is yet to be established. Patient selection in randomized controlled trials was the subject of an editorial by Otto in the New England Journal of Medicine. She points out that no bicuspid valves are included. Nearly 50% of surgeries for bicuspid valve. We are awaiting the RCT results. Patients more selected with suitable aortic valve, coronary, and peripheral vascular anatomy. Very severe underrepresentation of female patients, possibly because of their anatomy with small annuli, poor vascular access. Also inappropriate referral base, as females tend to have a higher incidence of low flow, low gradient aortic stenosis. The issue of increased risk of stroke in bicuspid aortic valve, TAVR, was addressed just last year, and substantially higher stroke burden on MRI in TAVR patients with bicuspid valve compared with tricuspid. Now, to get a a very comprehensive all-comers view of the outcomes of TAVR. We have the RESPIVA study published in 2021, 2,000 patients from Italy, comparing 5 different prostheses. And we can see here at 1 year, including the implant period, mortality similar, about 12 to 14%. Overall risk of stroke, 2 to 3%. Very low risk of myocardial infarction. Major bleeding, mainly peri-procedural, was in the range of 3 to 5%. And major vascular complications primarily related to catheter injuries in the range of 10 to 15%. Need for surgical valve conversion or valve-in-valve very low. This is a major problem. The pacemaker need in 15 to 30%, especially in younger people. This has serious long-term consequences in terms of congestive heart failure. So overall, major adverse events, 20 to 25%. So TAVR, even though catheter-based, still is a major serious procedure. More recent data regarding reoperation for TAVR when valve-in-valve is not suitable shows very significant morbidity and mortality because some of these patients require major complex procedures, including root replacement. The indications for surgical aortic valve replacement are suitable anatomy after the complete evaluation of the patient by the heart team and a recommendation for surgical AVR. Coexistent severe coronary artery disease, probably better treated by CAB at the time of a surgical valve replacement. Multiple disease valves can be staged with TAVR, but often better operated on in younger patients. Ascending aortic aneurysm coexists with bicuspid valves and may require treatment. Young age, still very little data on TAVR, long-term results in patients under 60 years of age. There may be a need or a preference for a mechanical valve, and of course, patient preference always has to be factored into the choice of therapy. Age is really not a major consideration. If we have a healthy elderly patient, they may be good candidates for surgery. As age, as shown here from a personal series of 3,000 patients, age has little impact on surgical mortality with surgical procedures. So now moving to mitral valve disease, there has been no revolution yet, but many percutaneous options are in progress. The options we have for treatment of mitral valve disease include medical therapy, which has a very limited role in mitral regurgitation, and it has no effect whatsoever on the progression of the mitral regurgitation. Surgical mitral repair is still the optimal therapy for primary MR when feasible. Mitral valve repair techniques are not static. We've had an extensive program of research at Houston Methodist on the American correction, and this has led to superior results. Primary MR medical treatment may give Lasix to sick people to make them feel better, but no benefit to vasodilators in terms of the natural history. Catheter-based mitral therapies can be edge-to-edge repair, indirect annuloplasty, direct annuloplasty, direct chordal replacement through the apex, or transcatheter replacement. Recent data, just published online, consequences of failed MitraClip, a study of 177 patients from the STS database. When these people were sent for surgery, the mortality rate was 6.3%, and the mitral repair rate was only 6.8%. So the authors concluded that surgical mitral repair is rarely achieved after failed transcatheter edge-to-edge mitral repair. They suggest caution in using MitraClip in good surgical candidates. Our own result in surgical candidates is 0.5% mortality with a repair rate of 100%. Now, the timing is really critical in mitral valve surgery. We want to see these patients with moderate to severe or severe MR while asymptomatic, class 1 or 2. Onset of symptoms is an indication for urgent evaluation, as is the onset of atrial fibrillation. Left ventricular ejection fraction should be 60% or above, and systolic dimension 3.5 to 4 centimeters. and no significant pulmonary hypertension. The guidelines point out it's important to find a center with 95% pair rate, but I would also point out that check the individual surgeon, find out his or her annual volume, mortality, repair rate, and the techniques employed, modern techniques versus older, less satisfactory traditional approaches. The STS database in 2018 showed that nationally only 65% of mitral valves were being repaired, and in the degenerative group, 82%. So this is a very low repair rate. This is a paper that's in press in the Annals of Thoracic Surgery documenting our experience in 1,000 consecutive patients with 10 to 15-year follow-up, 100% repairability. And at the 10 to 15-year mark, we have 95% freedom from significant MR, reoperation, or need for a prosthetic valve. Again, as with aortic valve surgery, mitral surgery, very safe operation and very little affected by age. So age alone should not be used as a consideration for some interventional procedure. This is another type of patient who has severe mitral regurgitation secondary to systolic anterior motion. And this is secondary to a hypertrophic subaortic stenosis from HOCM. And this has been cured here completely by extensive resection of the hypertroph. I'm pleased to report that Houston Methodist Hospital is a designated center of excellence for the Hypertrophic Cardiomyopathy Association. So management of tricuspid valve disease. Tricuspid valve surgery has had a very bad reputation because of high mortality figures in the literature. This review of 50,000 patients from the STS database showed a surgical mortality of 8.2%. But if you look carefully at the risk factors for mortality here, you can see a litany of very severe comorbidities present in many of these patients at the time they presented to surgery. Whereas for patients who are undergoing routine tricuspid valve repair during, for example, a mitral valve surgery, there's very little risk. So I looked up a review from several years ago of 223 tricuspid valve surgery I had performed, and mostly primary, with some, about a third of the group had a redo surgery. Most rate would be repaired. And the perioperative mortality was 3.4% for primary tricuspid and 6.1% for redo chest surgery. We've emphasized to our cardiologists to refer these people earlier at the onset of drug refractory symptoms. The high mortality late is often a result of excessively long medical therapy. We often bring these people in for a week to 10 days of medical stabilization in the hospital, and we become more aggressive about intraoperative treatment of tricuspid regurgitation at the time of primary surgeries. For further information on these topics, which we've been able to touch on briefly here, please go to YouTube, Gerald Laurie, MD, mitral valve. There are surgical videos and 1-hour review lectures. Thank you.
Thank you very much, Dr. Lowry. Nice overview of surgery in valvular heart disease, certainly very needed. And let me tell you, seeing both of our surgeons there, we need to make sure that we still have great surgeons going forward, because your services are needed. And yes, transcatheter techniques are very important and great for patients, but surgical perspectives are still very important. So we have few minutes to carry some discussion here and question and answer from the audience. I will point out again to the audience that through the web, you can go to paulev.com and enter DeBakey and ask your question, or by texting. So you can text DeBakey to 37607. We have a couple of questions here. The first one is about bicuspid aortic valve, and probably for you, Michael. Great presentation. It is relatively common. And a couple of questions on it. One, The importance of assessing the aorta itself, aortic root and aorta in bicuspid valve disease, and when do you refer such to a surgeon in general? So that's one. Two, I will probably answer that question. This is regarding echocardiography measurement compared to CT. I mean, echo may underestimate the LVOT diameter because of the elliptical portion. So for you, Michael, is one, when do you feel comfortable at this time sending somebody with a bicuspid aortic valve to TAVR? And when should you refer somebody to a surgical opinion? Talking about aortic root and ascending aorta issues in bicuspid disease.
Well, assuming that the patient is a reasonable TAVR candidate based on age and your perceived risk, you start looking at what are the anatomic risk of doing a bicuspid valve. So, if your ascending aorta is 4.5 or bigger, you've met the guidelines to have your ascending aorta replaced. And if you're a surgical candidate, you should get your valve replaced and your ascending aorta replaced. If you have a calcified raphe and an opposite leaflet that's very calcified, you're not going to do well with TAVR. So unless you're just a really poor surgical candidate, you should probably go to surgery. And Gerald and I all the time see these people that have this calcium that drips down off the non-coronary cusp onto the anterior leaf of the mitral valve and often protrudes several millimeters into the lumen of the LVOT. This is very easily handled with surgery, and it's not very easily handled with a TAVR valve because of the ability to seal the valve in there. So you really have to look at the anatomy and ask yourself, is this patient going to do okay with a TAVR for the bicuspid valve? We still recommend a fair number of these go and have surgery.
That's great. Well, Dr. Goel, on the go. I can see you on the go today, this morning. A question to you. TMVR in mitral annular calcification cases can be done, but in what % of patients is the procedure actually successful? And maybe broaden the question to who would you choose, to do something like it? And is this a TMVR or is this, another approach?
That's a great question, Dr. Zoghbi. MAC patients are, one of the highest risk patients. Not only from an anatomical aspect, but also from the comorbidities from their baseline situation. And these are the highest of the highest risk patients from a TMVR standpoint. When we look at the cumulative data over the last several years from the STS-TVT registry, looking at transcatheter mitral valve replacement, for instance, with the SAPIEN valve, looking at different cohorts of patients, say for instance, valve and valve, or valve and ring, or failing prosthetic surgical valves or failing rings, and then comparing it with valve and MAC patients. The mortality appears to be the highest with the valve and MAC patients, and also the risk of LVOT obstruction, which is sort of the Achilles heel of TMVR technology, appears to be the highest with valve and MAC cases. But we are learning more and more about the anatomy, more and more about the neo-LVOT, and how to predict the risk and mitigate the risk. There are, adjunctive strategies such as alcohol septal ablation or intentional laceration of the anterior leaflet of the mitral valve using a lampoon technique, which in selected patients can reduce the risk of LVOT obstruction. So, this is a field of growing interest, and we are all learning, and now we have dedicated TMVR systems such as the ones from Medtronic as well as Abbott that have their pivotal trials which are ongoing, and they both have dedicated MAC arms, and we are going to find out more about these patients in the next few years.
Gerald, along these lines of mitral annular calcification, severe calcifications, could be MS, it could be MR. Challenges to the surgeons, are they some individuals that you prefer not even to touch? I mean, I know obviously there are a lot of other comorbidities, but how do you handle it at surgery? Is there any decalcifications that you use, or how do you deal with those?
Yes, Bill. There are a lot of techniques that the first thing is to recognize the very broad array of things covered under the term mitral annular calcification. Mitral regurgitant mitral annular calcification is generally easier to deal with than mitral stenosis annular calcification, because that calcium that's has grown down those leaflets from the annulus, so you tend to have a lot more calcium around. The posterior leaflet insufficiency from mitral annulus calcification is actually very simple to take care of. And it's also very important to differentiate on the imaging between leaflet calcification that has been misinterpreted as annular calcification. It's not uncommon to get into the operating room and occasionally find that you resect the leaflet and the annulus isn't bad. The main technique for dealing with a severely calcified mitral annulus is a piecemeal nibbling away at the annulus until you come to the fibrous intersection between the calcified tissue and the heart. And sometimes we have to use Dacron patches to reconstruct. But in general, the mortality, and this is something for an experienced surgeon, this is not something that an occasional cardiac surgeon should be doing. But in experienced hands, most centers have major centers have a mortality of 3 to 4%. So the majority of these people can be managed very well, but the mitral stenosis people tend to be the worst, and they tend to actually occur more commonly in the very elderly, which is just one more problem. Dr. Guerrero has published at the Mayo Clinic, published her recent experience with catheter management of mitral annular calcification, and the mortality in some of her groups was up to 20 to 30%. So I think the catheter approach, much as we would like it, not to have to deal with these people, is not yet arrived.
Well, I think these are very important, points, and at the same time, also, I think for our audience, just like you mentioned it towards the end, Gerald, in your talk, is know your environment. And, these surgeries usually are not emergent surgeries, and look around. Hopefully, you have a surgeon that has a great, expertise and experience with it. And if you don't, I think refer it to a center of excellence where people can use this for your patients. So that's the beauty of valvular heart disease. It's not usually an emergent kind of situation, and things can be planned for your patients wherever you are. So I think that's an important message, for us, for the the students and the healthcare professionals to think about that and get the best care for your patients. Be it locally or regionally or even nationally, whichever way you want to advocate for your patients. I think with that, I want to thank you all for really amazing talks today, focusing on valvular heart disease from catheter-based to surgical approaches, and thinking as a team approach, because that's how we do it here, and many great centers also do it. It's a team approach of interventionalists, imagers, as well as certainly surgeons to take a look at that. So thanks again for amazing talks. I'd like to invite our audience to take a look at the exhibits, take a little break. We'll take a break for about 15 minutes and resume at 1:30. Thanks again.
Good afternoon and welcome back. The morning session was absolutely scintillating and I enjoyed it. I hope you all enjoyed it as well. We're going to go into afternoon session. The first session is going to be on ischemic heart disease and its therapies. Again, I'm Dr. Alpesh Shah. I'm an interventional cardiologist here at Houston Methodist Hospital. Just to remind one more time, please join us by web. We strongly encourage any questions you may have. This is the time. And go to pollev, pollev.com. Then you enter DeBakey, DeBakey, and that will allow you to ask your questions. But also you can join by text. You can text DeBakey to 37607 and then text in your message, and we welcome any questions. So I'll start off my presentation and I'll talk about stents. As you all know, that's kind of the backbone of interventional cardiology. We all talk about it. So how did we come here? So first we start with coronary balloon angioplasty. You guys may have heard of this word called POBA. A lot of times patients and colleagues would ask us, what exactly do you guys do in the artery? Because the concept about expanding the artery is very unfamiliar, so to speak. Because as atheroma is developing, what we do is we push it out with the balloon. And unlike a fixed pipe, a coronary artery is very dilatable, and that allows the plaque to be pushed out and the lumen to be improved. And that was the basic principle of balloon angioplasty. However, there were some issues. We dealt with acute vessel closure and restenosis. So the abrupt closure, about 4 to 8% of those patients, and 20% of them required emergency bypass surgery. Restenosis rates were astronomically high, 30 to 50% of our patients, and then 20 to 30% of those require revascularization rate. And the problem was not only just the elastic recoil, which happened as soon as we take the balloon out, but also the neo-intimal formation. So there was late restenosis in those patients. So to overcome this issue, in 1993 in US, we received bare metal stents. And the restenosis improved to 20 to 30%. And the way this worked, it basically, after you've done the balloon, you would put in a stent, and that will minimize the elastic recoil. However, the problem of neo-intimal formation and neo-atherosclerosis inside the stent, or ISR as we would call it, continued to persist. And because of that, we led to these drug-eluting stents. And that was developed to prevent the cellular response leading to restenosis, and that came to USA in 2003. So not only it did everything what a scaffold would do and minimize the elastic recoil, but more importantly, the drug elution avoided any neo-intimal formation, so restenosis rates dropped. Because of that, we actually have led to revolutionary advances in stent technology. Stent failures have become very uncommon nowadays. Just to give an idea, it has dramatically reduced from 40% down to the low 5% or less than 10% in today's world. Emergency bypass rates have gone down. Restenosis rates, as I described, has gone down. So has stent thrombosis, as well as very late stent thrombosis. So those are very good features. So where do we stand today? Which patients is eligible for stenting, for example? So obviously anybody with a STEMI should always is a class 1 indication, but also non-STEMI and unstable angina. So those are patients who are kind of, hot atherothrombotic patients. But what about patients who have stable angina? Medical therapy is always recommended as a first-line medical therapy in stable ischemic heart disease patients, but angina can be different. It can be dyspnea, arrhythmias. What about high-risk stress test findings, where patients have, less than 4 minutes on a treadmill, for example? And what about asymptomatic patients or mildly symptomatic patients? Again, the objective evidence of a moderate to large area of viable myocardium or moderate severe ischemia on non-invasive testing is an indication for PCI. So our bar goes higher when somebody is asymptomatic or minimally symptomatic. Heart team approach is also strongly recommended in these patients. So I'll start with the question: which of the following patient could reasonably undergo coronary angiography without a non-invasive test suggestive of coronary artery disease? 65-year-old male with typical chest pain, 65-year-old smoker with 20 years of diabetes who complains of chest discomfort, 46-year-old male smoker with unexplained new heart failure, or a 56-year-old diabetic female resuscitated after witnessed cardiac arrest due to ventricular fibrillation? The answer is all of them. You don't really need to do non-invasive testing to recommend a cardiac catheterization or an angiography in such patients. However, the reason we are reluctant to just rush into cardiac catheterization on everyone, because it's an invasive test, and you went through in the morning session about all these varieties of ways where we can assess a person's risk by non-invasive testing, because there are complications. MI, death, stroke, obvious ones, but excess site complications. It obviously is reduced significantly with the radial access programs, but you can more likely have a non-excess site bleeding because a lot of those patients get anticoagulations, antiplatelets, so GI bleeds are can happen. But so can contrast-induced nephropathy, allergic reactions, radiation exposure, perforations, and stent thrombosis. I can go on and on. So this is not something you want to take lightly, but be very careful in whom you want to recommend this particular procedure. So let's get into drug-eluting stents, because that is what the standard of care is today. First and foremost, how do you make a drug-eluting stent? You have to have a stent, the metal, the design, followed by a drug which is going to inhibit the neointimal proliferation, but also a polymer, because that becomes a carrier for the drug to be attached to the metal of the stent. Currently, we have moved on to what are called second generation stents. On the left are the first generation stents, which are not really used much in US at all. OUS, there is still some utility of those. However, the ones on the right, on the right three are the ones which are available currently in USA and have become the standard of care. What you may notice, if you look at this graph very carefully, that the stent design, the metal has basically moved away from stainless steel to more cobalt chromium based devices. The strut thickness has gone down significantly from 140s and 130s to down to the 80 microns. The polymer thickness has gone down. The drug basically has moved on to Olimus group of drugs, and the elution time frame we believe is best at about 3 to 4 months after the stent implantation. However, that being said and done, we still are going into newer technology. Currently, we are also using a stent called Synergy, which actually only has coating on the abluminal side, because that's where the restenosis responses are happening. But also, it is very thin strut, and the data looks fantastic, and that has become another standard of care stent available in the US. We went through a lot of research with absorbed stents. These are bioabsorbable stents. They are made out of poly-L lactic acid backbone, and they are coated with the everolimus drug, just like current drug-eluting stents. It was available in US until a couple of years ago, but now there has been a market recall, so to speak, or withdrawal by the companies, mostly because of stent thrombosis, because the idea of absorb is fantastic, where you basically have a stent which does the drug elution for the first 3 months. That's what we want for prevention of restenosis, but also at about 16 months, 24 months, there is complete resolution of this particular stent. So the human coronary artery literally becomes stent free or scaffold free at this point, and the idea of restoration of vasomotion and other vascular healing probably improves with that. However, stent thrombosis noises was very high, and because of that, we don't have it available in our market today. Now, I'll get to another question. The patient undergoes stress testing and is found to have moderate ischemia in the RCA territory. Because he develops moderate symptoms, on medical therapy, a coronary angiogram is performed. The angiogram shows a 50 to 60% stenosis in the mid-RCA. What would you do? So these are patients who are somewhat symptomatic, has this defect, and has an angiogram 50 to 60%. Well, do nothing. Oh, stress test was probably false positive, or consider stenting. The lesion is because a 50% stenosis can be expected to cause ischemia. Well, is there a better way of assessing them? What about performing an FFR, or even performing an IVUS, intravascular ultrasound? So what is FFR? What is IFR? You guys will come across this many more times, because this has become more sophisticated science, where we are not just looking at the anatomy, not just looking at the lesion severity, but we are also trying to understand the hemodynamic significance of such a lesion. So this is FFR, is basically distal coronary pressure divided by proximal coronary pressure, but it has to be done under during maximal hyperemia, which we achieve by giving patients adenosine infusion or injection. but also IFR can be done without those infusions, and both are validated to show very, very well the hemodynamic nature of that particular lesion, especially the intermediate ones. Because when we studied this data, for example, in the FAME-2 trial, patients with FFR less than 0.80 were randomized to medical therapy versus PCI, and obviously with medical therapy. The primary endpoint was again death, MI, and urgent revascularization, and about 1,220 patients were enrolled. And we found that in the PCI group, these are again FFR guided PCI, 4.3% event rates of primary endpoint versus 12.7% in the medical therapy group alone. So very, very significant finding, and FFR based in PCI kind of has become the gold standard for intermediate lesions, anywhere from 50 to 70% stenosis on a routine angiography. But there's also some other issues. For example, when you do an angiogram, it's kind of a single plane angiogram. However, you can go around the angles. You can create a biplane angiography. However, the problem is that there is a dissociation between clinical as well as angiographic findings in such patients, and sometimes it's hard to say which one is real, because most of the coronary artery disease lesions tend to be eccentric. They are not concentric. So depending on the angle, sometimes you may miss out on the severity, or sometimes even overcall the severity of such lesions. So to understand this better, intravascular imaging has become the standard of care. On the left, you have an image of IVUS. You can see all the three layers of the arterial anatomy. And on the right, you have a picture of OCT, or optical coherence tomography, which also allows us not to look at the intima, but also in this particular picture, you can actually see the stent struts and a neointimal formation of rich stenosis. So a lot of information can be gathered by doing intravascular coronary imaging. There are lots of tools we have, atherectomy, whether it's rotablation or orbital atherectomy. These are used to get eventually the drug-eluting stent down there. These are not standalone therapy, but these are adjunctive therapy for lesion modification and lesion preparation. There are other devices for thrombus aspiration, which we can use in the setting of a large clot burden, for example, in a STEMI or stent thrombosis. And then we have distal embolic protections, which are umbrella-like devices, which will prevent any clot from going downstream when we are doing an SVG or a saphenous vein graft intervention especially. There are some novel techniques to work on our chronically totally occluded coronary arteries. One of them is what is called antegrade dissection and re-entry. So we actually go into the subintimal layer of the artery and re-enter beyond the occluded segment, and then we can put in a stent and push the whole atheroma out. There are also techniques which are used more and more called retrograde PCI, where we would actually go from the LAD and via the septals, go to the RCA, which is occluded, and do a retrograde recanalization, especially in cases where there is chronic total occlusions. A question. The patient continues to do well after a stent at 6 months follow-up. He remains compliant with all his medications, but remains concerned about bleeding from Plavix. What's the recommendation for how long should the DAPT be given? This is one of the commonest questions I get as an interventional cardiologist. 1 month, 3 months, 6 months, 12 months. Well, this is a big diagram. I encourage all of you to look at it. All the ones in the green box are basically class 1, and the yellow ones are class 2A. Anybody who gets an ACS, doesn't matter what kind of stent they've gotten, they have to get 12 months of DAPT. Anybody who is getting stable ischemic heart disease stents, if it's drug-eluting, it should be 6 months. If it is bare metal, which by the way has become very rare to use nowadays, can be limited up to 1 month. And this is exactly just emphasizes that very point. But again, anyone with ACS, the answer is always 12 months, but non-ACS can be reduced to 6 months on drug-eluting stents. This leads to the appropriateness criteria for key variables. Every patient you go to the cath lab or who gets a stent should have very good indications. So we have developed this appropriate criteria, whether it goes from stable angina to STEMI, or Canadian classification of 1 to 4, or high risk for coronary medical features, and obviously anti-anginal medications, and multivessel coronary artery disease or high risk coronary features. And the more features you have of this, it becomes more appropriate rather than not. Ischemia was a trial which came out or a year and a half ago, and that basically randomized patients with stable ischemic heart disease. They put them on a stress test. These are not very symptomatic patients, and once the stress test was abnormal, they followed them with a CAT scan, and once high-risk anatomy was excluded, they were randomized to medical therapy or medical therapy with revascularization. And the ischemia primary outcome at 4 years basically showed that there was no significant difference in choosing medical therapy over revascularization strategy. However, there was a slight benefit of medical therapy upfront and slight benefit of revascularization down the road. But at 4 years, again, the outcomes, death, MI, hospitalization for unstable angina, heart failure, or resuscitation from cardiac arrest remained unchanged. However, interestingly, quality of life indicators did show that revascularization does improve angina. So what we have learned from ischemia trial, first of all, in patients with stable CAD and moderate to severe ischemia with preserved LVEF, a routine invasive strategy compared with an initial conservative approach does not reduce mortality. A routine invasive strategy does reduce the occurrence of late MIs, although at the cost of procedural MIs. As such, there is no long-term impact of total MI death or MI or protocol-defined MACE, hospitalization, unstable angina, heart failure, or resuscitated cardiac arrest. Patients with stable CAD and moderate to severe ischemia have a significant durable improvement in angina control and quality of life with an invasive strategy if they have angina. Thank you, and that concludes my part of the presentation. And we will continue on this route of ischemia, ischemic heart disease and evolving therapies. And my next speaker is Dr. Ross Rule. Dr. Rule is one of our cardiac surgeons who is a pioneer in cardiac surgery, especially coronary artery bypass surgery. He's a big proponent of arterial conduits, and I would like Dr. Rule to give his talk.
Good afternoon. I'm going to talk to you today about surgical revascularization with coronary artery bypass grafting, which is the most widely studied surgical procedure in the world. I have no disclosures pertaining to this topic. We all know the risk factors for coronary artery disease, and it is important to also recognize how these same medical conditions can contribute to selecting the most appropriate therapies to treat coronary artery disease. The same risk factors for development of native CAD can also affect the long-term success rates of coronary artery bypass grafts. This is the only bacon cheeseburger that actually comes with a warning label. Some definitions and abbreviations I will use are included here. Conduit refers to any bypass graft. The terms LIMA and LITA for left internal mammary artery and left internal thoracic artery are used interchangeably. Patent refers to open and describes a functioning bypass conduit. Patency is the rate at which the bypass graft stays open. The goals for treating CAD include prevention and early detection of CAD, relieving angina, and preventing myocardial infarction when patients have CAD, and most importantly, prolonging survival and improving quality of life. The most commonly used treatment options for CAD include medical management, percutaneous coronary intervention, and coronary artery bypass grafting. So which treatment option is better? Clinical trials and registry data have contributed greatly to our knowledge of outcomes for subsets of patients and enhanced patient selection, but no trial nor meta-analysis has been sufficient to declare an overall winner. Early randomized controlled trials compared CABG to PCI were plagued with selection bias for their designs. Most excluded CABG favorable patients, enrolling a high percentage of 1 and 2 vessel disease, few diabetics, and few patients with low ejection fractions. Only 2 to 12% of patients recruited actually reached randomization. More recent randomized trials included more complex patients, but still required anatomic criteria to allow either safe stenting or surgery. With evolving therapies, by the time the outcomes were reported, newer generation stents and antiplatelet therapies were available for PCI, and multi-arterial grafting was more utilized for CABG. Despite these inherent flaws, several randomized trials and registries and meta-analyses have favored CABG outcomes over PCI. The Syntax trial compared outcomes of CABG versus PCI in patients with 3-vessel disease or left main stenosis. A heart team, including surgeons and cardiologists, was used to determine equivalent anatomic revascularization abilities for the patients. A Syntax score based on the degree of complexity of CAD was assigned to the patient by preoperative evaluation. While the subset groupings were not in the original design of the trial, The concept has been validated in several subsequent trials and registry data. At 5-year follow-up, the patients with greater complexity CAD had improved outcomes with CABG versus PCI in terms of major adverse cardiac events, all-cause death, myocardial infarction, and repeat revascularization. There was no significant difference in these events in patients with lower complexity scores. While these and many other trials have inherent criticisms, we can elicit some evidence-based criteria for CABG favorable or PCI favorable characteristics that help us to guide patient selection criteria to use the most appropriate therapies. Over the past several decades, CABG has become safer with improved observed mortality rates despite an ever-increased expected mortality rates as the patient population increases in age and medical comorbidities. The observed mortality rate for first-time CABG in the STS database is now 1 to 2%. So how do we take an incredibly safe and effective operation and make it better? Patient selection is critical. After the Syntax trial, the importance of the input of a multidisciplinary heart team evaluation has become accepted enough to be included in both the American and the European guidelines with a Class 1 recommendation. Here at Houston Methodist Hospital, we use the heart team concept extensively with multidisciplinary evaluations by multiple CV surgeons and interventional and non-interventional cardiologists to combine our experience and judgment and dilute our inherent biases for complex heart disease patient decisions. We use evidence-based protocols to promote medical optimization of patients preoperatively, involving our nephrology, endocrinology, hematology, and pulmonary colleagues when appropriate. We can also enhance the effectiveness of our operation by evolving strategies to improve long-term graft patency. Patient selection includes providing the appropriate evaluation of coronary artery disease and the indication to intervene. Evolving techniques for functional evaluation of lesions, such as FFR and IFR, offer information to avoid treating the picture, especially in moderate degrees of stenosis. One of the benefits of coronary artery bypass grafting is the opportunity to provide complete revascularization. Here you can see a heart with bypasses to the LAD, the diagonal, the OM1, the OM2, and the posterior descending artery. But the CABG operation is only as effective as the long-term patency of the bypass grafts. In the early days, before the universal utilization of internal mammary artery conduits, the attrition rate of the saphenous vein grafts was paralleled by a declining event-free survival rate. Vein graft patency depends on multiple factors. 1-year patency rates are 80 to 85% with vein grafts. Early graft failure is usually due to vein or target vessel quality problems, technical problems, or graft thrombosis. Vein graft failures after 5 years are often due to accelerated atherosclerosis that can be secondary to early intimal injury. By 10 years, most vein grafts have developed significant atherosclerosis mediated by the same risk factors that cause CAD, with 60 to 70% patency rates at 10 years. We can improve graft patency of veins with careful harvesting techniques that are unfortunately often overlooked, leading to neointimal hyperplasia and injury. Using only the best portion of the veins and improving outflow and size matching can also enhance the vein graft patency. Some vein grafts are destined to fail, and we should always have a plan B, C, and D available. Multiple studies have shown improved survival and quality of life when the left internal mammary artery is used as opposed to just vein grafts. The Lima to LAD bypass promotes survival and quality of life long after the operation, even when the vein grafts have failed. Long-term patency of the left internal mammary artery has been shown in angiographic follow-up studies to be 90 to 95%, far superior to the patency rate of other vein grafts. The Lima to LAD is used in about 90% of CABG cases, and the use of the Lima has become a carefully scrutinized quality measure. The IMA is biologically different from other arterial conduits and vein grafts. The muscular media is thin and less muscular, leading to less spasm and a lower proliferative response to mitogens. The higher basal and stimulated rate of nitric oxide production also persists long after surgery. The lima has a non-fenestrated internal elastic lamina, which inhibits cellular migration, thus preventing intimal hyperplasia. So if one IMA is good, two must be better. Several studies have shown improved survival with bilateral IMA versus single IMA. The RIMA has the same biological characteristics as the lima. The patency of the RIMA to the LAD is similar to the patency of the lima to LAD, but the overall patency rate of the RIMA is slightly lower because the RIMA is often used to bypass secondary non-LAD targets. While the patency rates of the RIMA are higher than vein grafts overall, the patency rates are similar when used to bypass the RCA. This study shows improved survival with bilateral IMAs versus single IMA at 20 to 30 years. Unfortunately, multiple arterial conduits are underutilized, but this gives us an opportunity to improve on an already excellent result of CABG. In the Syntax trial, even with very experienced coronary surgeons, only 35% of the patients had CABG with a second conduit. In the US arm of the Syntax trial, only 17% of the CABG patients enrolled actually had a second arterial conduit. Even worse, in the STS database, real-world patients only had a second arterial conduit in 6.7% of CABGs performed between 2010 and 2013. Careful consideration of the proper conduit for each target vessel is required, and patient characteristics play a role. This study showed far poorer patency rates when the RIMA was used to bypass the RCA than when the RIMA was used to bypass the LAD. Often, the RIMA is not long enough to reach the PDA, and when the RIMA is used in situ, it may be put on tension. The flow characteristics of the RCA may also contribute to graft failure. Long-term RIMA patency is affected by the target vessel bypassed and the degree of proximal stenosis. Left-sided coronary targets in general have better outcomes than right-sided targets, and higher degrees of proximal target artery stenoses avoid competitive flow with better outcomes. This study showed excellent 10-year patency rates of the RIMA, whether used in situ or as a free graft. Patency rates were similar between LIMA and RIMA grafts when used to bypass either the LAD or circumflex targets. Patient selection for bilateral IMA use is critical. Insulin-dependent diabetic patients are significantly more likely to have sternal wound complications after bilateral IMA harvesting than after single IMA harvesting. This danger can be mitigated by harvesting both IMAs with a skeletonized technique to avoid injury to the sternum. Bilateral IMAs should be selected when there is an adequate secondary coronary target with good runoff and a proximal stenosis of greater than 70%. The RIMA is best used for left-sided targets and can be used in situ if it can reach the target without tension as a free graft with inflow from the proximal lima or as a free graft with inflow from the proximal ascending aorta. This is the angiogram of a 50-year-old male with severe left main stenosis. This operation was performed off pump with a lima to the LAD and the skeletonized free RIMA with inflow from the lima. You can see excellent flow through the graft. The RIMA was used to bypass the distal OM with excellent flow in both conduits. The radial artery can be used as a second or third arterial conduit with its inflow from the aorta directly or from the lima. The radial artery has a thicker, smooth muscle layer, and that makes it more prone to spasm than the IMA. Nitrates or calcium channel blockers are given in the operation and postoperatively to avoid spasm long term. The radial artery is prone to spasm with competitive flow, so it should only be used to bypass arteries with a 90% or greater proximal stenosis. To enhance long-term graft patency and the effectiveness of CABG, we carefully consider the appropriate conduit for each target vessel, taking into consideration the patient characteristics. My CABG conduit strategy currently involves using the lima in much greater than 99% of cases. I add the RIMA in non-insulin dependent, non-morbidly obese patients with a good secondary left-sided target. I use bilateral IMAs in greater than 40% of CABG cases currently. I will use the radial artery for an adequate target with greater than 90% proximal stenosis if the patient has an intact palmar arch and no other good conduit available. I use saphenous vein grafts as needed for complete revascularization. In conclusion, the best is getting better. CABG is the gold standard for treating most patients with complex multivessel or left main coronary artery disease. CABG can be performed safely despite an older, sicker, more complex patient population. The appropriate patient selection for each treatment option and clinical optimization before surgery will improve the outcomes. The optimum bypass conduit strategies must be selected appropriately and individualized to each patient and each target. LIMA-TEL-ID is the primary choice for most patients, and the use of secondary arterial conduits can and will optimize outcomes in properly selected cases. I thank you very much for your attention, and please enjoy the rest of the conference.
Thank you, Dr. Rule. Just to remind everyone, again, please join by web and ask questions on polev.com by entering DeBakey, or also join by text. Text DeBakey to 37607 and ask your questions there. Our next speaker is Dr. Neil Kleiman. Dr. Neil Kleiman is an interventional cardiologist and is the director of the cardiac cath lab here at Houston Methodist Hospital. He is passionate about platelets, and he's going to talk to us about antiplatelet therapy. Dr. Kleiman.
Hi, I'm Neil Kleiman, and I'm going to discuss with you in the next 15 minutes antiplatelet therapy, which meds and how long. I have no conflicts, and I confess or disclose that I do not know the answer to the question. But on the other hand, neither does anyone else. Many people think they know the answer. The problem is no one agrees on what it is. If we look at something as simple as the duration of DAPT optimally, the debate goes on and on. 2 years, then 3 years, now 5 years. We're still debating. In a 5-year period, on a simple question, there were approximately 20 randomized controlled trials, probably more by now. 192 meta-analyses of short versus long-term DAPT published in this 5-year period. They're not all concordant. In fact, they aren't even close. And among those of us in the know, it's very easy to lose count. So, in terms of our quest for the Holy Grail, we have not found a medication that prevents clotting and doesn't cause bleeding. So everything I'm going to tell you concerns the balance between pathologic clotting and pathologic bleeding. Let's start with aspirin. The drug's 120 years old. We still don't know the optimal dose. Is it 80 milligrams? Is it 650 milligrams? The mechanism was worked out in the 1970s by Roth and Majerus, and very simply, as you probably know, this involves permanent acetylation of serine 529 on the enzyme prostaglandin GH synthase, also known as cyclooxygenase, which prevents the formation of the prothrombotic compound thromboxane A2. Aspirin's antithrombotic effect is saturable at low doses, so giving more aspirin doesn't mean more antithrombotic effect. In the 1980s, the role of aspirin in the treatment of patients with unstable angina was pretty clearly cemented by a number of pivotal trials. So here are the clinical data at the doses that were studied. For acute MI, 162 milligrams a day prevented 40 major vascular events per 1,000 patients treated. For acute ischemic stroke, 160 to 300 milligrams per day prevented 9 deaths and 7 poor recoveries. For secondary prevention, the number was lower, 10 to 15 events per 1,000 high-risk patients treated, while for primary prevention, the number needed to treat was less than the number needed to harm, meaning no benefit, probably harmful to give patients aspirin at low risk. If you graph things out, this is what they look like. I've plotted, or rather Dr. Patrono has plotted the annual risk of a serious vascular event versus the number of vascular events avoided per 1,000 treated with aspirin. And as you see, secondary prevention's over here, lots more events prevented than bleeding, shown by this virtually straight line. Down at this end, we're talking primary prevention, low event rates, a very similar bleeding rate. The number needed to harm is greater than the number needed to treat. These two vertical lines represent the inflection points. So primary prevention is down here. You harm more patients than you treat. Secondary prevention's up here. You help more patients than you harm. Somewhere in the middle, 2021, patients with high calcium scores probably fall into this region. There's more to come about aspirin, but first let's talk about the ADP receptor. In fact, we learned 15 years ago that there is no the ADP receptor. On human platelets, there are 3 of them. All of the action, though, from a clinical standpoint has thus far been shown on your far left, the receptor known as P2Y12, which is responsible for platelet activation and aggregation. It is the target of the active metabolites of clopidogrel, ticlopidine, and prasugrel, and the target of the drug ticagrelor, or Brilinta. If you're not a cardiologist, these are the P2Y12 antagonists you'll use: clopidogrel, prasugrel, and ticagrelor. Clopidogrel and prasugrel are prodrugs. They're given orally. They're a member of the phenylpyridine class. Ticagrelor is an active drug. It also is given orally. It's a member of the CPTP class. We will not quiz you on the formal name. Clopidogrel, the most commonly used P2Y12 antagonist, is a prodrug. It's activated by 2-stage oxidation by hepatic cytochromes. The activation functionally is bottlenecked in the liver and is subject to a variety of polymorphisms of the cytochrome enzymes. Thus, there's a lot of biologic variability you'll hear about. Because it's bottlenecked, overdose with clopidogrel is physiologically impossible. If you take too many, you won't bleed more. Here are the dose activity data. 75 milligrams peaks in 24 hours. 300 milligrams takes 6 hours to peak. 600, 2 hours to peak, and that's probably the max. 900 milligrams takes about the same time period. Absorption of clopidogrel is questionable in patients with acute MI. What about prasugrel and ticagrelor, the newer drugs? They're 3rd generation P2Y12 antagonists. They have more potent antiplatelet effects than clopidogrel and considerably less biologic variability. They're more effective than clopidogrel in clinical trials of acute coronary syndromes. In fact, they're indicated only during and following acute coronary syndromes and high-risk ACS at that. Prasugrel is indicated only following PCI for high-risk ACS, while ticagrelor is indicated for all high-risk ACS and can be started upstream. It's not indicated for PCI in stable coronary artery disease based on the Alpheus trial, and its upstream indication is now coming into question based on a trial interestingly known as Dubious and based on the Swedish SCAR registry. Here's where clopidogrel, actually ticlopidine and then clopidogrel, became well loved in cardiology, the beginning of dual antiplatelet therapy, or DAPT. 4 randomized clinical trials in patients getting stents, a variety of antithrombotic regimens tested. The bottom line is the regimens containing aspirin and ticlopidine far and away caused less bleeding and less ischemia and were considerably easier to administer than all the other regimens. And then over on the right is the Classics trial, which showed similar outcomes for clopidogrel, which is much better tolerated than ticlopidine. And in fact, that's how stent use began. This is our experience at the Houston Methodist Hospital. We were at about 10% stent use. Then in the spring of '93, the ticlopidine data were first presented. The use of stents took off. We're now talking 98% of PCIs in 2021. Interestingly, all the way over here are when the data were finally published in a peer-reviewed journal. As we've since moved on to drug-eluting stents, been through a lot. We've learned that far and away the strongest predictor of acute stent thrombosis is premature discontinuation of antiplatelet therapy. And we've since learned that if there is disruption of therapy, that is, patient stops it without medical advice or has to stop it because of bleeding, that's the highest risk group. So hence the debate about duration of dual antiplatelet therapy. So where are we now? Well, it gets interesting. These are the current guidelines, AHA, ACC, most recent focused update. Basically, the algorithm is based on the balance between bleeding risk and thrombotic risk. What you can see is patients with stable ischemic heart disease. Drug-eluting stents require a minimum of 6 months of dual antiplatelet therapy. Bare metal stents, 1 month. Shorter durations may be acceptable, as indicated by the asterisks, in patients at high bleeding risk, assuming their thrombotic risk is okay. At that time, it's acceptable to move from dual to single antiplatelet therapy. The European guidelines a year later are very similar. In fact, they're almost identical. Again, distinctions are made based on bleeding risk. Intuitively, this makes perfect sense, until, of course, they're spoiled by the data. And here are the data. These are data from the Paris registry. And if you look at patients at low bleeding risk and high thrombotic risk, or high bleeding risk and low thrombotic risk, the groups we like to target specifically with tailored medicine, well, really simply, there are very few such patients, fewer than 7% of patients undergoing stent. Most patients at risk for thrombosis are also at risk for bleeding. So it's not so simple. But here's, of course, where the fun begins. We've been wedded to dual antiplatelet therapy since 1993, and our 120th anniversary with aspirin was this year. Aspirin's been in our cardiology blood since the early 1970s. So let's look at it in a little more detail. Here's a cartoon you might or might not enjoy. But in parallel, what does the S in SAPT refer to? Single antiplatelet therapy. Which antiplatelet therapy is single? We used to think it was dropping the clopidogrel or ticagrelor or prasugrel. Well, it turns out it may not be. So let's take a look at a few very important recent trials. Here's the SMART Choice trial. All comers undergoing PCI with 3 modern-day drug-eluting stents. A comparison between 3 months of DAPT, followed by clopidogrel continued for a year, versus 12 months of DAPT, followed for major adverse cardiac events and bleeding. Non-inferior for major adverse cardiac events. So you didn't give up any thrombosis by cutting the aspirin therapy short, whereas you did see nearly a 50% reduction in the risk of bleeding. So short DAPT, longer monotherapy, won. There have also been 4 large trials, slightly different, but all very concordant in their findings. Global leaders, nearly 20,000 patients. This was all comers, regimens tailored according to acute coronary syndrome or not. Short duration DAPT versus 2 years of either ticagrelor or aspirin. Twilight, done in high bleeding risk patients, 3 months of DAPT, followed by ticagrelor monotherapy, versus a full year of DAPT. Tycho, done in ACS patients, 3 months of DAPT, then followed by ticagrelor monotherapy, versus a full year of ticagrelor inclusive DAPT. Asset, interesting, low-risk PCI patients, prasugrel alone with no aspirin. So how did short DAPT with continued P2Y12 antagonist therapy fare versus prolonged DAPT? Well, take a look. Global leaders was neutral. No loss of effect using monotherapy, but no increase in bleeding. So you didn't lose anything by stopping the aspirin after a month. Twilight, monotherapy beat DAPT in terms of bleeding and ischemia. Tycho, high-risk ACS, Same finding, monotherapy 1. Asset, well, only 100 patients, but prasugrel alone with no aspirin, no events. So it looks like when all is said and done, aspirin may well be left out in the cold. After a period of DAPT, if a patient complains of bleeding, you're probably on solid ground if you tell them to stop the aspirin. What about patients with atrial fibrillation? Well, as you probably know, based on trials in the 80s and 90s, there's no getting around oral anticoagulants. Shown in the upper left are the vitamin K antagonist trials. They always won. Upper right, the active A trial, vitamin K antagonist versus aspirin and clopidogrel. Vitamin K antagonist won on thromboembolic events, 77% more strokes with aspirin and clopidogrel versus vitamin K antagonist. The Aristotle trial, apixaban, a direct oral anticoagulant, beat vitamin K antagonist. Well, what if you use less DOAC or kept your INR lower? Well, that's shown in this graph from Elaine Hayek. And very simply, there appears to be an inflection point. Less anticoagulation reaches a point very quickly where there's no protection against stroke. So you have to use DOAC, and probably you have to, or a vitamin K antagonist, and you have to use it at full strength. So this is what I call the 7% solution. About 7% of stent patients have an indication for an oral anticoagulant in virtually every study that's done. There have now been 5 trials, 1 for vitamin K antagonists and 1 for each of the direct oral anticoagulants. So VOOST was the first, Pioneer Atrial Fib, Redual, and Trust PCI, and Augustus. The bottom line here is that in every one of these studies, every one of them, double therapy, that is a P2Y12 antagonist, usually clopidogrel, plus the oral anticoagulant, beat triple therapy with aspirin, the oral anticoagulant, and clopidogrel. So the bottom line is if the patient is receiving oral anticoagulants, they ought to receive a full dose, and you ought to continue a P2Y12 antagonist. Generally, it's been clopidogrel. There are very few prasugrel or ticagrelor patients in here, but don't continue the aspirin, so double therapy. Aspirin used only during the case and during the initial hospitalization. But I caution you, if you look at the sample size for these studies, they're all relatively small. They're all concordant in showing that triple therapy is the loser, but again, individually, none of them offer proof positive that that's the case. Nonetheless, that is certainly the way the wind is blowing. So what are the take-home points? Well, here they are. Currently, aspirin is indicated in secondary, but not primary prevention. DAPT is indicated after intracoronary stenting, although there isn't much agreement for how long. Aspirin will probably end up being used for a short period of time after stenting. If an oral anticoagulant is required, aspirin is probably useful only for the very short term. Long term, it increases the risk of bleeding without a benefit in terms of thrombotic effects. And finally, third generation P2Y12 antagonists as of 2021 are only useful in patients who've had an acute coronary syndrome. Thank you.
Well, thank you, Dr. Clement, for a wonderful presentation on antiplatelets. Actually, I have Dr. Rule right next to me. He just finished surgery, and we are all together here. So there are a few questions. Let's start with antiplatelets, just to continue that conversation. Are there patients you ever recommend, Dr. Clement, to tell them to never stop it? I mean, do you ever consider them using like statins, for example? Neil, can you speak a little bit louder? You may be muted.
Can you hear me now?
Yeah, perfect.
Okay, great. So the answer is yes. At least it has been yes. You know, and I've been recommending for a very long time to most patients that they continue DAPT indefinitely. But I have to tell you that over the last 2 years, the data really have poured in, telling me I'm probably no longer correct. So, you know, my approach is, if I view a patient to be high risk, and rather than calculating bleeding risk, I think we ought to keep things simple. If they're young and fit, the answer is yes, continue it. If they're young and fit and do exciting but hazardous things, got a patient who does class 5 whitewater rafting every year. I said, look, considering what you're doing, considering that you break ribs every year, probably you shouldn't be on DAPT. So for the most part, I really have backed off from that in the last year. And now it's only patients who have really bad looking coronaries, multiple long complex stents that I really am worried aren't endothelializing despite the passage of time, because their endothelium is likely to be quite diseased. Those are the patients I'm continuing on DAPT, although you know, I'm doing it with a lot of hesitation. Now, you know, we were asked to prepare these slides a few weeks ago, which was always great, but unfortunately that always precedes the ACC meeting. And there were some interesting presentations at ACC, one of which took patients on 6 to 12 months of DAPT after stenting who were event-free, and then randomized them to aspirin or clopidogrel and followed them. And like the other studies, except this was a broader patient group, patients on clopidogrel and no aspirin did considerably better than patients on aspirin and no clopidogrel. So to me, that's one more indication that you ought to strongly consider switching from DAPT to single antiplatelet therapy. And as time progresses, I think aspirin really is going to be left out in the cold.
Great, thank you. So on that note, Dr. Rule, help us understand the role of antiplatelets, where they are in the bypass surgery world. You know, there have been a lot of reports about using clopidogrel post-CABG. What is your practice? What do you think should be the standard of care? Because we keep on getting mixed messages from varieties of surgeons. What is your take on that?
Well, we get and give mixed messages on that also. We, you know, for the longest time we thought that antiplatelet therapies such as Plavix and Brilinta were evil, and we've learned to embrace them in our post-operative management. We always try to treat patients with aspirin, usually a full dose aspirin after bypass surgery. If they come in with previous stents and on Plavix, and we have not protected that stent, or we have to be sure that stent is protected, we may continue the Plavix as indicated with the guidelines that Dr. Kleiman has discussed. We, in patients who present with an acute coronary syndrome, more and more we are talking about using dual antiplatelet therapy in the postoperative period. In patients who undergo an off-pump coronary artery bypass operation, we are often concerned because they have what we refer to as a relative hypercoagulable state. They're not necessarily hypercoagulable, but they don't have their coagulation factors diluted by the pump. So now you're taking a bypass operation where we have an injury pattern in a 1 to 2 millimeter blood vessel at an anastomosis, and you're expecting them not to form a platelet adherent clot in that area. So I think in the off-pump cases, I always treat patients with Plavix initially the night of surgery if they're not having any bleeding, along with aspirin. And I actually suggest dual antiplatelet therapy with Plavix and aspirin for 1 year postoperatively.
Great. I think we have a little time for a couple of more questions. So Dr. Rule, to continue on that line, you are a big proponent of arterial conduits, we see that in your talk. I think you mentioned that, if I understood it right, that more than 1/3 of your patients, you try to do bilateral mammary grafts. Why is this not become the standard of care when you have such fantastic long-term data? Is that because the patients who are presenting for bypass surgery are too old to continue benefits, or is that something surgical which kind of inherently stops a lot of other cardiac surgeons to doing that routinely?
All of the above. So there are several issues. One is that several of the early trials, several of the trials that have been done using multiple arterial conduits have been excellent, and some recent trials have actually not shown incredible superiority, and there are several reasons behind that. But that's more of an excuse than the cause. I think mostly there are patients who should not have a second arterial conduit for various reasons, either biologically or anatomically. We do know that in insulin-dependent diabetics and in morbidly obese patients, we probably see a significant increase in the risk of sternal wound complications. We can mitigate that somewhat by taking down the mammary skeletonized, where we don't traumatize the collaterals to the sternum as much. But there is a risk of wound complications. We're all very cognizant of that. There are also patients who may not benefit from it because their targets are not appropriate for a second arterial conduit. And so we really have to take into account the patients who are really going to benefit from it, and then try to think of what is the benefit they're going to get. Long-term graft patency is probably much better with a second arterial conduit than a vein in the right settings. And survival is likely better, but we haven't proven it in randomized trials well enough to mandate it yet. So while there is plenty of evidence to show that it can be better in many situations, it's not better in every situation. But I think more and more the overwhelming evidence is that using arterial conduits for the next best target, if it has a high degree of stenosis, is a very good idea.
Thank you. So Dr. Clement, there's often been this question and often the consideration of anticoagulants on patients with CAD. Let's say a patient with coronary ectasia, for example. Are there scenarios where you think there may be a role for anticoagulants?
Well, I'm glad you phrased it that way, because there are scenarios where I think there's a role for anticoagulants, whereas if you'd asked, do you know whether there are situations where anticoagulants are indicated, to that I'd have to say no. Meaning, look, we think of anticoagulants specifically as drugs that affect thrombosis that occurs when there's a stasis of blood. And when we think of ectatic vessels, we think of disruptions in flow, and rather than the high velocity jets we see in high-grade stenoses, we think of these big patulous vessels that are probably lined with clot, the way aortic aneurysms are, and we worry about either clot propagation and thrombosis or embolization of large pieces of clot. We don't really know that very well, and the truth is, if you look at the interior of these vessels with ultrasound, in fact, they're extremely atherosclerotic, and one has to deal with the pathways that favor platelet thrombosis. So the answer is, I really don't know. I still favor antiplatelet medications for them, but the truth is, conscience doth make cowards of us all. And when I see a really large diameter ectatic vessel, sometimes I succumb to the temptation to treat them with oral anticoagulants, meaning specifically vitamin K antagonists or DOACs.
Great. I think I maybe have one more minute left. It's a very tough question, but I would like to get opinions from both of you. Left main disease, Dr. Rule from a surgeon's perspective, and then Dr. Clement from an IC perspective. Tell us, where do you think the messaging should be? What should we do with our patients with left main disease?
Well, I think left main disease is a spectrum of problems, and whether you're talking about a proximal or a bifurcation lesion, whether it's a complex 3-vessel coronary disease with left main or an isolated mid-left main lesion. I think there are many differences, as well as all the patient characteristics. In my mind, in general, if you want to generalize it, people talk about the term that I hate, the widowmaker lesion, but it's a scary process when we see a real severe left main lesion. We want to do whatever we can to avoid that from clotting and from having an acute coronary disaster from a left main problem. So if you think of it in that context, the reason we're treating it is to avoid a sudden disaster. I think the bypass surgery for left main disease makes a lot more sense than a complex stenting procedure in a high-risk patient. That all being said, we can get excellent results when the patients are selected properly for an appropriate use.
Dr. Clement?
I have to confess I agree with everything that Dr. Rule has said. I hate the term widowmaker lesion. I think you have to view left main as a broad category. Osteal disease, I think, is easily stented and probably should be. Bifurcation disease, to me, is no longer quite as technically challenging as it was at one time, but I think it's indicative that there's a lot of other disease that we underestimate. If you look at the results of the Excel trial, the composite endpoint didn't seem too different at either 2 years or 5 years. Mortality favored surgery at 5 years. And truthfully, if you look at recurrent events within that randomized comparison between surgery and stenting, there were many more non-left main events in the PCI limb versus surgery. So I think all other things being equal, surgical risk being low, bypass surgery is the treatment of choice for bifurcation left main disease, which is more common than osteal disease, than isolated osteal disease. But I think we're technically pretty good now. Acute events are pretty uncommon with bifurcation left main stenting. I think we've learned some valuable lessons. So I think if the surgical risk is high, bifurcation left main stenting is a very acceptable treatment.
Thank you, Dr. Clement, Dr. Rule. Appreciate that feedback and all those answers. Let's move on to our next session. We will be starting our session on advanced heart failure diagnosis and management. Again, I continue to encourage folks to join by web on paulev.com and enter DeBakey, or join by text and text DeBakey to 37607. My next speaker is Dr. Yousufzai. Dr. Yousufzai is a heart failure expert, and he's going to talk to us about medical therapy in heart failure. Ryan?
Thank you for the invitation. My name is Ryan Yousufzai. I'm one of the advanced heart failure cardiologists at Houston Methodist. I was tasked with talking about medical therapy in an advanced heart failure patient. I have no disclosure. What I thought to do is in next 15 minutes or so to talk about progress that we have made in medical therapy for a patient mostly with a heart failure with reduced ejection fraction in the last 7 to 8 years. To start, I would like to review the stages of the heart failure as they will be important during this talk. We have an ACC stage, which is based on symptoms and structural heart. Stage A are the patient who have a risk factor for heart failure but no symptoms. Stage B are a patient who has structural heart disease but no symptoms. Stage C, which is most of the patient that we treat in the heart failure, are the patient who has structural heart disease and symptoms. Stage D are refractory symptoms and advanced heart failure patient. And NYHA classification is more based on the symptoms. NYHA class 1 are a patient who have no limitation in a normal physical activity. NYHA class 2 are they have mild symptoms with normal activity. NYHA class 3, they have moderate symptom during daily activity. And class 4 are the severe limitation with this symptom or symptom at rest. This is where we started in 2013. we had a angiotensin converting enzyme inhibitor or ACE inhibitor, or angiotensin receptor blocker or ARB, and beta blocker. And we had loop diuretics for a patient who were congested, hydralazine nitrate for African American who were still symptomatic on background medical therapy, and aldosterone antagonists for the patient who were still symptomatic class 2 and 4 and meeting the criteria. Since then, we had multiple drugs that we added for a therapy for a heart failure with reduced ejection fraction. The first medication, which really changed the paradigm of the treatment of the heart failure, was Entresto. This is the angiotensin receptor neprilysin inhibitor, or ARNI, has two components, has a valsartan and sacubitril. Valsartan affects the renin-angiotensin system, and sacubitril affects the natriuretic peptide system. The trial that looked at the Entresto, here's the inclusion criteria. Patient had a class, NYHA class 2 to 4, ejection fraction less than 35%, elevated the BNP or NT-proBNP, and the patient was supposed to be able to tolerate enalapril or ARB or ACE inhibitor at least for 4 days before switching to ARNI, and they were on the guideline of directed medical therapy of beta blocker, and they were supposed to meet the criteria for blood pressure and kidney function. They were randomized 1-to-1. There was a run-in period to make sure the patient be able to tolerate enalapril and Entresto, and they were randomized 1-to-1. The primary endpoint of the trial was cardiovascular death or heart failure hospitalization, which was decreased by 20% the patient who were on Entresto versus the patient who were on enalapril. And looking at the cardiovascular death, there was again 20% relative risk reduction for a patient who were on Entresto versus patient who were on enalapril. And even all-cause mortality, there was a 16% reduction of the mortality, all-cause mortality of the patient who were on Entresto versus enalapril. So there was a significant and very positive trial. Second medication that we looked at was ivabradine. This is a medication that affects the funny channels. These are the channels there are that in the sinus node, and that affect the heart rate without affecting the blood pressure or inotropic effect. The trial that they looked at this medication was a SHIFT trial. Here the inclusion criteria, they were adult with the NYHA class 2 to 4, low ejection fraction less than 35%. They had to have this normal sinus rhythm with heart rate more than 70. They were randomized 1-to-1 to ivabradine versus placebo on the background of tolerated medical therapy. As you see here, the patient who were started on ivabradine, there was a significant reduction of the heart rate, which was consistently stayed lower compared to a placebo group, and the mean ivabradine dose was about 6.5 milligram BID. The primary endpoint was cardiovascular death and hospitalization for heart failure. There was a significant reduction of 18% for the patient who were ivabradine versus the placebo. Looking at the component of the primary outcome, the hospitalization for heart failure was significantly reduced by starting an ivabradine by relative reduction of 26%. However, the cardiovascular death was similar in these two patients. Based on these two important trials, there was an update in 2017 for a guideline of the therapy for a heart failure patient. ARNI or Entresto was a class 1 indication in the patient with a chronic symptomatic heart failure, reduced ejection fraction, who had a NYHA class 2 to 3 or ambulatory 4, and tolerates ACE inhibitor or ARB. The replacement with the ARNI was recommended. There was a recommended of the 36-hour washout period for the patient who were on ACE inhibitor before starting ARNI. And ivabradine was recommended as a class 2A for the patient who had an NYHA class 2 to 3 or ambulatory 4 with raw ejection fraction less than 35% in normal sinus rhythm where heart rate more than 70. So this was kind of the summary of the guideline with the important changes of adding replacing the ACE or ARB with ARNI, and adding ivabradine for a certain group of patients that we talked about. Since then, there was some new medication and some changes of the guidelines, and there was another guideline in 2021, which was recently published. There were really two important parts for this guideline. The first part was push for starting this medication early and up titrating it to the recommended dose. And the second part was a new medication with SGLT2 inhibitors, which we will talk about. Some of the important tips from this guideline that I found was are helpful for managing of our patient was it's always the question comes when to start beta blocker versus ARNI or ACE inhibitor or ARB. The answer is you can start them both at the same time if the patient tolerates. However, if the patient are congested or wet, they tend to tolerate the angiotensin receptor system or ARNI, ARB, or ACE inhibitor better than beta blocker. And when they're more euvolemic, they tend to tolerate beta blocker better. But the important message is no matter how you start them and which one first or all together, it should be up titrated to the recommended dose as the patient tolerates. As far as the ARNI initiation, as you remember in 2017, the guideline recommendation was to start the patient who were already on ACE or ARB and switch them to ARNI if they tolerate the ACE or ARB. There were two important trials since in 2017. One was the PROVE-HF trial, which showed tolerability and significant reverse cardiac remodeling by initiation of the ARNI in patients who were ACE inhibitor or ARB naive. And then PIONEER-HF trial, where for a patient with the de novo HF who underwent in hospital initiation of the ARNI, there was a greater reduction in natriuretic peptides, and the safety profile was similar for these two patients. So there was a push for the direct to ARNI approach is recommended, meaning you can start the patients on ARNI who were not on an ACE or ARB in the past. One tip that has helped me to start these patients are if the patient are euvolemic, it would be helpful to decrease the diuretic dose since the ARNI has a more diuretic effect and not natriuretic effect. If you decrease the diuretic dose of the patient with the euvolemic, that would help the patients tolerate ARNI better. Here's how the recommended initiation. If the patient are already on a high dose of ACE inhibitor or ARB, equivalent of enalapril more than 10 milligram or valsartan more than 160 milligram, you can start middle dose of 49-51 milligram twice a day, and you can increase them to the recommended dose of 97 and 110 milligram BID as they tolerate. If they are on a lower dose, meaning less than enalapril less than 10 milligram, valsartan less than 160, or they're naive to ACE inhibitor or ARB, or based on their renal or hepatic function or older patient, more than 75, recommendation is to start 24-26 milligram twice a day and up titrate from there as they tolerate. How about the new medication? The SGLT2 inhibitors are another change of the paradigm in managing the patient with heart failure with reduced ejection fraction. The first medication that was looked was dapagliflozin in the DAPA-HF trial. In the inclusion trial, the NYHA class 2 to 4, EF less than 40%, elevated NT-proBNP, and exclusion criteria was a severe kidney dysfunction, very low blood pressure, or type 1 diabetes. So they randomized the patient 1-to-1 with a placebo and dapagliflozin on the background on optimal medical therapy. The primary composite endpoint was cardiovascular death, heart failure hospitalization, or urgent heart failure visit. And the important part, they looked at a diabetic patient and non-diabetic patient, and in both groups, there was significant reduction in primary endpoint. Look at each component of the primary endpoint. Cardiovascular death, even though there was a trend to improvement of the cardiovascular death, however, it was not statistically significant. However, looking at the cardiovascular death or heart failure hospitalization as a secondary endpoint, there was a significant reduction of the patient on dapagliflozin versus placebo, again, in both group of diabetes and non-diabetics. Looking at the renal function improvement, the slope of the worsening of the renal function was better in the patient with the dapagliflozin versus placebo. There was a trend of the improvement. However, looking at the statistical analysis, it was not statistically significant. The second medication that we looked at was in the Emperor reduced trial. It was empagliflozin. Here, the inclusion criteria, again, very similar to the dapagliflozin and DAPA-HF inclusion criteria. And they randomized the patient 1-to-1 on the background on the optimal medical therapy. The primary endpoint was cardiovascular death or hospitalization. But for heart failure, there was a significant reduction of the primary endpoint in the patient who were on empagliflozin versus placebo. And look at each component. The first hospitalization for heart failure was significantly reduced, and cardiovascular death, similar to dapagliflozin, and there was a trend to reduction in the heart failure death. However, it was not statistically significant. But what was significant as a secondary endpoint was the slope of worsening of renal function. The patient on the empagliflozin did much better, and it mitigates the worsening of the renal function compared to the placebo. Looking at the reduced composite renal endpoint, which was defined as acute kidney injury or end of dialysis, patient on empagliflozin, there was a significant reduction of this endpoint. So to summarize the guideline, is that this is the most recent guideline, is the 2021 guideline. The first line of therapy is starting ARNI, ACE inhibitor, or ARB, and beta blocker, as we talk, at the same time if the patient tolerate, or starting one, adding the next one. Then again, the more important thing, titrating to the recommended dose. The SGLT2 inhibitors was added as a class 1 for a patient in NYHA class 2 to 4, and following with the aldosterone antagonist like a spironolactone and eprenone, diuretic for a congested patient. Remember, hydrolysis and isosorbide for especially African American who are on the directed medical therapy and still symptomatic. And do not forget the ivabradine, especially for a group of patients, more an advanced heart failure patient, that they are on a beta blocker, or they are not be able to start a beta blocker because of the blood pressure, but they're still tachycardic and heart rate more than 70. They can definitely benefit for adding ivabradine to their heart failure regimen. Thank you for the opportunity to present. This is my information, and I'll be happy to entertain any question. Thank you.
Thank you, Dr. Yousafzai. That was a very detailed presentation of a very complex topic, medical therapy of heart failure. Now we will, next speaker is Dr. Mawaz Kasi. Dr. Kasi is an assistant professor. She's also a heart failure specialist here at Houston Methodist Hospital, and her presentation is going to be on devices and surgical treatments for advanced heart failure. Dr. Kasi.
Good morning. I'm Mawaz Kasi, and I'm one of the advanced heart failure transplant cardiologists at Houston Methodist, and I'll be talking about devices and surgical therapy for advanced heart failure. So before I go into describing what are currently devices and surgeries available for patients who have advanced heart failure, I want to talk a little bit about advanced heart failure and what that really means. So advanced heart failure by definition describes a clinical syndrome characterized by persistent or progressive symptoms and ventricular dysfunction despite guideline-directed medical therapy. Again, that's a really important point, because I don't think that until we've tried to optimize guideline-directed medical therapy can we really define advanced heart failure. So before moving on to further clarification on advanced heart failure, I want to talk about a few facts about heart failure. So currently in the United States, 6.2 million American adults are affected by heart failure, and the incidence approaching about 21 per thousand population after the age of 65. Projections estimate that by 2030, more than 8 million people over the age of 18 will be affected by heart failure. Data from the ADHERE registry, which is an acute decompensated heart failure national registry, suggests a prevalence about 5% among hospitalized patients. And with the global burden of heart failure increasing, advanced disease will undoubtedly increase in tandem. In last year alone, more than 3,000 patients were treated with an LVAD, more than 3,000 patients received a heart transplant, and an additional 3,500 patients are awaiting transplantation. So again, how do we define advanced heart failure? This is a really nice classification that was introduced by ACCHA, which dichotomizes heart failure in stages A to D. The focus of my talk, of course, is stage D, which is the end-stage disease, and it requires specialized treatment. So how do we recognize these patients? Usually by recognizing their clinical class, which is fairly easy. Of course, if a patient has marked limitation in physical activity, and they are unable to carry out their daily activities, they're skipping work, they're getting readmitted. Those are, of course, red flags. So, of course, numerous societies have come up with different ways to describe it, but there's, of course, a lot of overlap. I mean, clearly patients who are intolerant to GDMT and they have end organ dysfunction or persistent hyponatremia, they're getting frequent ICD shocks, frequent hospitalizations, their blood pressure is persistently below 90, they're not able to tolerate any medical therapy. And then you can get really objective about your assessment as well by doing cardiopulmonary exercise test, where if their peak VO2 is less than 12, with a good effort, they're clearly advanced. If they have, they walk less than 300 meters at 6-minute walk distance, if they have a lot of heart failure admissions, I mean, these are clearly poor prognosticators. And then in addition to that, if you have right heart cath data or imaging data to support that they truly are advanced. The trouble, however, also with advanced heart failure is that while end-stage cancer, you have a clear trajectory of how if the patient's not doing well and they may not live past 3 months or 2 months. Patients with end-stage heart failure have a variable trajectory. So they can have progressive symptoms and then they may get better, then they may have progressive symptoms again, and then sometimes unexpectedly they will present with cardiogenic shock. And so I always explain to my patients that the trajectory can be unpredictable, but typically if they do have advanced symptoms, their survival past a year is less than 50%. But timing is very important in recognizing these patients early because the way I explain this to patients is that as you progress in advanced heart failure, you're really coming close to a cliff. And if you fall from the cliff, then I really cannot help you. I cannot do anything more than that. And at that time, of course, failure to recognize leads to a lot of issues, and unfortunately, people can pass. However, if you do recognize early, then you can at least prepare them in advance for therapies like transplant or LVAD. Now, what are device and surgical options that are available in heart failure? So currently devices that are available are usually either remote monitoring or devices that can allow some cardiac restoration and reverse remodeling. And then of course, the cardiac replacement being the LVAD or transplant. But the real question you have to ask yourself is that whether how it will help my patient. Will these strategies prolong their survival? Will it improve their quality of life? Will they prevent people from getting admitted? And is my patient truly a candidate for such therapies? And what does the data suggest whether these strategies are truly helpful or not? In terms of device development, there's truly been a hiatus since 2000, since ICD, CRT, LVAD have become streamlined. Since then, the device development has been, although much has been put into it, but none of the devices are so far accepted for patients with advanced heart failure. And I'll talk a little bit about some of the various devices that are looked into and are being evaluated for this patient population. So I'll start off with the case. This is a 74-year-old who had non-ischemic cardiomyopathy, who was on low doses of metoprolol and cilopril, was unable to tolerate higher dosages of medications because of hypotension. The patient was upgraded to CRT-D in the last 1 year, however, continued to deteriorate and had 5 hospitalizations with them since the CRT-D. The LVF was less than 20%, with LV and diastolic dimension of 8.2 with moderate mitral regurgitation. If you look at, we did a right heart cath. The right atrial pressure was 15, the bench was 24, and the cardiac index was 1.6. So all of these are, of course, as I had alluded to earlier, 5 hospitalizations, unable to tolerate medications, low EF, dilated LV, poor hemodynamics are all well put together, and we can all recognize that this patient has advanced heart failure. So what would you do next? I mean, this patient, of course, the options that are available are either we consider transplant or LVAD or ICD, or the other options are cardiac contractility modulation, some of the restorative devices, or mitral clip. So in our patient, if you look at the patient profile again, this is a 74-year-old, so clearly transplant is not an option. However, this patient was then considered for a left ventricular assist device and was evaluated and was a good candidate for an LVAD. Clearly, the patient had failed CRT, and there's in this strategy at least no role for cardiac contractility modulation. Being moderate mitral regurgitation, this was not a capable option. So basically, you have all these options. You have to just figure out what your patient would benefit from and what they are a candidate for. So talking about heart transplantation, of course, this is the preferred therapy for select patients, and the survival is up to 90% with a conditional half-life of about 13 years. Survival has definitely improved in the last 5 decades. However, the challenges continue to be that there's limited donor pool, patients with complex medical problems and other end organs being affected are usually not candidate for transplant. And of course, geographic constraints with ischemic time is an important consideration. And we have to clearly accept that not everyone is a transplant candidate. However, maybe this is the best strategy for patients who have advanced heart failure. And of course, definitely, we're also dealing with a lot of waiting time in these patients. However, in the last, since 2018, with the upgraded criteria, some of these wait time issues are being addressed with a newer classification system. But clearly, if you're at imminent risk of a decompensation or death, and you don't have enough time to wait for a transplant to happen. So in those patients, left ventricular assist device seemed to be a very reasonable option. This was evaluated in the rematch trial and in the first randomized study to describe the benefit of LVAD support. And LVAD therapy has really evolved with each subsequent generation with improvement in durability, device complications, survival. So we went from HeartMate 2 to the HVAD to HeartMate 3. But it's important to recognize, again, that patient selection is crucial. It should be considered in patients who have NHI class 3 to be to 4 symptoms with LVEF less than 25% with a peak VO2 of less than 12 to 14. And definitely, we've seen with device evolution, there has been an improvement in outcomes. As you can see with the newer generation centrifugal flow pumps, the survival has clearly improved compared to the older generation axial flow pump, which was a HeartMate 2. Now, the next question is there a role for remote monitoring in these advanced heart failure patients? Typically, if these patients are at risk of imminent death or if their survival is less than 50%, really, remote monitoring may not be helpful, but it may be helpful in those ambulatory class 4, 3 to 4 patients who are getting readmitted in the hospital, and CardioMEMS is maybe helpful in monitoring these patients closely and preventing further hospitalizations. And we've seen that with a lot of remote monitoring and optimizing their medications, we have been able to get them out of that stage D heart failure, and people have improved. So, so definitely is an option, but it is not an option for very, very advanced heart failure patients. Now we'll talk about another case, which is a 66-year-old with newly diagnosed heart failure. The prior history was only positive for hypertension. Patient was on Coreg. 12.5 in losartan, 75, that was the peak dosages that he could achieve. His NHI class 3 symptoms improved to NHI class 2. EF remained 25 to 30% with moderate to severe mitral regurgitation. This is his EKG, where you should see a left frontal branch block, sinus rhythm. So what would you do next? In this patient, of course, the important consideration here was persistent low EF despite optimization of medical therapy. So, of course, now is the time to consider him for an ICD. So, indications for ICD with patients with heart failure, usually class 1 indication if you've already had an event like VT or VF, and 3 randomized trials have shown benefit. And in patients where they have persistent low EF, ICD is class 1 indication if they are in NHY class 2 to 3, despite being on medical therapy. But the caveat being here that if you're expected to live more than 12 months in really advanced heart failure patients, in ICD may not be a suitable option. And it has been shown beneficial in 2 large randomized trials and demonstrated a statistically significant relative risk reduction in overall mortality in patients who didn't received an ICD compared to those who were treated with medical therapy alone. And highest risk reduction is achieved in patients with ischemic cardiomyopathy. Now, other important consideration here is the CRT, which is a cardiac resynchronization therapy, which this patient was a really good candidate for since they had a left bundle branch block, and it has been shown to improve symptoms, exercise capacity, and reverse remodeling and ejection fraction. So again, CRT is it can be used in advanced heart failure who have LVF less than 35% and have a QRS above 120. And there's a 3-lead system that's placed right atrial, right ventricular, and the coronary sinus. And those patients who benefit from CRT are usually those with very wide QRSs, above 150, and those with left bundle branch morphology. So again, you have to recognize appropriateness. So if the patient has left bundle branch block and if they have a QRS greater than 120, then of course they're suitable candidates for this. It can be even beneficial in some patients who have less advanced symptoms, such as NHI class 1. But it is also important to recognize there's a good number of patients who feel worse after the CRT placement, and a good proportion of patients who actually have gain no benefit from CRT. So that is usually how I counsel my patients when I offer them this therapy. So our patient received CRT, and as you can see now, his QRS is nice and narrow, and with appropriate CRT, the patient's ejection fraction actually normalized with a reduction in mitral regurgitation severity. So this is a very good example of how the patient was appropriate for this therapy. The device was appropriately placed, and with left bundle branch block, we know that it has the most benefit. And thereafter, of course, we saw that his ejection fraction improved and the MR severity improved. But there's definitely a hiatus in patients who do not meet criteria for the CRT. So then FDA has approved the Optimizer smart implantable pulse generator for heart failure, which is basically cardiac contractility modulation, and is indicated in patients who are chronic heart failure who are not eligible for CRT. So this approval was in March of 2019. So what this really does is that it has a similar mechanism. It has an implanted pulse generator, and the CCM signal basically is applied to the absolute refractory period to the RV septum via a standard pacing system. And what we've seen in this patient population is that there's improved peak VO2 and there's symptoms and reduced heart failure hospitalization. So definitely there's a role for this in patients who are not candidate for CRT but have persistent symptoms and still are and have not gained full benefit from medical therapy. What this really does is this cardiac contractility modulation is that it upregulates the circuit activity, and it normalizes the sodium-calcium exchanger. And basically, all these mechanisms at the molecular level are causing reverse pathological remodeling. Now, LV remodeling, which means that, once you have heart failure, you have a dilated left ventricle with mitral regurgitation, you have, what are ways to basically reduce the size of the left ventricle in an effort to actually improve the heart failure? This concept has been in literature since the 1990s, where they first developed a surgical technique to reduce the size of the enlarged left ventricle. The idea behind this is that, we understand that if you do have an enlarged left ventricle volume, this is associated with increased mortality. And if you reduce the left ventricular size, you're basically reducing the wall tension, increasing survival by increasing the left ventricular ejection fraction and decreasing the left ventricular end systolic volume index. So we went from the original door procedure, which was a restoration procedure, to the restore to stitch trial. And essentially, different ways to basically reduce the LV size. For in this example, where we see a patch is placed at the LV septum, and so that reduces the LV size. So the idea is beautiful, but unfortunately, despite all the initial enthusiasm, the mid to long-term results of these studies were disappointing, and the concept was finally basically abandoned. And the reason for failure, if you look at back at these studies and dichotomize them, it's really because there was improper site or scar selection, there was improper or inadequate volume reduction, and improper patient selection a lot. And I'm not going to go into details of all these trials, but now what I really want to hone on is that there is room for re-innovation in this area. There's a new device that we are also a center for, is the Bioventrix, where there's an anchoring system that reduces LV size. So, and this is only for patients with ischemic cardiomyopathy. So definitely there is room for innovation, and I think with the newer imaging modalities, better recognition of scar, our better understanding of the patient's profile, I think there could be room for these therapies in the future, but currently are still under exploration. Lastly, I think if any conversation about advanced heart failure therapies and devices should not be complete without talking about the mitral clip. So this is basically, as the LV dilates, patients develop more mitral regurgitation, which is as a result of essentially the valve just stretching out. And in these patients, particularly those with moderate to severe secondary mitral regurgitation who remain symptomatic, again, despite medical therapy, mitral clip may be a good option to lower their symptoms and improve all-cause mortality. And it is becoming more and more streamlined. But again, this therapy is best suited for patients who, one, truly have significant mitral regurgitation and are not advanced or extreme advanced heart failure patients who are at imminent risk of death. These mostly patients who benefit from this are usually, again, those intermax 4 or 5 patients who are still ambulatory and could benefit from this additional therapy. And we've seen a lot of benefit in these patients. And certainly, again, suitability of the patient, and if your patient's really good candidate for these therapies, it's are important considerations. So in this, I will end my talk, and thank you for listening to me. And if there are any questions, I'll be happy to take them.
Well, thank you, Dr. Kasi, for a wonderful presentation. It's just amazing how the toolbox in heart failure therapies have grown. My next speaker is Dr. Ashrit Guha. Dr. Guha is the director of the pulmonary hypertension program here at Houston Methodist Hospital, and he will talk to us about pulmonary hypertension, diagnosis, and therapeutic approach. It's a very unique diagnosis, and I would like Dr. Guha to tell us more about it.
Good afternoon, everyone. I'm Dr. Ashrit Guha, one of the heart failure transplant cardiologists here at Methodist, and also the director of the pulmonary hypertension program for the Methodist DeBakey Heart and Vascular Center. I'll be talking to you all today about pulmonary hypertension. These are my disclosures. And during this talk, we'll be talking over the new definition of pulmonary hypertension and pulmonary arterial hypertension, evaluation of a patient with suspected PH, the current medications which are being used for the treatment of pulmonary hypertension, and the treatment algorithm and risk stratification tools. So pulmonary hypertension is defined as mean PA pressure greater than 20 millimeters of mercury. And pulmonary arterial hypertension is defined as mean PA pressure greater than 20 millimeters with a mean pulmonary artery occlusion pressure or pulmonary capillary wedge pressure less than 15 with and a pulmonary vascular resistance of 3 Woods units. Now, pulmonary vascular resistance is defined as mean PA pressure minus the wedge pressure divided by cardiac output. And all of these have to be measured by a right heart catheterization, which is really the gold standard to diagnose patients with pulmonary hypertension. So just to sort of reiterate what we just talked about, so this is the right side of the heart, and all the systemic blood flow comes back to the right side and then gets pumped through the pulmonary artery. And these are the capillaries, and then the blood gets oxygenated, and then goes into the left side to be pumped out through the aorta. So in patients with pulmonary hypertension, the blood pressure here in the pulmonary arteries are high. However, in a pulmonary arterial hypertension, the wedge pressure or the pressure on the venous side is entirely normal. So this will segue into the classification of pulmonary hypertension, where group 1 or PAH is really where the wedge pressure is normal, and this is subdivided into based on etiology into idiopathic, heritable, drug-induced, and PH associated with connective tissue disease, HIV infection, portal hypertension, congenital heart disease. And in group 2 are those patients who have left heart disease or in whom the wedge pressure is high. And these are patients with valvular disease or systolic and diastolic dysfunction. And patients due to lung disease and or hypoxia, such as COPD, interstitial lung disease, fall into group 3. Group 4 is chronic thromboembolic pulmonary hypertension. And these are patients who have had blood clots and then eventually go on to develop CTEPH. And group 5 are those with unclear multifactorial mechanisms, such as dialysis and those patients with other systemic disorders. So in whom should you suspect pulmonary hypertension? Those patients who have exertional dyspnea, syncope, angina, and progressive limitation of exercise capacity. This is something that we see in a lot of patients. And in whom should we really think about PH? And in PH, I think that's the bigger question. So this is the usual sort of diagnostic algorithm that we use in patients with pulmonary hypertension. So once you have a patient who presents to you with shortness of breath, echocardiography is really sort of the kingpin investigation, which will help us diagnose somebody has pulmonary hypertension. So echocardiography can give us signs of elevation of right ventricular systolic pressure, which oftentimes is the same as the PA systolic pressure in the absence of pulmonary valvular lesions. And that is one of the ways in which we can see if patients have pulmonary hypertension or not. Another way using echo that you can also kind of get a sense of whether patient has pulmonary hypertension is by looking at the downstream effects on the right ventricle or on the right atrium. So if you have patients who have tricuspid regurgitation or enlargement of the right ventricle, then that can give us a clue that patient could have pulmonary hypertension. Because a lot of times, because the echo's sensitivity to pick up the high PA pressures are about 80%. So in about 20% of the patients, we might not be able to pick up if patients have high pressures. So in which case, we should also look to see if there are downstream effects, and that could help sort of delineate if patients have pulmonary hypertension. And then in addition, you always look at the company it keeps. If these patients have connective tissue disease, if they have left heart disease, so if they have other conditions which can lead to shortness of breath, it can help differentiate what group of pulmonary hypertension they could belong to. So then, based on the history, risk factors, and pulmonary function test, then you can decide if they have, lung disease, heart disease, and if there are no signs of pulmonary hypertension or RV dysfunction on echo, then you can attribute it to those other conditions. Otherwise, you can go down this algorithm, and then, especially if the VQ scan is a very important test that we do in patients with pulmonary hypertension, and I'll talk to you all about it later on. But once you have a high suspicion of pulmonary hypertension, really you have to get the gold standard test done, which is the right heart cath. It can help tell you what group of pulmonary hypertension the patient belongs to, so that they can be treated appropriately. The other things, once you diagnose that somebody has pulmonary arterial hypertension, like we talked about in 2 slides ago, you kind of look at all the other causes, whether patients have connective tissue disease, whether they've had a history of drugs and toxins or ongoing use of these drugs and toxins, HIV, PVOD, portopulmonary, congenital heart disease. So you go through all of these in a stepwise manner to see why that patient could have had a pulmonary arterial hypertension. So this again reiterates, what to look for on echocardiogram. If you have a high velocity on the tricuspid regurgitation jet, that will help us diagnose or estimate the RV systolic pressure, which will then help us diagnose pulmonary hypertension. So once we diagnose pulmonary hypertension and do the right heart cath to confirm pulmonary arterial hypertension, the next thing we have to do is, talk about treatment. So, 20 years ago, there were barely any treatments. Now we have almost 13, 14 drugs which have been approved for pulmonary hypertension. But let's talk about some of the general measures we do. As we looked in slide 2, pulmonary artery, the downstream to pulmonary artery is the right ventricle, which is what really bears the brunt of the pressures on the pulmonary artery go up. So a lot of our general measures are geared towards managing right heart failure. So you look at diuretics, then digoxin. Both of these, help in decreasing the preload of the RV and in helping in contractility. Oxygen, not only addresses hypoxia, but also helps with RV dysfunction by decreasing the by increasing the oxygen being delivered to the right ventricle. And oral anticoagulants, the role is controversial. Currently, it is accepted that in patients who have idiopathic pulmonary hypertension or connective tissue disease-related pulmonary hypertension who receive IV therapies, that is something that you can consider doing. Now, PAH specific treatments, which have been developed in the last 20 years, there are really sort of 3 pathways that these target, but there are 5 drug classes. So the endothelin receptor antagonists target the endothelin pathway. They work on endothelin receptor A and or B, depending on the drug. And again, they lead to vasodilation in the pulmonary artery and decreases the fibrosis. The phosphodiesterase 5 inhibitor or PDE5 inhibitor, which is sildenafil, tadalafil, and the SGC stimulator, which is riociguat, all of them work on the nitric oxide pathway. The prostacyclin receptor agonist and prostacyclin analogs, both of these work on the prostacyclin pathway. And so these are the 3 big pathways. And of these, the first 7 drugs you see here, they are all orals, as you can see here. And treprostinil is available in all the forms, and epoprostenol is available really in IV form. So let's just briefly go over some of the features of these therapies. The ERAs are very effective in early form of PAH. They really decrease the fibrosis and the remodeling. But it has a big side effect of causing edema. So you've got to be careful in advanced patients who already are in decompensated RV failure. Now, the problem with liver toxicity was present in the earlier generation of ERAs, which is no longer present. Now, in terms of PDE5 inhibitors, they're probably the most commonly used and well-tolerated pulmonary hypertension therapies, especially in some of these elderly patients and patients with a lot of secondary issues. It is much well tolerated. The only thing is that over time, it loses kind of its efficacy, because as the disease progresses, your nitric oxide levels go down. And without endogenous nitric oxide, it is really difficult for these medications to work very well. Now, very, very rarely, these patients with PDE5 inhibitors can get something called NAION, which is optic neuritis, which is ischemic in nature. And these patients can present with seeing altered colors or blurriness of vision, in which case you should really stop it and refer to a ophthalmologist. Again, you cannot use it with nitrates. And the same thing with SGC stimulators, since they work in the nitric oxide pathway, cannot use it with nitrates or with sildenafil. They're just more potent than PDE5 inhibitors, and mechanistically, they work kind of independent of the nitric oxide or endogenous nitric oxide production. So it can be used a little bit later in the disease. In terms of prostanoids and prostacyclins, these were some of the first developed therapies for pulmonary hypertension. But unfortunately, because of their IV use and because they have so many side effects, such as, jaw pain, flushing, nausea, headache, thrombocytopenia, diarrhea, it is used, really in class 4 patients. In other patients who present with shock and RV failure, it is very useful as well. Off late, there are oral, agents which work in the prostacyclin pathways, which have come into market and have made the use of prostacyclins a lot, or prostacyclin analogs and oral prostacyclins a lot more easier. So I wanted to talk to you about one sort of paradigm change which happened in pulmonary hypertension treatment a few years ago. And this was the Ambition trial, which looked at upfront combination therapy versus monotherapy, really combining the ERAs along with PDE5 inhibitors. And as you can see here, there was a clear difference in outcomes at 3 years, where there was a 10% difference in a combined endpoint of clinical worsening at 3 years. So at this point in time, it is our new accepted paradigm that we have to start these patients on dual therapy. So this is sort of the treatment algorithm. Once PAH is confirmed, then they undergo vasoreactivity testing. And this is again in the cath lab using nitric oxide, Flolan, or adenosine. And if they're not reactive, then they get traditional therapies. If they are, then they get calcium channel blockers. And in those patients who are low to intermediate risk by some risk stratification tools that I'm going to talk about, then you start upfront dual therapy. If they're high risk, you go directly to IV therapies and or including prostacyclins. But after 3 to 6 months of treatment with dual agents, you reassess their risk, and then decide, how to augment therapies. This is a risk stratification tool, which is predominantly looking at a lot of RV-related parameters, or right ventricular parameters. And this is available online, and we use it often in clinic, once at the initial diagnosis and also at follow-ups to see how patients are responding to treatment. Now, so I just want to quickly talk about a little bit about the CTEPH. It's a potentially curable type of pulmonary hypertension, which in which by doing a pulmonary thromboendarterectomy, you can cure this in about 60% of the patient. In the rest of them, even though they have residual disease, can be very well managed with medications. And the key here is doing a VQ scan in patients who you suspect pulmonary hypertension, especially in those patients who've had splenectomy, who had a history of PE, ESRD, or those patients with thrombophilia, to diagnose CTEPH. So again, tremendous advances have been made in the field of pulmonary arterial hypertension. The prognosis is vastly better compared to the last 30 years. However, it is still a progressive disease. We have to diagnose this early. Currently in the United States, there is almost a 2-year lag from the onset of symptoms to when patients are being recognized. So if we diagnose them early, we can treat them better and potentially even reverse all the changes in this disease. And again, always keep in mind CTEPH whenever you're thinking of patients with PH. And we are a large CTEPH center and offer all therapies for CTEPH, including surgery. So happy to take questions. And thank you, Dr. Shah and Dr. Zoghbi, for giving me the opportunity to talk in this conference.
Well, thank you, Dr. Guha. That was amazing. I have several questions lined up. I don't know if you're going to have time for all of them, but let me start with you, Dr. Guha, first to kind of lead into your presentation. It seems like most doctors are having a hard time timely diagnosis of pulmonary arterial hypertension. Any key features that you would like to advise? I'm sure you will probably like to get patients before their RV fails. And the second part of the question is this diagnosis curable? What is the prognosis once you've been diagnosed with pulmonary hypertension? I think it's a two-part question.
Yeah, very good question, Alpesh. So yes, we would like to diagnose them sooner. So I think one of the key things to, I guess, think about is if we see that we have a patient who has shortness of breath, especially unexplained dyspnea in younger patients, I think we should have a low threshold to do a right heart cath. And in a lot of older patients that I'm seeing right now, even though echo says the patients have pulmonary hypertension, a lot of the times it's attributed to, they have COPD or they have diastolic heart failure. But the degree of pulmonary hypertension oftentimes is way out of proportion to the left heart disease or COPD. So in an American registry, the REVEAL registry, patients who are a little bit older than 50, almost 20-25% of them had other comorbidities. So the presence of other comorbidities should not dissuade us from considering pulmonary hypertension as one of the diagnoses. So I think that's something to keep in mind. And secondly, I think unexplained dyspnea, if you don't have any other good explanations, I think considering a right heart cath and sometimes even an exercise right heart cath is very valuable. That's for your first question. The second question, more and more we are recognizing that if patients are recognized early, if they are NYHA class 1 or class 2, then potentially a lot of these changes are reversible. I have a patient who now has pulmonary hypertension for about 23 years, which is amazing, because that means she was started treatment early and she never progressed. So that's pretty much kind of unheard of. That thankfully she got diagnosed. This was way before even this is when I was in medical school. So whoever diagnosed her appropriately at the right time and started her on treatment. So if we diagnose it early, it is possible to arrest the disease and hopefully it won't progress. That's one. Secondly, the only cure we have is lung transplant, and that's not a good cure, as we all know. So so it's so important for us to diagnose it early.
Thank you. This question, I guess maybe Dr. Yousafzai can take. Are there any updates on the Parallax trial? If no improvement in heart failure class and 5-minute walk test, would you start Entresto in patients with HFpEF or preserved EF?
Yeah, so there's, the Entresto has been, looked at in a HFpEF patient. As you know, the HFpEF trials has been, most of them negative trial, but however, there's the new trials has shown some benefit especially with the Entresto, and they're looking at the SGLT2 inhibitors in newer trials. So to answer the question, I would definitely consider Entresto in a HFpEF patient, as that has shown some benefit, especially with the rehospitalization benefit of this patient. And the patient, if they can tolerate as far as the blood pressure, the kidney, failure or AKI, I would definitely consider Entresto in the HFpEF patient as well.
Great, thank you. Dr. Kasi, if you can help us with this question. There are two questions for you. One is, should everybody with low EF get ICD automatically, A? And B, what about stem cell in heart failure therapy? If you can help us out with those two.
So that's a good question. I think one important thing is that you have to pretty much optimize these patients with medical therapy first before you even go down the route of doing ICD. And more what we're seeing, particularly with the non-ischemic cardiomyopathy, there are patients that never have, or never, after the ICD has been implanted, they never have an ICD shock. So right now, of course, the guidelines say that we should consider it an implantation in patients who have EF that's, of course, less than 35. Ischemics benefit more than the non-ischemics. But as we are learning more about the phenotype of the patients and trying to figure out who are more arrhythmogenic than others, then that guidelines may be an evolution in the future. But the key here is optimal medical therapy prior to consideration and a good discussion with the patient about their risk. I've had patients who wanted to not do ICD even after 6 months of optimization of medical therapy, and lo and behold, their EF ended up improving 12 months later, not in the 6th month. So there's that cohort. And on the other hand, there are patients who have EF greater than 35%, but still need an ICD because they're more arrhythmogenic. I want to stress on that aspect, particularly the ones who have sarcoid or have LV non-compaction or some of the more arrhythmogenic or laminaceous cardiomyopathy. These are patients who are more arrhythmogenic and should be considered for an ICD early. Your second question was what again, Dr. Shah?
On stem cell therapies in heart failure patients.
Yes, so there are some trials going on. There were some phase 1, phase 2 trials about this. So far, of course, it's not been, it's not streamlined, but there are definitely, when I was at Mayo and we had a trial here where they were doing stem cell therapy, they have shown some marginal benefit where the ejection fraction has improved by like 5%, like going from 35 to 40%. But the data is not enough to say whether it will give a mortality benefit in the long run. But there have been small trials in mice and then some human trials that have shown some marginal benefit, but needs bigger trials.
Got it.
Alpesh, just want to add that
yes.
we were a participant here in DREAM study, which was again looking at a particular kind of stem cell, and the data has not been presented yet, but though the company released the top of the line results, like maybe about a month ago or so, looks like it might be positive in class 2 patients, but we don't have any more data yet. So I think they're looking to present that probably in ESC, so more to come.
Great. Maybe time for 2 more questions. Well, one is kind of a fundamental question. Is cardiomyopathy the same as congestive heart failure and vice versa? It seems both terms are used interchangeably and sometimes separately. Ryan, can you help us out with this? This is a dilemma for non-cardiologists.
Yeah, so that's a really good question. I think the heart failure, it's a clinical diagnosis. And it's, patient comes with fluid overload or, that's kind of the diagnosis of a heart failure. Cardiomyopathy is a disease of the myocardium of the heart, and that's kind of a broad spectrum of the diseases. That's what we're talking about. Are we talking about etiology can be very different, can be very broad? Are we talking about ischemic cardiomyopathy, which is, focused on a coronary artery disease? Are we talking about, there are diseases like amyloidosis, diseases like infiltrative diseases that can cause HFpEF type of, physiology, or are we talking about some of the genetic cardiomyopathy, which is, has hereditary cardiomyopathy, or we talk about, non-compaction? So these are a broad spectrum of the diseases that kind of falls under cardiomyopathy. And all of those can be, and having a patient having a heart failure, which is congestive heart failure, which is mostly kind of clinical diagnosis. So you can have a patient who have a cardiomyopathy, but does not have a heart failure. For example, a younger patient has idiopathic or genetic cardiomyopathy and hasn't been diagnosed, and they have a low EF, but they are very well compensated, so they don't present as heart failure per se, but they do have cardiomyopathy. So that's kind of comes with a little more investigation and a good history taking to hopefully be able to diagnose these patients who have cardiomyopathy before they present with heart failure. As we know, every hospitalization and every presentation to heart failure is correlated directly with how poor this patient do. So you could have cardiomyopathy without heart failure. Heart failure is more clinical diagnosis, but cardiomyopathy is more related to the imaging, CAT, and type of thing to kind of identify what type of cardiomyopathy are we talking about.
Got it. We have several questions on this session. I only have time for one more. Spironolactone or Lasix? When do you give which diuretic? Anyone? Help us out.
I guess I can take that. So spironolactone and diuretic. So diuretic is obviously it's useful, for the patient that as kind of we talked about with the congestive heart failure. The patient are congestive. The diuretic definitely it's a cornerstone of treatment to decongest this patient for the symptomatic improvement and also end organ improvement, especially the kidney improvement. So we use the diuretics, and there are a host of diuretics. The loop diuretics is the most common use, like a furosemide and torsemide, and they're thiazide diuretics that we use as a second role. The spironolactone, it is diuretic and has been used as a diuretic effect, but it also has shown improvement of remodeling as well. So it is more than diuretics has been using it, and we use it in the patient who are on other medical therapy, especially ACE or ARB or Entresto and beta blocker. And spironolactone is another, the third or fourth kind of drug that we use for the preventive of the remodeling for the heart. So it has a diuretic effect, was mostly used for kind of preserve and prevent remodeling of the worsening of the cardiomyopathy.
Got it. Thank you so much. Appreciate all your insights, and we are headed to a break. Thank you again. So please visit our webpage and you'll go to the virtual exhibits by our vendors because it's because of them that we are able to get this program up and running for you all. So we'll take a 10-minute break and we'll be back in 10 more minutes. Thank you. All right, and we are back. We are entering our 7th session. I hope you have been enjoying the very thorough reviews which have been given to us by expert speakers. Now we go to the electrical part of the heart, electrophysiology. So the next session is going to be dedicated to cardiac electrophysiology and arrhythmias, diagnosis and management. Our first speaker is Dr. Amish Dave. He's an assistant professor and is a very eminent electrophysiologist, and he's going to actually teach us about something very important to all of us on EKG interpretation. You must know some of the facts of this lecture. So Dr. Dave, please.
So I'm Dr. Amish Dave, and I'm going to talk today about EKG interpretation. These are some must-know slides. I'm going to try to go through this in 15 minutes. So before we talk about abnormal, it's always a good idea to have a really clear idea of normal. Here's a normal EKG, and briefly, it's good to have a system here to read this that you follow every time, that way you don't miss things. I like to look at the rate first. You can see that this heart rate is right around 75, 80 most beats per minute. It's a little bit faster, a little bit longer than 3 major boxes, and 3 would be 100 beats per minute. You can see the rhythm. There's 1 P wave before every 1 QRS, and this is therefore a 1-to-1 rhythm. It's sinus rhythm because the P waves are positive in lead 2 and initially positive but later negative in V1, and that's the hallmark of a normal sinus P wave. The axis is normal if it's positive in 1, if the QRS is more positive than negative in lead 1, and more positive than negative in 2, then this is basically a normal axis. And then, of course, the PR interval looks normal. It's less than 1 major box, and it's a normal narrow QRS, and it's a normal QT interval. The T waves also look normal. It's normal and acceptable if you had a T wave inversion in V1, but V2 and especially V3 to V6 should be positive with the narrow QRS. So with that said, we'll talk about some abnormal EKGs that it's really important to recognize. This is an EKG that if you followed the previous protocol for looking at EKGs, you basically would suggest that maybe the heart rate's a little slow, the PR interval is okay, the P wave looks like it's a sinus P wave probably. The striking thing over here is the QT interval is really long. When the QT interval, which is measured from the beginning of the QRS to the end of the T wave, when that is more than half the interval from the QRS to the QRS, it is going to be long. And so here it's a strikingly long QT interval. And when you see this, very often this is iatrogenic. This can be caused by a variety of antiarrhythmic drugs, certain antibiotics like photoquinolones and erythromycins, antifungals, certain SSRIs, certain off the market now GI drugs. It's also very commonly a genetic condition. There are a number of enzymes that are encoded by genes that have specific mutations in certain families, and these lead to certain subtypes of what we call long QT syndrome. The gene that's mutated affects the phenotype. Some of these patients with characteristic T waves and a specific mutation can have their sudden cardiac arrest induced by exercise, some others when the alarm clock goes off, some during sleep, etc. The first line of therapy for these patients is beta blockers, but generally speaking, if you see a wide QT interval, you should look at the medicine list and you should really strongly consider referring if there's any questions. This is the converse. This EKG shows a very short QT interval, and just like a long QT interval predisposes patients to sudden cardiac arrest, a very short QT interval is also very concerning and predisposes patients to ventricular fibrillation arrest. A normal QT interval should lie between at least 320 milliseconds on the low side up to about 500 milliseconds on the high side. And so those patients with short QT syndrome, this is familial. It's oftentimes the case that these patients are diagnosed with atrial fibrillation at a young age, and any EKG like that should be run by a cardiologist. This is an important EKG to recognize. The thing that's very striking here is the ST segment elevation. However, this specific pattern should be memorized as something called Brugada syndrome. You see a downsloping pattern to the ST segment and leads V1 or V2, and it goes into an inverted T wave. That is one of the hallmarks of Brugada pattern. Now, patients who have this EKG may have a relatively normal EKG half an hour later, and this particular appearance to the EKG can be brought out during a febrile illness when patients who have this particular syndrome have a fever. It's really an emergency. We more or less tell them to go straight to the emergency room because fever in the setting of Brugada syndrome is oftentimes when those patients develop cardiac arrest and ventricular fibrillation. So if you see this type of EKG, start thinking of a genetic syndrome called Brugada, and not necessarily STEMI. So it is a sodium channel mutation, and it is a little bit more common in men and Asians. So of course, you can see it in any population, and seeing that EKG, it's important that EKG gets saved, because it's the next 5 EKGs you do may not show the pattern. So another set of EKGs that you really want to recognize are these ones. These are striking for high voltages. The QRS complexes have a lot of vertical boxes, and that suggests hypertrophy of some sort. And then when you see the really, really abnormal repolarization, this is really strongly suggestive of hypertrophic cardiomyopathy. And hypertrophic cardiomyopathy is present in about 1 in 500 Americans, the gene mutation. It has very variable penetrance, and most of those patients will never have any phenotype of hypertrophic cardiomyopathy, but many of them will. And it is in America the most common cause of sudden cardiac arrest in young athletes. This is an EKG that shows another genetic sudden cardiac death or producing syndrome. The hallmark over here are these epsilon waves. There's some notching near the end of the QRS. You can see this most strikingly in V1 and V2, also V3 and 2. These this notching has a name. It's called the epsilon wave. The T waves are also, as usual, inverted, well past the usual, maybe V1. It's okay to see that. V2 also in young people and women. But here, this is the hallmark of something called arrhythmogenic RV dysplasia. This is more common in descendants of people who from northern Italy, but of course it can be seen in all populations. And the key thing over here is these patients are at risk for developing life-threatening arrhythmias. They can also develop right ventricular cardiomyopathy. Those patients with that kind of EKG should be referred. Next, we're going to look at some SC segments that are very concerning and not so concerning, but otherwise look alike. So on the left, we see some ST segments that are curved with the concave portion, the part that's like a cup or cave, facing down. And those ST segments are very scary. Those are concerning. Those are tombstone ST elevation. And that's from a myocardial infarction. On the right, though, you see that the ST segments over there have the cup portion of the ST segment, or the cave portion, pointing up. They're concave up. And those are more like a smiley face. Those are not so scary. The ST segments over there are actually fairly common to see, and most definitely are not from a myocardial infarction. So Now, this is an EKG where you do see some ST segment elevation. That's even maybe concave up to some small degree, but this is really an ST segment elevation myocardial infarction. What V1, V2, V3 are trying to tell us here, remember that those leads are really in the front of the heart, and we don't really have in a normal 12-lead EKG any leads that are recording the activity of the posterior wall of the heart, so-called V7, V8, V9, V12, etc. If we had, they would be located really directly opposite of leads V1, V2, and V3. And those leads, if we had them in this patient, would show a tombstone ST elevation. When you look at V1, V2, V3, they are really just showing an inverted tombstone, and it's a posterior myocardial infarction. If the anterior part of the heart muscle was having a heart attack, you would see a more typical tombstone pattern like we saw before. This is a person who needs to go to the cath lab right away. And these patients have a little bit more sensitivity to hypovolemia and hypotension, so would be important to avoid too much sedation. Pulmonary embolism, is characterized on the 12-lead EKG by really a few things. The most reliable is sinus tachycardia. It's also the case that you see a right bundle branch block often, and sometimes you see an S1, Q3, T3. Here it's really an S wave in lead 1, which again you can see in most right bundle branch block patterns. But you also have a Q wave in lead 3 and an inverted T wave in lead 3. When you have all of these signs, it's probably suggesting pulmonary embolism. This is an EKG of a heart that is freely floating in fluid. So the key thing over here is there's QRS alternans. You can see that every other heartbeat has a different amplitude, and even a different shape, basically, on for example, B3. And the reason for this is this patient has a pericardial effusion, and the heart is really, as the patient's breathing, floating in this fluid. And the voltages are smaller because there's fluid between the surface of the heart muscle and the EKG stickers. And of course, the tachycardia is suggesting that this may even be tamponade. When you see this, you also want to look for signs of pericarditis, which is really characterized by diffuse ST elevation, and oftentimes you'll see this, but this patient has a pericardial effusion and probably possibly tamponade. Now, this is a really important EKG to recognize. It's not unusual to have a person who has a CKG and have it missed. The protocol or stepwise reading of an EKG includes looking at the morphology of the QRS complex, and if you see what we call bunny, what oftentimes is called bunny ears on V1, if you see a right bundle branch block pattern like over here, the thing to keep an eye out for is that if the right bundle branch block patient has problems in the left bundle branch, then that patient is running out of bundle branches and may be at risk for complete heart block. And one of the clues here that this is happening is this patient has a left axis deviation. In addition to the right bundle branch block, you can see that the QRS is positive in lead 1 and negative in lead 2, and therefore this patient has probably what we call a left anterior fascicle block. If this patient had a normal axis, then you would assume that the left anterior and posterior fascicles are probably okay. If they had a rightward axis, meaning lead 1, the QRS is negative, that is a right axis deviation, then maybe the left posterior fascicle is blocked. But really, if they have an abnormality in the axis and a right bundle, then you know that the right bundle doesn't work and one of the fascicles in the left bundle is not working. And then on top of that, if the PR interval is long, that could mean that the remaining fascicle, the posterior fascicle in this case, is diseased. And so we call that a trifascicular block. Remember that there are only 3 fascicles, the right bundle, left anterior fascicle, and the posterior fascicle. So when you see the combination of right bundle branch block and an axis deviation and a long PR interval, you really have to be concerned that the patient may be at risk for progression to complete heart block. Another thing you can see is left bundle branch block with a long PR. If you have a left bundle branch block, that means the left anterior and posterior fascicle don't work, and the long PR may be telling us that the right bundle is problematic. All of those types of patients really are potentially at risk if the remaining fascicle goes away of really not having a heartbeat, because there won't be many backup mechanisms when the conduction system below the AV node stops conducting. This is a diagram of the 3 fascicles, and basically, if your AV node is gone, well, the muscle fibers within these fascicles can sometimes generate heartbeats for you, but once they're blocked distally, the heart rate when there's no more conduction will be really, really low. This EKG is from hyperkalemia. You can see it's starting to lose the sharp aspects of the EKG. It's looking a little bit more like a sine wave. It's got these large peaked T waves, and you start losing the P waves. The T waves are large and peaked, and when you see these, really worry about hyperkalemia and checking electrolytes. This could also be toxicity from certain antiarrhythmic drugs like flecainide. In this case, this is hyperkalemia. And then this is an EKG showing WPW. WPW is an important EKG to recognize. Patients who have an EKG like this have a risk for sudden death. And so recognizing this EKG and referring them as appropriate is really important. Not everyone has a risk of sudden death, but we can tell which patients do and which patients don't. So the hallmarks of WPW, which stands for the Wolff-Parkinson-White syndrome, are that there's a P wave that runs straight into the QRS. There's no real flat PR interval here. The PR interval is actually very short, and the beginning of the QRS, if you look at lead 1 or V1, is really a very slurred onset, and that's called the delta wave, and it represents the activation of the portion of the heart muscle that is connected to this accessory pathway, fiber that's carrying electrical signals from the atrium to the ventricle without waiting or using the AV node. And if patients like this develop AFib, they have a risk of going into ventricular fibrillation. And patients like this develop AFib at a much younger age than others. So it is a real problem in some of those patients. So even if a person has a CKG but has never had palpitations, never had syncope, they really should be referred. So with that, I'm going to stop. I hope anyone who has questions will share them with me at the end of this session. Thank you.
Hello, welcome back. Thank you, Dr. Dave, for a fantastic talk. I like the last slide. Our next speaker is Dr. Paul Sherman. He's also an electrophysiologist here at Houston Methodist Hospital, and Dr. Sherman will talk about atrial fibrillation, one of the biggest topics, medications and devices to prevent stroke. Dr. Sherman.
Hello, everybody. My name is Paul Sherman. I'm a cardiac electrophysiologist here at Houston Methodist, and I'm going to talk about atrial fibrillation and the left atrial appendage closure devices. So atrial fibrillation by far is one of the most common arrhythmias you might encounter, especially in the elderly population. On the left side of the screen, you can see how a normal beat originates from the sinus node on the top of the heart, and it goes down to the AV node, then travel to the left bundle, right bundle, and finishes the conduction system. As you can see in the tracing, you can see that every QRS is equally separated. And instead on the right side, you can see that the atrial fibrillation is a disorganized rhythm that it starts in the atrium and travels down to the AV node at the different times. And that explains why in the tracing you can see different timings and spacing between the QRSs, easily to identify on the strip, because you won't see a discernible P wave and you will see different QRSs at different time without a specific pattern. It's also important to recognize the different stages of atrial fibrillation. Usually in the beginning, it starts as a paroxysmal atrial fibrillation, which is defined as a spontaneously termination of an AFib episode within 7 days. Okay, the episodes may reoccur with a variable frequency. The presence of persistent atrial fibrillation is usually defined by a sustained episode of more than 7 days, or any episode that require a cardioversion or the initiation of antiarrhythmic drugs to terminate it. That means that the episode did not terminate spontaneously. What about long-standing atrial fibrillation? We usually define as that one that lasts more than 12 months with atrial fibrillation. And we call permanent atrial fibrillation when the decision between the clinician and the patient together, they decide to stop the attempts to restore or maintain sinus rhythm. Non-valvular atrial fibrillation is determined as the absence of rheumatic mitral stenosis, mechanical or bioprosthetic heart valve. Once that we know the stages, then we usually, when I encounter our patient, we try to identify why this patient has atrial fibrillation. And we have to think in two categories, cardiac and the non-cardiac. The cardiac usually is hypertension, heart failure, pericarditis, post-cardiac surgery due to the inflammation, coronary artery disease, mitral valve disorders, and cardiomyopathy. In the non-cardiac, we have very commonly the COPD, the sleep apnea, with patients who are BMI, hyperthyroidism, pneumonia, sepsis, alcohol abuse, very important and easy to recognize with a simple screening questions. There are certain medications and genetic disorders that can predispose to atrial fibrillation, and another one is carbon monoxide poisoning. Once that we try to identify the etiology, if it's not reversible, like for example in the case of sepsis or pneumonia, which you treated, and the episode of atrial fibrillation will subside, it will no longer require any further intervention. In other cases, especially when it's cardiac etiology or those that are not reversible etiologies, we need to start thinking about stroke prevention, because atrial fibrillation increases the chance of a stroke by 5 times. Also, if we don't control the atrial fibrillation, it can produce heart failure by a process of tachycardia induced. Also has been shown to decrease dementia, and it is thought to believe because it's the decrease in the strokes. A very important paper that we need to update you is in the EAST-AF trial, which is the early rhythm control therapy. It has been an important landmark paper in the recent years. The reason why in the past we thought to believe that rate control and rhythm control perhaps will have the same outcomes to our patients. And we have 2 trials that were done in the past. The AFFIRM trial, 2002, and then the AF with heart failure, New England Journal of Medicine. However, recently we have the CASTLE trial, which has shown a decrease in and a superiority in the group that received rhythm control strategy, in this case an ablation, with a decrease in the cardiovascular events. Also, another important is the use of newer drugs like dronedarone, which has shown to also to decrease cardiovascular event in the group of paroxysmal atrial fibrillation, and that was in the ATHENA trial in 2009. So we have catheters, ablation, antiarrhythmic drugs showing now that you can perhaps decrease cardiovascular events. So in really to assess the one strategy to another one, we compare head-to-head early rhythm control in patients with paroxysmal atrial fibrillation, which is usually the early stages, and the usual care, which combine the rate control. Both group will, no matter what, be on an anticoagulation. They were followed up to almost 5 years, and it was a blinded study, multi-center trial. As you can see, both groups in this trial were very similar. Half of them were normal sinus rhythm on type of enrollment. The CHAS-VAS was 3.3. Interesting wise, the female population was not a minority, 46% of them, and the age was about 70 years. There was difference in the use of beta blocker, was more in the rate control, and in the digoxin also it was more often used, and the statin were slightly higher in the rhythm control. What about efficacy? Whenever we see these trials, we have to look how efficient was in order to maintain rhythm control. As you can see, there was a significant difference compared one strategy to another strategy in maintaining rhythm. At the end of the 24th month, most of the patient, 80%, were in rhythm in the rhythm control strategy, and in the rate control strategy was about 60%. So what are the results of this trial? So we look at two types of results. The co-primary efficacy was a composite trial of death, cardiovascular, stroke, hospitalization. And the secondary was individual components of like symptoms, LV function. And the trial was stopped early due to efficacy at the third interim of analysis, almost 5 years of follow-up per patient. And the primary outcome event occurring are about 249 patients in the early rhythm control, which will be about 3.9 per 100 years, compared to 316 in the usual care, which is about 5 per 100 person years. And why is this? So as you can see, it met the statistical significance, and the majority interest was driven for the cardiovascular events, including death from cardiovascular events. There's a decrease in mortality, also a decrease in strokes, a decrease in hospitalization from heart failure, and a decrease in acute coronary syndrome. However, this one did not meet statistical significance, but was a tendency. So overall across, there's a tendency to decrease cardiovascular event, mainly driven statistical significance from stroke and death, okay? And this is the other importance between the two groups. Sinus rhythm was significantly higher in the rhythm control strategy compared to the rate control strategy. It's also important to show that there was an increased bleeding in the rhythm group, mostly related to the procedures of the ablation. However, it was the episodes of major bleeding, it was a very low incidence. We're talking about 6 over 1,395 compared to 6 out of 270. So, however, they did not translate to death or any events of mortality. So the strategy of rhythm control therapy in patients with early onset atrial fibrillation, like paroxysmal atrial fibrillation, has an impact in our cardiovascular event, lowering their death from cardiovascular causes, stroke, hospitalization, and heart failure and acute coronary syndrome. And usually the absolute different risk is about 1.1 event per 100 persons per year. So if you apply this therapy of early rhythm control in your patients, and usually are the non-cardiologists, the first exposure to this type of patient, you will encounter better outcomes on your patients. And why is this? Why now this trial is showing the opposite or a preference for rhythm control compared to our prior ones? So if we look at the two trials and we compare head-to-head, the EAST and the AFFIRM trial both have very similar type of patient, and the age were very similar, and the percentage of AFib and the amount of normal sinus rhythm achieved. However, the antiarrhythmic drug was different. In the AFFIRM trial, was used more a class 3 agents. Instead, in this case, we use more a class 1 and dronedarone, which are the usually drug of choice for paroxysmal atrial fibrillation without structural heart disease. Also, the anticoagulation, a very important topic. In this trial, no one stopped anticoagulation. It was continued regardless of your rhythm controlling. But in the AFFIRM trial, in the protocol was established if you achieve rhythm control and you were allowed to stop anticoagulation. And many of those patients that stop anticoagulation knowing that perhaps you are not 100% in rhythm all the time. Maybe you have some breakthrough of atrial fibrillation that were undetected during the trial. So in this trial, everybody continued anticoagulation, no matter how good you were in rhythm control. So my takes out of this for you guys is that times matters. And if you catch early on onset of atrial fibrillation, you may significantly increase the outcomes if you try a rhythm control strategy. This is a newer new game changer for all of us here, and everybody deserves to be in normal rhythm, at least attempt to be in normal rhythm. And this is not a trial to see who was better antiarrhythmic drugs of atrial fibrillation. It was a trial to look for the strategy. No matter how you achieve it with drugs or with catheters, the outcome will be is better than a rate control. And no matter what you do, how good you are maintaining that rhythm control, you need to maintain anticoagulation to prevent stroke. This is a good slide to illustrate how we use antiarrhythmic drugs. If you have a no stroke through heart disease, the list of antiarrhythmic drugs that you can use is significantly, you can use most of them. But however, if you have a stroke through heart disease, it's not only dofetilide and dronedarone solo if you have CAD, but if you had heart failure, only amiodarone dofetilide. Catheter ablation can be used in all strategies between structural and non-structural CAD. And what about stroke? Another important gadget that we learned from this is the higher the CHA2DS2-VASc score, the more likely you will benefit from anticoagulation. But also, regardless of atrial fibrillation, the CHA2DS2-VASc score is an important predictor value. The higher your CHA2DS2-VASc score, even if you don't have AFib, you could potentially have a stroke. However, you have AFib and a high CHA2DS2 score, that goes multiplied by 5. So significantly increases your chances of having a stroke. That's why it's so important, anticoagulation. And not everybody qualify for anticoagulation. Also, many people who need anticoagulation, they also are high risk for bleeding. Usually they're hypertension, prior stroke, bleeding, elderly, or concomitant use of alcohol or other drugs that predispose to bleeding. So it's a very important decision that we have to make is not everybody will qualify for anticoagulation, and not everybody can afford it also. So the Watchman on a left atrial appendage occlusive device has been also an alternative for certain patients. And we have epicardial and endovascular left atrial appendage occlusive device to prevent stroke. The most widely used in study is the Watchman. And in the beginning, we have shown significant safety event, but as the technology has progressed and the evolution of this technology advances, we have come to decrease our safety events, and now these days even at the 2% registry. So we have become more safe in applying this therapy, and as you can see in the part of a stroke, it shows that the hemorrhagic stroke significantly is decreased by the Watchman. There was a tendency to increase and favor the warfarin over the Watchman, but did not reach statistical significance. However, no difference in all-cause mortality death. However, there was a major difference in bleeding, non-procedure related, that favors the Watchman, of course. As you can see, there was a 71% reduction of major bleeding after the stopping the anticoagulation that favors the Watchman, and that's one of the main reasons why we're trying to do it in patients with high risk of bleeding. And not everybody also, we can assume that the CHA2DS2-VASc score is the whole story of a stroke prevention. There are appendages that tends to be more malignant than others. As you can see, this one has like a dragon tail that if very unlikely the anticoagulation will be able to control a massive clot formation. And this one, perhaps this patient could benefit from anticoagulation. We're far to identify and screen appropriately this. However, the use of non-invasive imaging like the CT scan has been tremendous help. And we're starting to study now which is of this morphology tends to be. The most benign at the moment should be the chicken one. With this, I will finish Thank you very much for listening to my talk of cardiology to non-cardiologists, and I hope I have transmitted a good message to you and you are able to practice in your practice. Thank you very much.
Thank you, Dr. Sherman. That was a fantastic presentation. I heard you say everybody deserves to be in rhythm, and I don't know if you're talking about their dance moves or actually their electrical rhythm. The next speaker is Dr. Miguel Valderrabano. He's the Director of Electrophysiology Services here, Professor at Houston Methodist. And Dr. Valderrabano is going to talk to us about ablation. When do I refer? When is the ablation procedure appropriate? Dr. Valderrabano.
Thank you very much for the invitation. I will be discussing ablation of atrial fibrillation and when to refer the patients. So we need to first step back and try to understand what it is atrial fibrillation. Atrial fibrillation is the most common heart rhythm disorders characterized by an irregular ventricular response and disorganized atrial activity. Many years ago, it was shown that the first beats of atrial fibrillation tended to originate from one of the pulmonary veins, and this led to the procedural strategy of pulmonary vein isolation as a potentially curative therapy by eliminating the site of the first beat of atrial fibrillation. Atrial fibrillation is not just a rhythm problem, it has implications beyond the heart. It's associated with an increased risk of stroke, which could be as high as 6 times if you're compared to the normal rhythm patients. And it also leads to an increase in mortality. More recently, it has also been linked to an increased incidence of dementia, not just vascular dementia from strokes, which could have been the simplest association to understand, but also Alzheimer's, any other kind of dementia. So we know that atrial fibrillation has implications for cognitive function beyond that of stroke. Atrial fibrillation is here to stay, and with the aging of the population, it is expected to increase its prevalence in the coming decades. A few definitions to understand atrial fibrillation. Paroxysmal atrial fibrillation is one that terminates spontaneously or with intervention within 7 days of onset. Episodes may recur with variable frequency, and thus there is the term of AFib burden that quantifies the percentage of time that patients are in atrial fibrillation versus normal rhythm. Persistent atrial fibrillation is that in which atrial fibrillation is continuous for more than 7 days. Long-standing persistent atrial fibrillation is that is continuous for a year or more. And then permanent atrial fibrillation is the kind of atrial fibrillation in which the physician and the patient decide that we are going to accept atrial fibrillation as the long-standing rhythm of the patient, and we're not going to try to cardivert the patient. Acceptance of atrial fibrillation may depend on symptoms, of rate control, and tolerance to drug therapy. There's nothing specific about permanent atrial fibrillation other than the decision of the physician and the patient to accept it as a long-term rhythm. Non-valvular atrial fibrillation is typically in studies used to discriminate patients that have atrial fibrillation in the context of typically rheumatic valvular disease that has its own particular mechanistic causes as well as its own prognosis. So in outside rheumatic disease, outside rheumatic mitral stenosis, we call it non-valvular atrial fibrillation. What are the treatment goals when we approach atrial fibrillation? Number one, we need to make the patient feel better by controlling the symptoms. Number two, improve the outcomes by preventing strokes, preventing tachycardia-induced cardiomyopathy, prevent dementia, and reduce mortality. And the approaches are rhythm control versus rate control and anticoagulation. Rhythm control being fighting for normal rhythm. An interesting update has occurred in the past few years when it comes to the diagnosis of atrial fibrillation. So, simply stated, the diagnosis of atrial fibrillation, it depends on the EKG, and you just need to find an EKG where the patient has irregular QRSs with disorganized atrial activity. But a diagnostic challenge occurs quite commonly when the patient tells you that they have symptoms that could suggest atrial fibrillation, but all the EKGs that you do are in normal rhythm. And if the patient has episodes of atrial fibrillation very sporadically, you're never going to catch them. So as of the last year, there was a study looking at an Apple Watch looking at whether the Apple Watch would discriminate atrial fibrillation independent of the patient's symptoms. And this was a massive study that Apple was able to pull through, enrolling almost 500,000 patients over the span of 3 months, which is heroic. And they were able to, looking at pulse irregularity, not the EKG Apple Watch, but pulse irregularity, they were able to detect 450 events of irregular pulses, of which 153 were atrial fibrillation. So a high degree of false positives. But based on the continuous monitoring, this device could actually pick up atrial fibrillation, even though with a very high degree of false positive, there was basically the ability to catch atrial fibrillation independent of the patient's symptoms was proven. So this is probably one of the things we're going to be seeing in the future in the general medicine management of patients with suspected atrial fibrillation. Perhaps even more interesting development came last year or 2 years ago when a group from Mayo Clinic used an artificial intelligence algorithm to process the EKG in patients in sinus rhythm. And they put the EKGs of almost 200,000 patients and 650,000 EKGs. They put these EKGs through a machine learning algorithm to try and see if the computer could figure out which patient would go on to develop atrial fibrillation. And with an anticipation of 31 days, so this was a short-term study, they managed to create a convolution neural network algorithm by which the computer would learn to interpret EKGs in sinus rhythm, and with an accuracy of 90%, they would predict who would go on to have an EKG with atrial fibrillation. So it's kind of fascinating that if a patient now tells you that they may have symptoms of atrial fibrillation, but the EKG is in sinus, you could put this EKG through an artificial intelligence algorithm and predict who would develop atrial fibrillation. And interestingly, this was actually validated against other epidemiological associations that we have that predict atrial fibrillation. The most common and best established is the CHARGE-AF score, which computes the presence of white rays and height, weight, systolic and diastolic blood pressure, smoking and hypertension, diabetes, and myocardial infarction. And if you compute all these factors, you get a score that will tell you with a C statistic, with an area under the curve of 66 or 70%, whether a patient will develop atrial fibrillation. Well, you don't need to do any of that. You can just get an EKG in sinus, put it through the AI algorithm, and this algorithm would predict with the same degree of accuracy whether a patient is at risk of atrial fibrillation. So this idea of diagnosing atrial fibrillation based on an EKG in sinus seems to be catching on. Another group more recently, just last month, they use a similar artificial intelligence algorithm and a convolution neural network to identify the electrocardiographic signature of atrial fibrillation, this time with 1 year of anticipation, not 31 days. And in patients with no history of atrial fibrillation who go on to have an AFib-related strokes, nearly 2/3 of them could have been predicted to be higher risk for AFib before the stroke by the deep learning model. This is fantastic because you could implement treatment options, including stroke protection studies, stroke protection therapy with anticoagulation to prevent strokes before they even happen. Anyway, say we have the diagnosis, say we want to now treat atrial fibrillation and we want to implement rhythm control. What do we have as choices? We have drug treatments, antiarrhythmic drugs. This is AADs, antiarrhythmic drugs. And the problem with these drugs is that they're tricky. They're tricky because if you use them in the presence of structural heart disease, some of them could be dangerous. So you need to really understand the patient's underlying structural disease to choose on which drug therapy to give, because if you give the wrong drug, you could kill the patient. So when there's no structural heart disease, you can use any drug. When there is coronary artery disease, the only ones that are safe are dofetilide, dronedarone, sotalol. When you have heart failure, only amiodarone and dofetilide. For all substrates, ablation is available. So should we implement a rhythm control versus usual curve rate control? There were several studies in the 90s. The most common was, the most powerful was AFFIRM, that showed that it was about the same outcomes in terms of stroke and mortality if you implement rhythm control versus rate control. And that had become the paradigm under which we would treat atrial fibrillation. But last year, there was a study, very large study, looking at current strategies for rhythm control compared to rate control. And what they found is that the early rhythm control, as early as with the first diagnosis of atrial fibrillation, led to reduced cardiovascular death, stroke, or hospitalization for heart failure or acute coronary syndrome. Early rhythm control, it was not just ablation, it was a combination of ablation and drug therapy. Only 19% of the patients got ablation. But the bottom line is that the early implementation of rhythm control strategies for the first time were shown to improve mortality. And this was in part because of the length of the follow-up. If you compare the length of follow-up and the length of the years since initiation of atrial fibrillation treatment, it turns out that EAST, which is this large study that I just mentioned earlier, had longest follow-up and showed lower mortality with rhythm control. So there is a push lately to implement rhythm control strategies. And ablation is the one that has the most promise and the most powerful. How do we ablate atrial fibrillation? As I said, and the mainstay is isolation of the pulmonary veins, getting rid of electricity for this area, plus more or less add-ons as determined by the specifics of each patient, operator experience, and others. But everybody should get pulmonary vein isolation. And what is the data using ablation as the first line of treatment? Well, last year or this year, 2 studies were published in the New England Journal on the same issue, showing that cryoablation, in this case, was associated with much improved rhythm control. In 2 studies randomized to cryoablation versus antiarrhythmic drug therapy, in both cases, there was a significant, very significant improvement in rhythm control. Now, this is tricky. We know that ablation is better than drugs when it comes to rhythm control. But is it overall worth it? Is it overall worth it if you count the procedural risks, the procedural problems that can arise with ablation? And this is the fallacy that is not studied is hidden in these studies, because just because rhythm control is better doesn't mean it's better at rhythm control is better with ablation. It doesn't mean that you need to use ablation on everybody as first line of treatment. Because if you have one episode of atrial fibrillation and you get an ablation and you get a complication, what was wrong with waiting? You were going to wonder. And that's, I think, my take when it comes to deciding first-line treatment using ablation or not. But suffice it to say, there's 2 studies that just published this year, build on previous studies that had shown similar things, that ablation as first-line does better when it comes to rhythm control than antiarrhythmic drugs. That's better in terms of rhythm control, not necessarily overall outcomes. And sure, symptomatic AFib, there's no doubt that is reduced by ablation, as is reduced AFib recurrences. So is it fair to use it as first line? Well, there are 5 randomized studies that support ablation superiority. If you have tried previous ablation and previous antiarrhythmic drugs and you still have atrial fibrillation, then there's no doubt that ablation is the way to go. And there's no point in treating patients with multiple drugs. Once you fail one, there's no really any suggestion that other drug would do any better. But as a first line of treatment, symptom control can be achieved in a substantial fraction of patients with drug therapy, because symptom control with ablation comes at a big price in terms of risk if you're unlucky. So sure, most patients go through it without any problem, but there is a risk of tamponade and pericardial bleeding, TIA or stroke, atrial fistula, very rare but deadly, and phrenic paralysis, pulmonary vein stenosis, and other problems that can arise with ablation. And also, let's not forget that AFib, even though many times it's lone AFib, there's no valvular disease that causes it, there's no overt associated heart disease. AFib does come in the context of other systemic diseases and that can be treated. And obesity is one of them. Obesity increases atrial fibrillation risk. There's some mechanistic implications as to the epicardial fat that can be pro-inflammatory, and that increases with obesity. Obesity is associated with hypertension and sleep apnea. And if you are obese, you're more likely to have atrial fibrillation. And it's one of those things that if you lose weight, you can actually lower the incidence of atrial fibrillation. So this is treated. Few words about the obesity paradox, which is interesting. Sure, obesity increases the chances of atrial fibrillation, but if you look at outcomes of atrial fibrillation in obese patients versus lean patients, it turns out that obese patients tend to do better. Maybe something about being lean and having atrial fibrillation that leads to worse outcomes in atrial fibrillation. But nevertheless, obesity should be treated as a means to reduce atrial fibrillation. Also, sleep apnea. There's no doubt that sleep apnea is a combination of severe stress during the periods of apnea, where hypoxia lowers the pulmonary artery pressure, increases the load of the right ventricle, leads to right ventricular right atrial enlargement, and impedes left ventricular hemodynamics. So it's a severe stress on the heart that occurs every night on burst, and that leads to progressive structural remodeling that leads to atrial fibrillation. And this can be treated or controlled with CPAP. Also, alcohol. As little as one glass of wine a day can increase the risk of atrial fibrillation. And we used to think that, alcohol is heart healthy, a glass of wine is great for your heart. Well, that is nonsense when it comes to atrial fibrillation and abstinence in patients that have paroxysmal atrial fibrillation. Again, last year shown that abstinence, no alcohol for 6 months, reduce atrial fibrillation recurrence and reduce the AFib burden in patients that have paroxysmal atrial fibrillation. So these things have to be implemented when you see a patient before you talk about ablation. Don't get me wrong, I make a living out of ablation, but still it does not mean that every patient needs to be ablated as a first line of treatment. There are some conditions where ablation is particularly impactful. And it could even improve survival. So in patients with low ejection fraction, there's 2 studies looking at the role of ablation in outcomes. And of course, the first study was a small study that didn't look at mortality, but they found a 53% reduction in mortality in patients with heart failure, low ejection fraction, and atrial fibrillation that underwent ablation. And this was confirmed by the large Castle AFib study published in the New England Journal 3 years ago that showed that ablation reduced hospitalization for heart failure, death from any cause, and the combination of both. So there are situations where ablation needs to be strongly considered, and heart failure is one of them. Overall, the outcomes of ablation versus antiarrhythmics were studied in the largest ever study for atrial fibrillation, the Cabana study that took 10 years in the making. It was overall a negative study when it came to the primary endpoint of death, disabling stroke, and serious bleeding or cardiac arrest, in part because up to 1/3 of the patients randomized to drug therapy ended up getting ablation. So there was a lot of crossovers that messed up the data. Suffice it to say, death and hospitalization was reduced by catheter ablation. And when you look at per protocol analysis of patients that actually got ablation versus patients that didn't get ablation, the primary endpoint was improved by catheter ablation, both at 6 months and 12 months. So does this mean, how do we put it all together? When is ablation appropriate? Well, a very simple approach in my take is ablation is appropriate when the benefits of ablation outweigh the risk. And that requires individualization. You need to take into account that some patients may not benefit from symptom control because they may not have any symptom of atrial fibrillation. Some patients have paroxysmal AFib with 1 episode every 6 months of 5 minutes versus 2 hours every other day. So the AFib burden is a problem. That structural disease impacts prognosis and results of the procedure. And stroke and dementia can be a problem, and we don't know yet if ablation impacts those. We need to treat the associated conditions, hypertension, obesity, sleep apnea, and reduce alcohol intake. Some patients respond really well to antiarrhythmic drug, and there's no rush into jumping into atrial fibrillation, and there's no loss. You don't lose anything by trying a few weeks of antiarrhythmic drugs. That has issues with compliance long-term, and structural disease determines the antiarrhythmic drug of choice, but still it's worth trying. And then ablation success is not the same for everybody. Paroxysmal versus persistent, there's no doubt that paroxysmal patients do better after ablation, easier to succeed. Structural disease compounds adds difficulty to the procedure. So the way I look at this is to determine who is an appropriate ablation candidate. I looked at this if there is patient gain, if reliable rhythm control was to be achieved better than existing therapy, and then consider patients' symptoms, quality of life, and stroke prevention strategies. Number 2, I ask myself, is the procedure safe? Can the patient tolerate a 2-hour procedure under general anesthesia? That is a key. Some patients may not be able to, and then therefore they're not procedural candidates. And third, is there any technical difficulty that compromises success of the procedure? Some massive left atrial enlargement or presence of thrombus can actually make the procedure undoable. So when the answer to these three questions is yes, that the patient can get benefit out of being in normal rhythm, that the procedure is safe and there's no problems technically to achieve a successful procedure, then I think ablation is very appropriate. Thank you very much.
Thank you, Miguel. We don't have much time left for Q&A, but I want to, there are a few questions I would like to see if we can address this. Miguel, maybe we can start with you. How long is the anticoagulation required in patients who are getting AFib ablation? Well, Paul, maybe you can help us out, please.
Yeah, I can answer that question for sure. Look, one thing is important is that no matter how good rhythm control is, patient needs to continue anticoagulation. In certain cases where the risk of bleeding is higher, you may consider, with a good discussion, the benefit and the risk with the patient, you may consider taking him off anticoagulation 3 months after the ablation. But you need to have a good surveillance mechanism in case the atrial fibrillation comes back to be able to restart him on anticoagulation. But overall, the preference is not necessarily take him off anticoagulation once the ablation is performed. If you're ablating atrial flutter, it's different because atrial flutter could be cured with catheter ablation. It tends not to recur at all down the road, and it's more forgiving in the outcome. So I will treat it differently what type of ablation where you are, depends on the chest vascular that you are, and the risk of bleeding. I think all those three things are important to determine when we're going to take off the anticoagulation after catheter ablation.
So just to clarify, if somebody does not have a contraindication for anticoagulation, you would continue them indefinitely in spite of a successful ablation?
That is correct. If we're talking about atrial fibrillation and you have no contraindication, we should continue anticoagulation until it's contraindicated or is harmful or the risk of bleeding is too high.
Okay. I have another question which is rather long, but I'll try and paraphrase it. There's a 51-year-old woman who starts getting palpitations, checks her blood pressure, gives an error message. Pulse oximeter is with her and she finds her pulse in 250. She goes to a cardiologist in a couple of hours and EKG is normal. So the cardiologist thinks that may have been an SVT episode and basically tells the patient, here, take some verapamil. But the patient is concerned because she has had previous such events in the past. And I guess in a way wants to know what are the options. Can the patient just wait for ablation? Is interventional therapy should be rushed into, or medication is the first choice here?
Yes. Dr. V is there. I don't know if he could hear the question, but I can take this one. So it's very important to make the diagnosis because sometimes you could be dealing with a paroxysmal atrial fibrillation or you could be dealing with truly an SVT. So it's very important to try to establish the diagnosis. And usually ambulatories and event monitors, they might miss it, but that's your first choice. Otherwise, we have used other resources to try to diagnose the rhythm abnormality when they're so paroxysmal and so rare. Like we have now devices on our phones that can do tracing like EKG that are very diagnostic. The Apple Watch is also a very useful resource to immediately to do a recording and catch it on time. And in those cases where the patient is not savvy with the technology and cannot do that, well, we have those loop recorders that we can implant and try to diagnose them with recordings.
Okay, great. I have a few other questions. There are a lot of them lining up. Let's say AFib on EKG on routine pre-op. Don't know when it started. Do you start rhythm control and anticoagulation right away?
Yes, very good question. Anticoagulation should go first. That should be your first goal. Once that you have that conversation, then you should proceed for rhythm control. But I wouldn't start rhythm control without addressing the anticoagulation first. Okay. I think it's important to first tackle the stroke situation and then consider doing rhythm control. So if you can do both in the same visit, great. But if you cannot, then start with anticoagulation right away.
Okay, great. Let's see. There are a couple of more questions. Is Miguel on? Can he hear
I
us?
am on. I'm having trouble with the video, but I am on.
Okay, and I see Amish
Right.
now. Okay, great. So guys, chip in here. Patients with paroxysmal AFib could benefit from heart monitoring digital fitness device. Shouldn't be a prescription prescribed? Amish, you want to try that? I'm sorry. Go ahead, Miguel.
No, that's a tough one. So there's a couple of manufacturers that make wearable monitoring devices. Of course, the Apple Watch is one known one that uses pulse monitoring, not EKG monitoring, and so do other watches. That can track your pulse. In terms of electrocardiographic monitoring, the Cardia device is one that when you buy it, it asks you for a prescription. That is probably advisable because you need physician interpretation of the tracing. The device is good for screening, but when it comes to making a firm diagnosis, you need a physician. So it's best to have someone that you can show your tracing to.
Okay. All right. Amish, you want to chip in? Let's say, I understand that the Watchman device are appropriate for non-valvular AF patients. Does that mean someone with valve insufficiencies will not be considered for the Watchman? If that is not correct, what steps would they need to make to be qualified? I think you're on mute, Amish.
Okay, I would turn that on its head. I think valvular insufficiency would not disqualify a person from the Watchman device. A person with mechanical valve replacement who has to be on Coumadin anyway would probably be a person that may not be the most appropriate person for a Watchman device, obviously. In that you wouldn't be planning to get them off of Coumadin. But a person with, rheumatic heart disease or some other valve disease that needs to be on Coumadin but has reasons to be off anticoagulation would be still a good candidate, an acceptable candidate for a Watchman procedure for sure.
Okay, great. Well, one last question. A patient had an ablation and placed on Eliquis for 30 days and told that is all he needs. No aspirin, no beta blockers. His comorbidities are hypertension, diabetes, obesity. Does he need to continue Eliquis for longer?
It depends. So it depends obviously on what they had an ablation for. There are a lot of rhythms that we ablate. Typically when we ablate flutter, right atrial flutter, there's no burning in the left atrium. If they have a very low CHA2DS2-VASc score, where the guidelines would have that patient potentially with a CHA2DS2-VASc of 0, not needing any aspirin or anticoagulation, that could be reasonable actually. Just you've cured them of their flutter and they don't need anything beyond that 1 month. If they have atrial fibrillation or some left atrial arrhythmia that was burned, many of us do more than 1 month of anticoagulation, and then the duration of anticoagulation, probably most of us would individualize that. In some instances, really even a procedure such as AFib ablation, we would not necessarily stop anticoagulation. It sort of depends on the individual patient's risk-benefit ratio of continued anticoagulation and how certain we and the patient were that if he had any AFib or she had any AFib in the future, we would be aware of it, and they would be aware of it.
Okay. One last question. Quick answer, please. Let's try Miguel. Is AFib ablation always permanent after a successful, or can it reoccur?
It can reoccur. If you want to make it quick answer, it can reoccur. You have to remember that ablation does a good job at controlling the rhythm, but it doesn't alter the disease that led to AFib. So in patients that have hypertension, sleep apnea, big left atria, diabetes, and other conditions that simply aging can contribute to atrial fibrillation, we've seen late recurrences, typically as flutter, but you have to remain vigilant. we can achieve a solution for AFib, almost a cure, but we don't cure aging, we don't cure sleep apnea, we don't cure hypertension. So there are conditions that are always there that can tip the patient over into AFib again.
Thank you all three of you. I appreciate your input and excellent presentations. We will now move on to our next and the last session. We have saved the best for the last. This is about endovascular disease, the advances in therapies, and our first speaker is going to be Dr. Alan Lumsden. Dr. Lumsden requires no introduction. He's the medical director of Houston Methodist DeBakey Heart and Vascular Center, and is one world-renowned vascular surgeon, and he will educate us about aneurysm of the aorta. Is it going to kill me? Dr. Lumsden.
Well, thank you for the invitation. The topic that I'm going to speak on is aneurysm of the aorta. Is it going to kill me? And we'll try and address that sometime in the next 15 minutes. Here are my conflicts. When you look up at the roof of the Sistine Chapel, you see this God giving the spark of life to man. I used to give a presentation with a friend of mine, Jeff Marshall, who was an interventional cardiologist in Atlanta. I used to say, Jeff, you know, realize that's a surgeon that's up on that cloud. But he's very astute and observational, and he pointed out that stethoscope that was around his neck and said, no, you know, Alan, that's not a surgeon who's up there. That's an interventional cardiologist. So, you know, with that in mind, I'm going to do my best to try and persuade you about what we need to know about aneurysms today. Well, let's start off with some of the demographics. First of all, most aneurysms are detected by chance. The aorta lives at the posterior aspect of your abdomen, on top of your spine, and although most are asymptomatic, when they do cause symptoms, they often present as back pain. So it's not at all uncommon that we get referrals from a patient who's gone to the orthopedics. They may get a CAT scan, the spine's normal, but they see this calcified shell of the aneurysm, and then they're sent our way. You fix the aneurysm, and their back pain goes away. But again, to emphasize, probably 70-80% of them are completely asymptomatic. When they move into the symptomatic mode, when they are become symptomatic, either with back pain, the most common symptom, or abdominal pain, then there's some urgency in getting them fixed, because then they're in pre-rupture mode at that point. About a couple 100,000 people in the United States are diagnosed with AAA annually. About 15,000 patients die each year from a ruptured aneurysm. The mortality has really not improved a whole heck of a lot from a rupture. If you have a free rupture, most of these patients don't get into the hospital. What I mean by a free rupture was it decompresses into the peritoneal cavity, patients just exsanguinate. So it's a very pre-selected group of patients that we see in the first place. Those whose abdomen ruptures retroperitoneally, is contained, they then stabilize, and that gives us a chance to go ahead basically and intervene on that patient. 45 to 50,000 patients undergo some sort of intervention. Used to be surgery, increasingly it's with an endograft. And AAA is more prevalent, the older you get, more common in men than they are in women. The Trivial Pursuits question, which aneurysms are more common in women than men? Splenic artery aneurysms and renal artery aneurysms are the only ones more common in women than men. Everything else basically is more common in men. Where do aneurysms of the aorta occur? The most common location is in the infrarenal aorta. Okay, now why infrarenal? We really don't know. It's probably related to flow patterns in the infrarenal aorta, probably related to lack of elastin or degeneration of elastin in the wall of the aorta. The other location where you get aneurysms, of course, is descending thoracic aorta, much less common ascending aorta. We'll talk a little bit about descending thoracic aneurysms later. The definition of an aneurysm is about 1.5 times the adjacent normal aortic diameter. And so the other really valuable piece of information is to know that most aneurysms grow on average about 3 to 4 millimeters a year. But that's not basically linear progression. Sometimes aneurysms stay stable and expand more rapidly. And so you really once you make this diagnosis, you really have to follow those patients. Most are followed with ultrasound, some with CAT scans. So the annual risk of rupture, what are the numbers that you need to remember? So the numbers are Small aneurysms, the definition of small aneurysm is probably less than 4.5 centimeters in diameter. The risk of rupture, as you can see, is remarkably low. The risk of intervention at that point in time is probably higher than the risk of leaving them alone. So by and large, there are a couple of exceptions. Aneurysms less than 4.5 centimeters should be left alone. Aneurysms 4.5 to 5 centimeters in small women, you start thinking about it. But the numbers that we typically think of are in the 5 to 5.5 centimeter range. 5.5 centimeters needs to be fixed. 5 to 5.5 centimeters, we individualize. How do we individualize? Again, it's relatively bigger in a smaller woman. If there's been recent expansion of the aneurysm, we lower that threshold down to 5. Some patients have a history of ruptured aortic aneurysm. They're just completely paranoid about this. And if they're incapacitated by knowing there's an aneurysm, it's another situation where it's very reasonable to actually take the threshold down a little bit in those patients. But once you start hitting that 5.5 centimeter diameter, then what you see is an exponential rise in the risk of rupture. So if you see a patient with an aneurysm of 7 centimeters, and we're really quoting them at a rupture rate of 15 to 20% per year. Well, you got to be pretty sick in order not to have that aneurysm ruptured, because they are going to rupture if the patient survives more than, for example, up to about 5 years. Chances are that aneurysm is going to be ruptured. The mortality when the patient reaches the hospital is still in the order really of about 50%. So again, we're always weighing up the risk versus the benefits. And so when a patient says, what's going to kill me first, doc, is it the cigarettes, is it the booze, or is it that aneurysm? We're always judging the risk of leaving it alone and the benefit basically of intervention. And again, purely basically on a size basis, we think about the 5 to 5.5 centimeter diameter, a little bit higher in the descending thoracic aorta or in the ascending aorta before we decide to go ahead and intervene them. So these numbers I'm quoting you are really for infrarenal abdominal aortic aneurysms. Okay, patient's got an aneurysm. Now what are we going to do with this? Well, let's say it's an aneurysm 4 centimeters in diameter. What are we going to do with that patient? By and large, we're going to ask them about their history, family history of aneurysms. Do they have any abdominal pain? Do they have any back pain? And I can tell you in a 4 centimeter aneurysm, if they've got back pain, because of course half the world has got back pain, it's probably not coming from the aneurysm. And we have to explain that to the patient. And so typically the diagnosis is usually in our world, it's usually made with ultrasound or a CAT scan. Sometimes it's made with a KUB because the wall calcification may be evident, and that might be one of the reasons that they are referred to you. It's not a reliable way of measuring the diameter. So typically, if we're going to follow these patients, and it really depends upon the body habitus, but if it's an aneurysm 4 centimeters in diameter, they don't need a CAT scan every year. CAT scan should be really thought of as the pre-interventional evaluation. We need a CAT scan before we're going to intervene on them, but in terms of routine follow-up, typically we get an ultrasound, on an annual basis. If it looks like it's suddenly getting bigger, we'd probably get a CAT scan at that point to evaluate it. So ultrasound yearly, non-contrast CT scans another way, particularly in patients with an elevated creatinine. But if we're going to intervene on them, we really need either a CT scan or an MR, perhaps done with Furhim. So once we've made that decision, the aneurysm has now gotten bigger. We're now up to 5 to 5.5 centimeters in diameter. Now's the time that we're going to go ahead and get that CAT scan. And that CAT scan really should be done with relatively thin slices, 1.5 to 2 millimeters. That has become increasingly important as we've moved into the world of branched and fenestrated grafts. What is a fenestrated graft is where there's a hole lined up, for example, with the renal arteries that we're going to go through and put little branches really out into the renal arteries. Some have other methods basically of putting branches in because there are a whole variety of these different devices that exist at the moment. They're the accuracy of planning where those fenestrations are going to be made, where those holes are going to be made that you're going to put a stent graft through a stent graft into a renal artery or a superior mesenteric artery is critically important. So if the diameter of the renal artery is only 5 millimeters in diameter and we've got 5 millimeter slices, then we can be miles off in terms of where we're going to put that fenestration, and that makes it very difficult to actually catheterize these. So for the imagers who are out there listening to this, we have gone from thinking of the CAT scan purely as a diagnostic planning tool, because we now import that and we fuse it. And I'll show you some examples of this on top of these patients. We're actually delivering these devices using your CAT scan, and so it is very important that what the quality of that scan is going to be. So we've made the decision we're actually going to intervene on the patient. First of all, there is no role for angiography in helping plan these. Angiography is really used at the time of planning, and we use a hybrid room. We use what's called a Siemens Pheno hybrid room. It's the latest and greatest. It allows us actually to make CAT scans called cone beam CT. It allows us to do angiography, and we can bring in every other imaging tool that we need. So we can think of ourselves as the ultimate multimodality imagers. We use ultrasound always to get access. We never stick a blood vessel without using ultrasound. We use fluoroscopy to guide the catheters and wires. We use a CT scan, which we fuse, and at the end of the procedure, particularly with fenestrated grafts, we make a non-contrast cone beam CT so we can evaluate whether the stent spaces are adequately deployed. Increasingly, because we're particularly interested in imaging, we're interested in dynamic and functional techniques. And I think of this, for example, you would never really think about determining how you're going to fix a mitral valve using a CT scan alone. We use ultrasound. Sometimes we use dynamic CT, dynamic MR, because it's very mobile. And yet, in things like aortic dissections where there's mobile flaps, we've traditionally used static imaging, and we're very interested in taking some of these dynamic images and using them. Juan Perotti was a guy who first of all took a Palmas stent, put it on a piece of Dacron, and really allowed the development of this entire generation of stent grafts. These are some of the early ones, introduced in 1999. They've undergone a variety basically of different modifications and improvements since then. And I think of this now as like TAVR. We went through this many years ago where there was a lot of opposition to this. There's the acceptance of it, and now 80-90% of aneurysms primarily are treated with intervention. And these is just a list really of some of the strengths and the weaknesses of these different types of modality that we talked about. We've largely covered really this table. And the other one we use is intravascular ultrasound, which is always used for dissections to make sure that we're actually in the true lumen. When we look really in planning for stent grafts, because this is where the imaging part of this piece is extraordinarily important, every different company has a different method really of using, of measuring off the CAT scan. The CAT scan, he who owns the CAT scan owns the case. And again, we measure and plan the CAT scan of the endograft off the CAT scan, and increasingly we're fusing these on top of the patient. The key issues that are important are the infrarenal neck. Typically, there's a relatively normal piece of aorta below the renal arteries that allows us to seal a stent graft really up against the walls of that aorta, and that's very important. There are new modifications in these stent grafts where we have what are called shorter necks. The degree of angulation is important. The diameter is only used for planning to proceed with an operation. It's irrelevant during the procedure. What is important to us is the iliac arteries, much like TAVR. What are the diameter of this? We have stent grafts that now come down to about 14 French, so we can handle pretty diseased arteries, but tortuous, small, iliac arteries that are heavily calcified remain a problem. And the other thing that's a problem if you've got major branches like a patent inferior mesenteric artery coming off the middle. These are the sort of things that we want to know really off the imaging. So we talk about the neck, what's the length, what's the internal diameter, and what basically are the iliac arteries look like. Long, thin, parallel tubes, just like this ostrich species is what we really like. And making sure that they work in a multiplanar reconstruction plane, where you've got the sagittals, coronals, and the axials, optimizing the center line to make sure that we're actually measuring a true diameter is very important. What's also important on the right is demonstrated is what the quality of the neck looks like. For example, up here you're really looking at a lot of thrombus in the neck. Here we measure the inner wall to the inner wall. Some companies want outer wall to outer wall. You just kind of have to know that really in general before we can calculate this. And so this high resolution CAT scan, extraordinarily important. And again, as I just mentioned, stent graft companies have their own everyone's got a different way of actually measuring these, but it all is based upon getting an adequate good quality CT scan. And when you look at these devices, then we basically translate those measurements into the device itself and selecting a device from this kind of portfolio of menus that you get here. And these are the kind of things that we're looking at basically from this. We then translate this into optimizing that imaging at the time that we're actually doing this procedure and doing the implantation. iliacs really we've kind of talked about. If you get it wrong, this is what happens, is you end up basically with an iliac rupture. So I'm going to summarize there and basically say that the optimizing the imaging, particularly the CT scan, is extraordinarily important for us. The main way in which we select these patients to go ahead and do an intervention is 5 to 5.5 centimeters in the infrarenal aorta, 5.5 to 6 centimeters when we're talking about the descending thoracic aorta. Descending thoracic aorta a lot more straightforward in terms of being able to treat these patients than it is basically in the abdominal aorta. What you will see increasingly are branch grafts. These branch grafts are a way of producing an endovascular solution for all parts of the aorta, and you get it, and there's even an ascending trial going on at the moment with the stent graft. Thank you very much for your attention. Look forward to hearing some of your questions.
Thank you, Dr. Lumsden, for an excellent focused presentation on such a complex topic. Our next speaker is Dr. Charu Bavare. Dr. Bavare is a vascular surgeon here at Houston Methodist Hospital, and he's going to talk about something rather interesting, and that is about venous disease. It's often overlooked, but something is on everybody's mind. So everybody has veins. Dr. Bavare, please.
Hello, good afternoon, and welcome to the venous disease talk on the cardiology for the non-cardiologist meeting. I'm Charu Bavare, one of the vascular surgeons at the Methodist DeBakey Heart and Vascular Center. Looking forward to help you learn something from Everyone Has Veins. So instead of telling you how we do it, I think I should tell you why we do this. The talk can be divided into some introduction, a clinical presentation, anatomical considerations, and then we talk something about acute venous diseases and then chronic venous diseases. The clinical presentation of vein disease is broadly into three types: acute, which is very dramatic; chronic, which is very annoying; and then the sequelae of all that, which is really annoying. The acute part requires prompt diagnosis and treatment. The chronic part requires early symptom control, and the sequelae are really hard to control, but as much as we can, symptom control is most of the treatment. The symptoms are usually worse than the signs, so patients are found to have more complaints than what actually is seen under the skin, around the skin, or on the ultrasound. So just be empathetic to these patients. The acute and chronic DVT can be further classified as acute becomes DVT, which is restricted to the extremities, and then pulmonary embolism, which goes on to the lungs. Chronic DVT could be chronic venous conditions could be chronic DVT, varicose veins, venous ulcers, and then the last but not the least, post-thrombotic syndrome. So the acute DVT, which is essentially in the femoropopliteal vein, or the iliofemoral vein or iliocaval vein, all essentially become lower extremity DVT and central DVT, and they all can embolize and become the infamous pulmonary embolism. So from a non-life-threatening situation, we go to a life-threatening situation. Anatomical considerations for venous disease. At the top, just look at the box there, which says common internal and external iliac veins, which are above in the pelvis. And then below the inguinal ligament is the femoral vein, the common femoral vein, and the great saphenous vein. Remember, the femoral vein is a nomenclature which is designed to avoid confusion between superficial femoral vein DVT and femoral vein DVT. Essentially is the same because they're both deep veins. And so to take away the confusion, the word superficial has now been taken away, and it's only the femoral vein. So acute DVT is the way the clot forms is the clot forms in the common femoral vein, just at the inguinal ligament, and then it starts propagating. So it goes forward and it goes into the external iliac vein and stops where the big flow from the internal iliac vein comes through. And so whenever you have a clot in the common femoral vein, the Doppler never says iliofemoral DVT because they don't look at the iliac vein. They only stop at the groin or the inguinal ligament. So Unless you order an abdominal duplex, the iliac veins are not seen. So when you see clot in the common femoral vein on duplex ultrasound, remember that's the notable detail to have a red flag saying this is iliofemoral DVT. And why is that important? Because the Society for Vascular Surgery way back in 2012 had come with a consensus that if you have an iliofemoral DVT, then we should try and go after these thrombi so as to prevent post-thrombotic syndromes down the line. So the guidelines from the SVS, or the Society for Vascular Surgery, says that if you have a first episode of iliofemoral DVT, which is less than 14 days, and the patient has a low risk of bleeding with a good functional status and any absence of some unfortunate life-threatening malignancy, and they're expected to have a reasonable life expectancy, we should go after these thrombus. And there could be a variety of things to do. I'll come to that in the next slide. And the earliest thrombus removal is mandatory for people with limb-threatening ischemia due to iliofemoral DVT, which is called phlegmasia, which presents as a surgical emergency. And if the clot is confined to the femoral vein or the popliteal vein, then the consensus is just anticoagulation only. We do not need to go after these thrombi. The patients who can tolerate pharmacomechanical thrombolysis and anticoagulation should not meet criteria for an IVC filter. So no IVC filter is required. If patients have iliocaval DVT with extremely poor cardiac function or who have had recurrent DVT on anticoagulation, these are the patients where an IVC filter is recommended. There is a buffet of devices to go after these clots. There are some that pulse the clot, some that actually suck the clot, and then some that dissolve the clot. And it's a little beyond the scope of this talk, but just understand there's a huge buffet of devices that we have at our disposal, and we tailor them as to the condition of the patient. Here's a venogram shown. On the left side, slide A shows extensive amount of clot. Clot is the thing that is a defect, which is white amongst all the black contrast marks. And the slide B is where most of the clot is retrieved, but there's some clot in the common iliac vein. And in the slide C, most of that clot is taken off, and then probably some aggressive angioplasty has been done to maintain caliber of that vein. Similarly, in the upper extremity, this is a condition called Paget-Schroeder syndrome, where there is an effort-induced thrombosis of the subclavian and axillary venous system. Here, a wire and a catheter have been passed from the arm going into the central venous system. This patient probably has had some thrombolysis or percutaneous thrombectomy treatment done. And then the lower part of the slide shows an angiogram that shows a pretty significant pinch of the subclavian vein just where it goes over the first rib. And this is the classic sign, effort-induced thrombosis or Paget-Schroeder syndrome or thoracic outlet syndrome. But the job's not done. Usually we see something abnormal in about 30 to 60% of cases, which is the underlying abnormality, which is the cause of the DVT. Multiple X-ray angles may be needed. We may need intravascular ultrasound to actually look inside the vein and know exactly, this is a pretty sensitive modality to pick up any small caliber differences inside the vein. Usually failure to treat the underlying abnormality is what makes the procedure fail, and then patients come back with recurrent problems. So have a high index of suspicion because the eyes won't see what the mind does not know. So onward to pulmonary embolism, the treatment is usually tailored by the symptoms, and there are plenty of guidelines out there. The last one being the CHEST guidelines in 2016, and then the Pulmonary Embolism Response Team's consortium, or the PERT consortium, they came out with their statement about treatment strategies for PE. But broadly speaking, this is what we should know. Acute PE, which is not associated with hypotension, all they need is anticoagulation, and also provided that the heart function or right heart function is normal. If there is PE with hypotension with less than 90 millimeter of mercury pressure for about 15 minutes and or accompaniment of right heart failure or increasing troponin leak, then yes, these patients need intervention with systemic thrombolysis. Patients with a moderate bleeding risk or who have failed systemic thrombolysis, or there is in shock, which is not circulatory collapse, but just hypotension, they would meet criteria for being catheter-directed treatment with thrombolysis. Patients with severe pulmonary embolism who are in circulatory collapse and shock with cardiopulmonary resuscitation going on would actually meet criteria for an ECMO placement and then further treatment. Here, the buffet of devices is even larger. So we have amount of devices to suck the clot out, to fragment the clot, to dissolve the clot. Again, beyond the scope of this talk, but just understand we have plenty of options here too. When it comes to IVC filter, this is the most glamorous question people ask and the most confusing question people ask. So when are IVC filters really required is if you have an acute PE, which can be treated with anticoagulation, you do not need an IVC filter. So anticoagulation only. If you have an acute PE, where there is a contraindication for anticoagulation or there is a complication of anticoagulation, say you start the patient on anticoagulation and they have a bleeding gastric ulcer, or they have recent surgery and they cannot be given anticoagulation. So yes, then they are the patients who meet criteria for an IVC filter placement, no doubt about that. And the third one is a patient who's on anticoagulation and has a new clot, a new DVT and PE, for sure meet criteria for an IVC filter placement. Again, a lot of IVC filters available, but we have now uniformly have a statement saying that all IVC filters should be the temporary retrievable ones, which can be taken out. Because this is the question to do or not to do, is to take the filter out or not to take it out. And if you see IVC filter removal, the first thing that comes up is an attorney's website telling us to come and tell them about how bad you're feeling. But jokes apart, the IVC filter retrieval is something that the FDA has made a statement on, saying that they recommend removing the filter as soon as the protection from the PE is no longer needed. And that pretty much sums up the fact that yes, filters are there and filters are going to be removed. There are various tricks, and there's another buffet of solutions, but out of the scope of this talk. But essentially, we do all we can to pull the filter out as soon as possible. Typically, 1 year is the instructions for use limit to take the filter out safely. When you come to chronic venous diseases, it's a long list with a long frustration for the patient and the surgeon or the treating doctor. Chronic venous diseases could be varicose veins, venous ulcers, and post-thrombotic syndrome. We have chronic venous insufficiency. It is a reflux in the vein or obstruction. Combination of that is the worst, actually. And the second one would be an ambulatory venous hypertension, where the skin gets congested and even small pressure changes have a large impact. Unfortunately, not an easy fix to this. There is a CEAP classification where there is a clinical classification, the etiologic and anatomic and pathophysiological, essentially all the boxes and tabs are essentially how bad is the varicose veins or how bad is the degree of varicose veins. The anatomy is a little confusing, but broad brushstrokes saying there's a component of pelvic outflow, there is deep veins, superficial veins, and then the perforating veins. Venous ultrasound is done for varicose veins is not a conventional DVT study. It's called a radiated reflux study, where they look at the diameter of the vein and look at the time that the venous reflow refluxes back and goes forward. And traditionally, more than 500 milliseconds is significant here. The treatment is compression, 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 and sometimes more compression. Essentially, cannot take away the importance of compression here. So when you have reflux along with pelvic outflow obstruction, that's when treatments are done for improving the outflow to the leg by angioplasty or stenting or a combination of both. Really bad situations are long segment occlusions, which are not amenable to any angioplasty, and then they end up having surgical bypasses. It's a pretty morbid procedure to undergo and difficult procedure to do, and overall a high risk procedure for failure. So in summary, when you have an acute DVT, the diagnosis has to be done early and the referral has to be prompt to a treatment facility or a personnel. Have a low threshold for ordering venous duplex if you see swelling in the leg. The correct interpretation is important, so have it done by an accredited vascular lab. If possible, thrombolysis reduces long-term sequelae with post-thrombotic syndrome, and then anticoagulation alone prolongs valvular insufficiency. So we have to be aggressive in treating iliofemoral DVT. In summary, for chronic venous diseases, it's compression, 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 and maybe more compression. It's important to set the right expectations because these patients have a long, prolonged course with mostly not coming back to baseline in some situations. A thorough clinical exam and an ultrasound reflex study is the key. Identify the etiology and then treat accordingly. It could be just reflux, it could be just obstruction, or it could be a combination of reflux and obstruction. Again, I would say continue compression therapy, cannot mince that. And then close procedural follow-up is important so that we ensure compliance to compression, ensure compliance to wound care and skin care, and that would make the entire treatment process successful. I would say thank you for your attention. And this was a big blast through venous diseases, but for the time given, this is all I could cram. Hopefully we can have a detailed session some other time. Thank you for your attention. Bye-bye.
Thank you, Dr. Bawari. It must be good to be a vascular surgeon with the buffet of devices you carry. Our next speaker is Dr. John Cook. Dr. Cook, again, requires no introduction. He's the Joseph Walter and Carol Walter Luke Presidential Distinguished Chair in CV Disease Research here at Houston Methodist Hospital. And Dr. Cook is a fantastic vascular biologist by trade, and he will talk about PAD, peripheral arterial disease, hard to detect and treat. Dr. Cook.
Hi, I'm John Cook. I'm chair of the Department of Cardiovascular Sciences here at Houston Methodist, and I thank Dr. Bill Zoghbi for asking me to present some information to you about peripheral arterial disease, and thank you all for your attention, because this is really a very important topic. Peripheral arterial disease, or PAD, can be hard to detect, and it's important to treat it because it has such a morbidity and mortality associated with it. So what I'm going to talk about is why we need to make the diagnosis of peripheral arterial disease and how to treat it, and evidence-based for treatment principles. Peripheral arterial disease is quite prevalent. It affects at least 8 to 10 million Americans, probably more. It can affect the aortoiliac vessels, the superficial femoral artery, and the infrapopliteal vessels. It may affect those circulations in isolation or together. It's not a benign disease. Even if you look at normal subjects, here's a Kaplan-Meier curve, normal subjects in light blue. If you look at patients with severe symptomatic peripheral arterial disease, let's say someone who has severe difficulty walking, it's not a surprise that after 10 years only 25% of these individuals are still alive because they have coronary artery disease and carotid artery disease in association with their severe peripheral arterial disease. But what might surprise you is that even asymptomatic peripheral arterial disease has a poor prognosis with respect to age and gender matched people without peripheral arterial disease. So this is why it's very important to detect peripheral arterial disease in the office, because even when it's asymptomatic, it's deadly, because it's associated with other cardiovascular disorders. So patients with peripheral arterial disease typically have disease in other circulations, such as the carotid arteries, making them susceptible to stroke. They may have renal vascular disease. Someone with uncontrolled hypertension and peripheral arterial disease has renal artery stenosis unless proven otherwise. They may have aortic aneurysm disease. They get mesenteric ischemia. Of course, blue toes are not uncommon in peripheral arterial disease, typically these days after an endovascular procedure, but can occur spontaneously as well. And that augurs an aortic aneurysm or some embolic source from above. Of course, the most common cause of death in these individuals is coronary artery disease causing heart attack. So how do we make the diagnosis of peripheral arterial disease? Well, classically, as shown by this nice Frank Netter slide, it's in an individual who is walking. They develop pain with walking, typically in the calf. It's an aching pain, typically cramping or fatigue. It's made worse if you're carrying something, if you're walking upstairs. It can affect the thigh. and or the buttocks, which suggests more proximal disease in the aortoiliac location. This discomfort is typically relieved by standing still. Someone with peripheral arterial disease typically does not get pain when they're waiting in a queue for their groceries. For example, if they're getting pain just standing, think of something else like spinal stenosis. However, I should say that these classic symptoms only occur in a minority of patients with peripheral arterial disease. 10 to 30% of individuals with peripheral arterial disease, documented peripheral arterial disease, have the classic symptoms. That means a majority of patients are, quote, asymptomatic or have atypical symptoms. So it's something that we actually have to look for in the office. In the office, possibly the best way to make the diagnosis is with an ankle brachial index. You just need simple tools for this, blood pressure cuffs and a handheld Doppler. Now you have to use a Doppler, you can't use your stethoscope, because even in a normal adult, the leg arteries have a fairly fibrotic vascular wall. They can have some fibrosis, and that reduces their ability to make carot cough sounds. Remember, the carot cough sounds in the arm arteries are due to the vibration of the vessel wall. Well, the vessel walls are somewhat thickened in the leg arteries, and really in an adult don't vibrate that much. So you can't hear carot cough sounds really even in a normal individual. So you have to use a handheld Doppler. And it's pretty simple. After you get the blood pressure in the upper extremities, get the blood pressure down below at the posterior tibial artery, below the cuff up to suprasystolic pressures. You're listening over the posterior tibial artery, and then you gradually release the cuff until you can actually hear the flow of blood through the posterior tibial artery. You're looking right behind the medial malleolus for that posterior tibial artery. And then you go to the forefoot to look for the anterior tibial artery. You locate it, and then you blow up the blood pressure cuff until you can't hear the signal, and then you gradually relax it until you hear the signal again. That's the pressure at the ankle. And typically what you do is you take the higher of those two pressures and express it over the brachial pressure to create the ankle brachial index. So the ankle brachial index is the ankle systolic pressure over the brachial systolic pressure. It's that simple. The normal ankle brachial index is about 1 or a little bit over 1 because of systolic augmentation of the pulse waveform in the leg vessels. But once you get over 1.4, that's abnormally high, and that indicates calcification, which is common in diabetic patients. So frequently in diabetic patients, you can blow up that cuff as high as you want and not obliterate the flow of blood through the posterior tibial artery, because the vessel is like a pipe. It's become calcified. That's abnormal. Obviously, and that vessel can actually have intraluminal narrowing and yet have an artifactually elevated pressure. Now, below the level of 1 to 0.9, that's borderline. You'd be suspicious of peripheral arterial disease. That might be a person you want to put on a treadmill to see if they develop peripheral arterial disease. Best to send those folks to a vascular laboratory to get further documentation of that abnormality. But if the ankle brachial index is less than 0.9, you have a patient with peripheral arterial disease, whether they're symptomatic or not. In this case, you have to suspect disease in other circulations. Although they may be asymptomatic of their peripheral arterial disease because they're so sedentary they're not getting claudication with their minimal activity, they may very well have disease in the carotid, coronary, renal, mesenteric circulations, or an abdominal aortic aneurysm. So you see peripheral arterial disease, you have to look for disease in other circulations. Now, there's a lot that we can do to manage peripheral arterial disease. That's why we need to diagnose it. So there's quite a bit that can be done medically for these patients, and basically there's two things that you want to do as a physician. You want to reduce the risk for these patients of having a major adverse cardiovascular event, and you want to relieve the symptoms as much as you can with medical therapy. So with respect to reducing the risk, nutrition is a component. A Mediterranean diet is in my feeling is the best best diet for these individuals. There's good data from it dating back to the Diet Heart Lyon study about 15, 20 years ago, which was a randomized controlled trial. You want to modify the risk factors, treat the LDL cholesterol aggressively, treat the blood pressure, the other risk factors, elevated glucose aggressively, stop them from smoking tobacco, and you also want to put them on an antiplatelet or antithrombotic regimen. We're going to be talking about that in some detail. You also want to relieve their symptoms. The best way to relieve symptoms in a person with peripheral arterial disease is get them on a supervised exercise program. In some cases, they may also need intervention. Pharmacotherapy is not terribly good for peripheral arterial disease. Cilostazol, as I'll show you, does improve walking distance, but modestly by comparison to a good exercise program. So we've known for over 20 years that we can reduce morbidity and mortality in peripheral arterial disease by many of the same drugs that we use to reduce mortality in coronary artery disease. So these are data from the HOPE study that showed ACE inhibitors, angiotensin-converting enzyme inhibitor, in this case ramipril, could reduce risk in patients with peripheral arterial disease at least as much as patients without peripheral arterial disease. So the relative risk in the ramipril group was reduced by about 20% with treatment. And of course, statins reduce mortality in peripheral arterial disease. Many studies supporting this observation in the heart protection study, which showed that the odds ratio, again, for statins was over 20% improvement in major adverse cardiovascular events in those patients that received statin, whether or not they had peripheral arterial disease. Statins also increase the walking distance. Of course, they're not approved for that indication, but there's evidence from this study and others that lipid lowering can improve walking distance. The mechanism for that, not well known, may have something to do with improving endothelial function, improving the microcirculation in these patients. Here's the Fourier study of evolocumab, a PCSK9 inhibitor, also shown to reduce major adverse cardiovascular events in patients with peripheral arterial disease. And as you can see here, the absolute risk reduction was 3.5% from risk of 13% major adverse cardiovascular events to 9.5% in patients that received the PCSK9 inhibitor on top of a standard lipid-lowering background therapy. Now let's move on to antiplatelet agents for peripheral arterial disease. The evidence for aspirin in peripheral arterial disease, particularly asymptomatic peripheral arterial disease, is weak, but we do have antiplatelet agents that work. So the Capri study showed that clopidogrel was superior to aspirin in reducing major adverse cardiovascular events in patients with peripheral arterial disease. And in all patients, clopidogrel, the PAD, in patients with peripheral arterial disease, coronary disease, or carotid disease, the risk reduction was about 9% in those patients that got clopidogrel versus aspirin. But the patients with peripheral arterial disease demonstrated even greater benefit, over 20% reduction in major adverse cardiovascular events with clopidogrel. So clopidogrel is useful in peripheral arterial disease in reducing major adverse cardiovascular events. Ticagrelor also on a background of low-dose aspirin is useful in peripheral arterial disease. And here you see in the Pegasus study that there was with ticagrelor a absolute risk reduction rather, of 4.1% in patients with peripheral arterial disease that were treated with ticagrelor on a background therapy with aspirin. Here's going to antithrombotics now. There's growing evidence that antithrombotics can also reduce risk of major adverse cardiovascular events in peripheral arterial disease. And in this study, the comparison was between rivaroxaban with or without aspirin. And this is you're seeing the number of the risk factors, cardiovascular events here. And you can see that patients in aspirin on the red had this increase in risk over time of having a major adverse cardiovascular events, which was reduced in the green line by rivaroxaban, so rivaroxaban alone was better than aspirin. The combination of rivaroxaban plus aspirin, which is a lower line, was even better than rivaroxaban alone. So antithrombotics are useful in peripheral arterial disease. Beta-adrenergic blockers can be used in peripheral arterial disease to treat hypertension. There's no evidence that the beta-adrenergic blocker therapy worsens walking distance in patients with intermittent claudication. So in intermittent claudication, it's okay to use beta blockers. There's still some controversy as to whether or not they can be used in patients with severe peripheral arterial disease who have critical limb ischemia. But the average patient with intermittent claudication, one can use beta blockers. Now, that was about reducing risk of major adverse cardiovascular events in patients with peripheral arterial disease. What about treating symptoms? We really don't have much. Pentoxiflin is approved to treat peripheral arterial disease, but in my view, it's nearly worthless. Cilostazol does improve walking distance, and support for what I just said can be seen in this slide. What you're looking at here is a percentage change in maximum walking distance over time, over weeks of treatment, with pentoxiflin or placebo. There's really no difference between pentoxiflin, which is Trentol, or placebo. But cilostazol does improve walking distance about 30%. However, supervised exercise is much, much better. This is some early work from Bill Hyatt. He showed that you could get about 200% improvement in walking distance with a good supervised exercise program, and that's been supported by more modern studies. Here's a very interesting study, the RACE trial, which combined endovascular revascularization plus or minus supervised exercise, and this study showed that the combination of endovascular revascularization plus supervised exercise was better than supervised exercise alone. So the combination is very useful. So in conclusion, we need to reduce risk and relieve symptoms in patients with peripheral arterial disease. We want to modify their risk factors. We want to treat them with antiplatelet and/or antithrombotics. Pharmacotherapy with cilostazol to improve walking distance is reasonable. It's not as good as a supervised exercise program, which can improve walking distance almost 200%. And in some cases, these individuals will need intervention. And even if they do have the intervention, of course, they'll need modification of their risk factors and a supervised exercise program. Thank you all for your attention, and thanks again to Dr. Zoghbi for giving me this opportunity to speak to you.
Thank you, Dr. Cook, for a wonderful presentation on diagnosis and therapy, especially medication therapy for PAD. We actually have several questions. Let's see how much time we can get some of them answered. Dr. Lumsden, maybe you can help us answer this question. It's a very fundamental question, but I think it comes up all the time. When should we place vascular console for AAA? When it's already 5 centimeter or even earlier? When do you want to see those patients?
Well, of course, the answer to that is we're happy to see them anytime. At the bottom, I mean, I guess to be serious about it is that we are happy to see them at any time. We do follow all these patients with aneurysms, but you're not really going to intervene on them until it starts getting in that 4.5 to 5.5 centimeter range. So it really depends. It's relatively easy for us that sometimes these patients just want a second opinion so that we can kind of calm them down. A lot of the patients have a family history of aneurysms, and sometimes got a family history of members who they've lost because of ruptured aneurysm, and they require a lot of counseling. So I think we are more than happy to see them at any time. That usually involves counseling about when we think it's appropriate to intervene on them, and it's really just a matter of deciding who's going to be responsible for the follow-up, because that's the important thing, is you don't want to lose them for follow-up. If it's down in the 3 centimeter range, probably don't need to image them for at least a couple of years. If it's in that 4.5 centimeters, we're really imaging them on a yearly basis at that point.
Thank you. Dr. Bavari, your presentation has generated a lot of questions. Actually, one very pertinent question. What are the risk factors of DVT? Can you comment for COVID vaccine risks? Have you seen more of an increase in DVT patients?
Well, actually,
as far as COVID infection, we have seen an increase in thrombotic states where people get venous clot, but actually there have been people who have clots in their arteries as well, just de novo, which means without any prior history of clots. As far as the COVID vaccine, there were a few reports about, I think, the Johnson & Johnson vaccine, and then people having upper extremity DVT. But I still think that as far as vaccination is concerned, a few cases of upper extremity DVT versus hundreds and thousands of COVID infection prevention, I think it's still worth the risk. That's just my take on it. As far as DVT risk overall is concerned, I would say the top few are presence of a hypercoagulable state, having had DVT in the past that has actually about 5 to 6 times higher risk of new DVT, non-compliance to medication, contraceptive pills, oral contraceptive pills have been, but the newer generation actually are much better. I would top few are previous history of DVT, a known hypercoagulable state, and any recent history of major trauma, being bedridden. Those would be the top 3 in my list.
Thank you. Dr. Lumsden, what should we do? Well, I guess a physician, maybe he works in the ER or he or she works in the ER. What to do when the patient comes to the ER with a leaking aneurysm? What should they do first? Or what are the first steps do you recommend?
Well, the standard things are ABC resuscitation. It depends. There are patients who have acute onset abdominal pain and have a contained rupture. Obviously, we want to transfer these patients as rapidly as possible. The concept that has been developed basically is permissive hypotension, HYPO tension, in that we really don't want to resuscitate these patients aggressively. As long as they're awake and ventilating, and even if their blood pressure is 80, we don't basically pour blood into them at that point in time, because we know that these surges in pressure that can occur can exacerbate that. So we're quite happy for the patient to be tight and crossed, have a couple of large bore IVs, and then transfer them emergently. I mean, to that end, we actually started a thing called the Acute Aortic Treatment Center, in which we really, from our point of view, if you call our answering service, the answering service says, yes, we will transfer that patient, and that basically initiates the transfer. What's very important, which can delay things, is if the patient gets transferred without the CAT scan, because the CAT scan, as I mentioned, is critical in us deciding how we're going to go ahead and manage those patients. So making sure the imaging comes with the patient is fundamental.
Thank you. This is an interesting question. With patients who have mixed arterial and venous disease, Dr. Bavare, what is the protocol or your thoughts on compression of these patients?
I always ask to begin this answer, I would say, whenever I see a patient with chronic venous disease in the clinic, I make it a point to ask them for a history of claudication. I look at their feet, I feel for their pulses. If they have strong pedal pulses and have no history of symptoms suggestive of claudication, then I just give them compression therapy without a problem. If they have any history of claudication, any concern for PAD, I am a little resistant on giving them full 20 to 30 millimeter compression, sometimes not giving them compression at all, because that can exacerbate PAD. So if you have bad PAD, then no, compression would not be, at least unsupervised compression would not be the right thing to do.
Thank you. Maybe Dr. Lumsden can help us out. I know Dr. Cook is not online, but for PAD, is supervised exercise similar to cardiac rehab, or regular PT should suffice?
No, it's very like the cardiac rehab. Unsupervised exercise has not been shown to make any difference. And, I think you got to set patient expectations. What I always say to patients is, if you do an exercise program, what does that mean? We want to exercise until it hurts, and then we usually back off. But they're not going to go from walking 50 feet to running the marathon or walking a mile. I mean, these are, John quoted the percentages. And so for cilostazol, even though there's a 30% increase, if you're only walking 50 feet, now you can walk 80 feet. Sometimes these things are barely noticeable by the patient. So it's very important to have the discussion is what is it that they're looking for? And the second part of this, the fundamental discussion is we break lack of peripheral arterial disease into
limb-threatening ischemia. That's a group of patients that we're going to push to have some sort of revascularization. And claudication, where the patient's not going to lose their leg. Often they just need reassurance that I've got underlying blood vessel disease, but the majority of these patients are relatively benign course, and so we can't make the intervention worse than the underlying nature of the disease. And so explaining that to the patient is very important. You're only going to get major increases in their walking distance by some sort of intervention, whether it's endovascular or bypass.
Thank you. Maybe one last question. Dr. Bavari, I guess we live in the COVID era, and this question is almost a follow-up to what you just told us. Patients who have had DVT, what do you recommend about COVID vaccine?
Should I stir the conversation the wrong way? I don't know. I still feel that I'm a big proponent of vaccination because I feel the disease process is so incredibly dangerous for people who've not been protected. And if you've had DVT, I would say definitely talk to your medical provider first. Make sure your primary care physician is aware that you are going to receive the vaccine. Maybe you need a little more follow-up, and then keep an eye on the symptoms. If you have severe swelling of an extremity, then report sooner than later. I think we should get the vaccine, I would say. I know it's not a blanket statement, but I think you should get a vaccine. And if you've had DVT, your chance with or without the vaccine to get a new DVT is still high. And so I don't think the vaccination should exponentially sway you one way or the other.
And correct me if I'm wrong, but I don't think the CDC exclusion includes DVT. So maybe those patients are safe, at least to our knowledge, and they should get fully vaccinated. Correct, guys?
Correct.
Okay.
Yes, sir. Correct.
Well, thank you both very much. This concludes our session of PAD, and this also brings us to the end of this wonderful conference we have had all day. I hope you all have had fun. I had a blast today, learning so much from our distinguished speakers and varieties of topics. It's just mind-blowing. I want to thank our AV team. I want to thank our education team to put all of this together. We want you to keep on asking us more questions, and the ways you can do that is continue to do that. We will forward your questions if you have some unanswered ones to the respective presenters. But again, thank you very much. And with that, I want to thank my co-chair and my colleague, Dr. Bill Zoghbi, and I would like to invite him back for some closing remarks. Dr. Zoghbi.
Alpesh, thank you again also for spearheading this program, really. That was your brainchild. And it really is lovely to share the latest information in cardiovascular disease with you all. This meeting has become more global, if you will, with 35 countries now, watching. The nice thing also about it is with these offerings is that you can still have the material for the next 2 months or so for you to be able to peruse it at your time if you had to step out. Cannot thank enough all of our faculty, all our educational team at the DeBakey Education, and really all the people who are involved in this. So we want to thank you for your staying in touch with us. You can always follow us on the DeBakey Education YouTube channel and join more than 50,000 people who share in the knowledge development and innovation. So thank you again for joining us this Saturday.